गुड मॉर्निंग गिरीश जी।
मॉर्निंग सर, नमस्कार।
नमस्कार सर।
आ गए यहाँ से लाइव फीड आ रहा है वहां से हमारे पास क्या सर? ये
जी अभी लाइव कर रहे हैं सर, अभी लाइव कर रहे हैं।
वो जो हमारे जनरल
प्रोसेस प्रोसेस इज ऑन। हाँ जी।
हमारे जो वर्कशॉप लाइव फेंकने वाले हैं वो सब आ गए हैं भाई साहब?
हाँ जी हाँ जी।
एक हमारे मित्र हैं अजय जी।
अच्छा वो आएंगे, हाँ जी, जो वहां से फीड दे रहे हैं हमें।
फेंकेंगे जो, हाँ जी हाँ जी।
8 बजे की बात हुई थी उनसे कि
राइट
8 बजे वो आएंगे वहां से ना।
राइट, सो वी आर वेल इन
तो हम
टाइम।
लोग टेस्टिंग कर लेंगे एक बार। जी।
सर उड़ीसा, ये अच्छा आपका टेक्टिंग वाला आपका था, ओके। ये टाइमर आपने एक लैपटॉप लगाया होगा एक और, ओके।
हाँ ये आलोक हैं, आलोक टाइमर से हैं। एक टाइमर से हैं आलोक, और एक दूसरा है आलोक का। किससे है आलोक?
ये उड़ीसा
ईसा
टेक होगा।
ओडिशा टैक्स से।
अच्छा,
हाँ
उड़ीसा।
जी हाँ जी।
वंडरफुल वंडरफुल सर। शर्मा जी भी आ गए हमारे।
हाँ जी।
प्लेटफॉर्म भी सेट लग रहा है बढ़िया से, ऑल सेट।
ओके जी, थैंक यू।
बहुत ही बढ़िया चल रहा है सर, ग्रेट।
आप इतनी जल्दी कैसे आ गए सर आज?
अरे मेरे को थोड़ा ये नहीं, मैं जल्दी उठ जाता हूँ सर। बड़ा थोड़ा एक बार
अच्छा
देखने
अच्छा।
लगा क्या चल रहा है।
जी जी। नहीं सर, एवरीथिंग इज इन कंट्रोल।
बहुत परफेक्ट परफेक्ट। कल्चर एक ऑर्गेनाइजिंग कमेटी
जी
का टैब
जी।
भी बना दिया आपने, विच
हाँ
इज
जी
एक ऑर्गेनाइजिंग कमेटी का टैब भी बना दिया आपने, कमेटी ऑर्गेनाइजिंग कमेटी
हाँ
का,
जी हाँ जी।
विच इज ऑफ कोर्स ओपनिंग ए न्यू विंडो, विच इज फाइन। द लास्ट वन पे आई एम श्योर रिक्वायरमेंट आई थी क्लाइंट से, बट द टैब इज देयर, यस।
हम्म, हम लाइव होंगे शायद। लेट मी चेक।
लाइव हो गए, लाइव है हम।
नहीं सर,
लाइव है, लाइव
एवरीथिंग
है।
इज इन कंट्रोल
वी
होटल
लाइव
पे।
बहुत परफेक्ट कल्चर एक ऑर्गेनाइजिंग कमेटी का टैब भी बना दिया आपने,
हाँ वी आर लाइव नाउ।
एक ऑर्गेनाइजिंग कमेटी का टैब भी बना दिया आपने,
हाँ जी,
कमेटी
लाइव आ
ऑर्गेनाइजिंग,
गए। हाँ जी।
which is of course opening a new window, which is fine. The last one, I'm sure requirement I think client से, but the tab is there, yes.
हम लाइव होंगे शायद। लेट मी चेक।
लाइव हो गया, लाइव है हम।
नहीं सर,
लाइव है, लाइव
एवरीथिंग इज इन कंट्रोल
है।
होटल
लाइव बहुत
पे।
परफेक्ट कल्चर एक ऑर्गेनाइजिंग कमेटी का टैब भी बना दिया, which is fine. The last one, I'm sure requirement I think client से, but the tab is there, yes. Post Sheila Mitra.
लाइव है सर, हम लोग कैमरा ऑफ कर लेते हैं अभी।
करोड़ों लोग हमारे साथ में ये पैकेज की प्रैक्टिस
Check 1 2 2. Check 1 2.
हेलो मैडम।
हेलो भाई, सुनाई दे रहा है आपको?
नहीं, मैंने इसके साथ क्या
आ रही है आवाज आपको है ना?
नहीं आ रही। मैंने इसलिए आपको भी
नहीं आ रही आपकी आवाज? अनम्यूट है?
यस
इनको इनका साउंड चाहिए ना,
हाँ,
मतलब वहाँ
हाँ।
पर जो भी बोलेंगे डॉक्टर।
मैं नहीं समझ सकता।
हेलो 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 हेलो
हेलो
हेलो।
हेलो ऑडियो बोल।
सर आ रहा है?
अरे
बहुत कम कम आ रहा है आवाज।
मैंने कम किया है।
जो भी टेबल के पास
हाँ 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 हाँ। हेलो हेलो।
हाँ जी,
दिख गया?
हाँ जी, आवाज आ
आवाज आ रही है ना?
गई। यस आ
हाँ,
गई, आ गई आवाज आ
आवाज
गई।
आ रहा है। ओके।
वॉल्यूम बहुत कम है मानस।
Good morning. Please join everyone. Please unmute yourself and join.
Good morning, madam.
Please join.
Good morning. Good morning, madam.
Good morning.
Good morning, ma'am.
Good morning, Debasis. Please join. Unmute yourself. Show your face.
Madam, video is muted.
Please start your video. Yes. Everybody, please come join. Manas, come here.
Devasi, good morning.
Good morning, Kishore. Please stop your machine. Kishore, you are visible. Please stop your machine.
Sorry?
You are.
Good morning, sir. Pramod sir.
Kishore,
Good morning.
Good morning.
Please stop your machine. You are moving.
Okay, good morning all. I welcome all executive committee members, Vice President Dr. Kishan Mahapatra, President-elect Dr. Pramod Kumar Pallai, Honorary Secretary Dr. Debashish Pai, Joint Secretary Dr. Rajat Das, and all our EP members of the ISA Odisha Webcon 2021 and the organizing team Dr. Komalakanta Pradhan, Dr. Pradeep Kumar Das, Dr. Manoranjan Samantray, Dr. Sudhir Mahapatra, Dr. Dharmajivan Samantray, Dr. Sumita Mahanti, and our scientific team of the Odisha Webcon 2021, Dr. Nivedita Pani ma'am, Dr. Vasant Pradhan sir. Let us start and inaugurate this two-day workshop or conference by hosting the ISA flag. Let us join hand to host the ISA flag hosting. Manas, please come forward to flag hosting. Flag hosting. Now I request our Honorary Secretary, Dr. Debashish Pai, to conduct the meeting.
Good morning
Dr.
and
Debashish.
warm greetings to all the esteemed members of ISA Odisha State Branch and all the organizing committee team members who are present today in this auspicious occasion. ISA flag hosting is the first official function of this webcon. So I welcome you all. Now I request our Vice President Dr. Kishore Chandra Mahapatra to speak 2 minutes regarding this program as well as with the entire team. Dr. Kishore, please.
Good morning to all. Yes. May I audible, please?
Yes.
Yes. Good morning to all. So finally, our 49th Osasikon is going to held on 13th and 14th of March, and is a great effort done by ISA Odisha State Branch Executive and the scientific committee members, and a special thanks to Dr. Rekha Das and Dr. Nivedita Pani and all others to make it. They have done the all works to make it success. So this is a 2-day program definitely, and first day is the workshop and second day is the CME. So definitely it is helpful to all of us. I again congratulate all the participants, all the members, all the faculties. Thank you. Jai Hind.
Thank you, Kishore. Now I request our Vice President, our President-elect, Dr. Pramod Kumar Pallai, to congratulate on this event and express his wishes.
A very good morning and greetings to all and one. It gives me immense warmth and great pleasure to grace all of your presence in the interest of the ISA Odisha State Branch. It gives me tremendous contentment to welcome you all to the 49th ODISHA and first of its kind till date in the history of ODISHA. The uniqueness in this conference is that it is conducted on digital platform. While this 2-day academic extravaganza will help our budding anesthesiologists to expand their horizon of knowledge, it will also help the practicing anesthesiologists in adapting to newer technologies and come abreast newer developments in the field of anesthesia. The workshop and CME topics are chosen keeping this in mind. I hope all will enjoy this 2 days program. Thank you.
Thank you, Pramod sir. Now I request our treasurer, Dr. Rajat Das, to wish the gathering. Dr. Rajat, please.
Unmute.
Unmute, Rajat. Dr. Rajat, can you hear me?
Give him a phone call.
Give him a phone call.
Okay,
Give him a phone
okay.
call.
Now I request Rajat will speak at the end.
Good
Now
morning,
I-
everybody. I'm audible to everybody.
Yes, yes.
Yeah, yeah.
Go ahead.
This is a special occasion. This is also new to me. Let me congratulate our organizing chairperson, Professor Nivedita Pani, Professor Rekha Das, and all other EB members who have done an excellent job, and other event management staffs and Santi Hospital staffs. All are doing an excellent job to make it a success. The workshop where a difficulty airway and nerve block is a day-to-day practice of all of us. So we should learn and enjoy the workshop and utilize it in our day-to-day practice. Thank you, everybody. Thank you. Joy in. Long live ISA.
Thank you, Dr. Roger. Now I request our scientific committee head, Professor Nivedita Pani, to wish on this occasion. Professor Nivedita Pani, please.
A warm welcome to all esteemed faculties and delegates to ISA Odisha WebCon 2021 and 29th OSACICON. The theme of this conference is the grooming postgraduates to skilled anesthesiologists. It is a glorious moment to extend my warm wishes on behalf of the organizing committee. Before we begin the workshop, I would express my heartfelt gratitude to all of you who sincerely committed to this event to make it a success. This event would have been impossible without the support of each and everyone present here. Workshops and conferences are organized and conducted for the delegates to get insight and information that would remain effective in their gratitude to all present here for taking a keen part in this vital program. I ensure the workshop and the coming conference will be fruitful to everyone present here. Thank you, one and all. Jai Jagannath.
Thank you, Pani Madam. Now I request our scientific committee other members, Professor Basant Kumar Pradhan, to wish on this gracious occasion. Basant Pradhan, sir, please.
Basant bade link hai paruni bodhe.
He is not there.
I
I don't see him also.
Network problem tar boli phone re kotla.
Okay. Then I think sir will, if sir will be connected, we'll give a chance to sir.
We can request Dr. Dharmajivan and
Yeah.
Sudeep to speak a few
Yes,
words.
yes, other members, Dr. Dharmajivan, please. Unmute, unmute. Dharmajivan,
Am I audible, sir?
Yes.
Yes.
Am I audible,
Yes.
sir? Myself, Dr. Dharmajivan, I welcome all the staffs, all the delegates and faculties to this 49th OSACICON, which is organized by Odisha State ISA branch, and especially I am thankful to all the organizing teams, Rekha Madam, Nivedita Madam, and the event management team. Thank you all and join him. Let us join the program and make it success.
Thank you, Dharmajivan. I request Kamala, Dr. Kamala Pradhan, to wish on this occasion. Dr. Kamala. Dr. Kamala.
Sudeep is there.
Dr. Sudeep.
Sudeep,
Please.
Kamala is not visible, so Sudeep, you can tell.
Dr. Sudeep, please unmute. Dr. Sudeep, can you hear?
Yeah, sir.
Yes,
Good morning, sir.
please
Good morning,
express
sir
your-
and madam. Myself, Dr. Sudeep Mahapatra, and I congratulate everyone to organize this 49th OSACICON Odisha State. And I'm very happy that after so much COVID times and all those things, we are going to organize the extravaganza for postgraduate students. And also I congratulate the scientific committee. They have done a lot of work with magnification, everything with such a short time. Thank you. Jai Jagannath and long live ISA.
Thank you, Sudeep. Sumita ma'am, are you there? Sumita ma'am? Sumita ma'am, can you hear? Any other EP member available?
I don't think anybody else is there. Participants are showing 21.
Okay, then I think no other member is available right now. So I'll finish the program with my concluding remarks. Respected ISA President Professor Rekha Das, Vice President Dr. Kishore Chandra Mahapatra, President-elect Dr. Pramod Kumar Palai, Treasurer Dr. Rajas Das, all EP members and scientific committee members, Professor Nivedita Pani Madam and Professor Basant Kumar Pradhan sir. Good morning and warm greetings of the day. As I have already mentioned, ISA flag hosting is the first official function of this webcon. On this occasion, I congratulate all members and wish a grand success for the 49th ODISHA and annual state webcon 2021. This is a proud moment for all of us as well as for the entire state and all the members of the state to have this occasion live on a virtual platform for the first time in the state. We hope that such events will follow in subsequent years. I am grateful and thankful to all the members for their wholehearted and tireless effort for the success of this webcon. My special thanks for Rekha Madam and Nivedita Pani Madam, who has tried for last 3 months with other EP members to make this event a grand success. Long live ISA. Jai Hind, Jai Jagannath. I conclude the program, the flag hosting now, and over to the WhatsApp station. I request all the coordinators who are in the WhatsApp station to proceed with the event. I request Manas to switch over to the WhatsApp session. Thank you, Manas. Thank you all EP members.
I would like to speak a few words.
Madam, please.
So what we are going to do now is, we are now going to have the North Block session. So in this North Block session, we are going to have 5 resource people, and the course coordinator is none other than Dr. Ritesh Roy, who is well known for conducting these kind of programs. And they will be conducting various types of blocks. The one is above clavicle, one is below clavicle, one is strap block, one is for the lower limb they will conduct. And the resource person today are, in addition to Ritesh Roy, we are also having Dr. Siddhartha Mahanti, Dr. Neha Singh, Dr. Rajendra Sahu, and Dr. Gaurav Agarwal. And we have made all facilities so that they can go for a demonstration, both for the groups who are present here as well as those on the air. So initially they will demonstrate all the blocks on a person, and then it will go live also simultaneously so that everybody can watch them. And I would request all our EB members also to take the benefit and watch them and ask the delegates, the students, and all those who are known to them to keep themselves on the web so that they can watch the resource person teaching on the patients now for a period of almost 1 to 1.5 hours. And with this, I wish all success for this workshop. And I am extremely thankful to all my coordinators and all my EB members and all the scientific committee people, all the organizing team for coming together and working with this spirit. Actually, I am really touched because I never thought that conducting a conference on a web would be so difficult, and yet it will be so easy with the cooperation of everyone. Thank you all. Thank you once again from the bottom of my heart. And I wish everyone all success, and I seek your cooperation for the coming 2 days. Thank you again. And the blessings of the senior is also important. I would also seek the blessings of senior members like Nivedita Pani ma'am, Dr. Basant sir, and others present who we do not see, but they are constantly behind us and supporting us. Thank you. And now we take off to the workshop. Thank you all.
Thank you, ma'am. We conclude this program and we proceed with the WhatsApp. Manas, please proceed.
Thank you, Devas.
beautiful program.
Manas.
hello, 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 hello.
Good morning all. Now we come to the beginning of the workshop station. Okay. So good morning all. We now start over with the workshop station, and we are very happy to have with us a galaxy of resource people under the leadership of Dr. Ritesh Roy, who is our course coordinator, and with him he has a team: Dr. Rajendra Sahu, Dr. Neha Singh, Dr. Siddhartha Mahanti, Dr. Gaurav Agarwal, and he himself. And they would be bringing to you, Rajendra Singh will be starting off, he will be bringing to you above clavicle and brachial plexus block, interscalary and supraclavicular. And Neha will be teaching you below clavicle, brachial plexus block, costo-clavicular, lateral infraclavicular, and axillary. And the workstation 3 will be taken up by Siddhartha Mahanti, who will be teaching on the chest wall blocks, the PEG 1, PEG 2, the SAP block, the PEG intercostal block. And then Gaurav will be telling you about will be demonstrating the abdominal wall blocks, the TAP block, the subcostal, the TAP, RSV, and IIN and IHN. And Ritesh himself will be demonstrating you the lower limb blocks, the suprainguinal FICB block, the femoral, the LFSEN block, and the adductor canal blocks. And now I would request them, before starting off with this teaching the blocks, the landmarks, and how to go about it, to give a brief overview of the ultrasound machine and the procedure, that how they would be doing, and the anatomy of the canals, and the anatomy of the whole the system of how to do, and all the nerves and the arteries, and what precautions you would be taking, and how you'll be doing about in an individual. Now over to Ritesh, and he will start, and he will give you an overview of this nerve block session. Ritesh, please. I would request now Ritesh to speak a few words now. Ritesh, please give an overview of the whole thing.
Hello. Hello. Am I audible?
Yes, you are audible now. Yes.
Good morning, everyone. Rekha madam and the entire ISA Odisha team for giving us an opportunity to highlight what we are presently doing in Odisha. The thing is, in this part of state, the ultrasound guided nerve blocks was not practiced much, but thanks to many of the energetic, young, trained anesthetists coming back to our state and practicing the ultrasound blocks and giving a very good pain relief, post-operative pain relief to our patients, which was a distant dream a few years back. Now I have got a good team with me. I am Professor Dr. Ritesh Roy. I am head of the department, Care Hospital, Bhubaneswar. With me, I have got Dr. Rajendra Sahu, and we are lucky to have Rajendra Sahu in our state because he is trained in both chronic and acute pain, chronic pain from Toronto University and acute pain from USA. And we are very lucky, and the patients here are lucky in Odisha to have him to get a pain relief from the chronic pain. Then I have got Dr. Neha. He is an additional professor at AIIMS Bhubaneswar. Dr. Siddhartha Mahanti, he is a senior consultant in Apollo Hospital Bhubaneswar. And Dr. Gaurav Agarwal, who is with me. He's a consultant in Care Hospital Bhubaneswar. Now, before we go to the actual session, basically, I want to just give a brief overview of, because anything which you are doing, you should know what instrument you are handling. So I will just give a brief overview of the machine, of the probes which we are using, and then we can go to the 5 topics which is circulated in the brochure. So basically, this is the machine which I am using right now. No financial endorsement, and this is a Sonosite machine, Edge 2. So the 3 main buttons which we are concerned about, we scan in a 2D mode. So this is a 2D mode. Kindly utha. This is a 2D mode. If I press this in this mode, we do all our ultrasound blocks. Now, once a picture comes on the screen and you are confused whether it's an artery or a vein, you can just press the colored Doppler button, and it will give either a blue or a red. If the flow of ultrasound wave is towards the probe, it will be red. If it's away, it will be blue. So it's not that red is always artery and blue is always vein. If you are not sure whether it's a vein or an artery, you can just put the Doppler button and just slide on that particular area. And once you press again, if it's an artery, it will have an arterial waveform. If it's a vein, it will be a venous waveform. And there is one more button, that's a M mode, which is mainly used in lung ultrasound when they are doing their Doppler. In our practice, we use, when we do a lung ultrasound, to know about pneumothorax and everything. If I'm giving a supraclavicular block and I am in a doubt that the patient has developed a pneumothorax, then I will use a M mode to detect that, or just to get the center of the screen when we are doing a regional anesthesia block. So these are the 4 modes which we are concerned about. Now the rest buttons, which is important, is the depth button. Is the depth. By this you can either increase the depth or decrease the depth. The aim of the depth button, you want your target area to be in the center of the screen, because in the center of the screen, your ultrasound waves has got the best resolution, both axial and lateral resolution. So by this, we keep the target in the center of the screen by using the depth button. Now, at the most extreme end, we have got 3 buttons. That's a gain button. Because as the ultrasound wave goes inside the body, it becomes attenuated by the tissue which they are encountering. To compensate for that attenuation, the gain buttons are given. If I rotate this button, the overall screen will become either bright, or if I decrease, it will become dark. So it is just like a old-timer TV where you can increase the brightness and contrast of what you are seeing. If you want your near part, means the upper part of your screen, to be more brighter, you can increase this by using a near gain button. And if you want to decrease the brightness, you can just rotate it counterclockwise and the brightness decreases. And if you want the lower part, means the far end of the screen, to have a more brightness or less brightness, you can rotate this button. So these are the main buttons, and if I press this auto, then the automatically, by the computer processing of the ultrasound machine, it will give you a picture. If you are happy about it, it's well and good. Otherwise, you can use the 3 buttons to make your image much better. So these are the main buttons which we are concerned. These all hell lot of buttons, don't worry about these. If you know all these 4 or 5 buttons, that is more than enough for you to start using your ultrasound machine for regional anesthesia workshop. Now this is about the machine. And one more important thing, and one more thing is the examination. This is the button, examination button. If I press this examination button, you get the different options out here. Can you see? If I press this examination button, I get these options here. We use usually the nerve mode when you are doing a ultrasound guided regional anesthesia workshop, regional anesthesia block. Okay. So these are the buttons which we are important. Now coming to the probe. There are two types of probe which we are using in the ultrasound blocks. This is the linear probe. Okay. It has a frequency from 6 to 13 megahertz. And this is a curvilinear probe having a frequency of 2 to 5 megahertz. Now, 99% of the block, even in fact 90% of blocks which we give in ultrasound, by ultrasound, we use this linear probe. The linear probe has got a better resolution and it is very good for all superficial blocks. For deep blocks or when you are doing a central neuroaxial blocks, we use the curvilinear probe. Hardly in 10% of the things which you are using the curvilinear probe. Rest of the time we use the linear probe. So this is just a brief basic about your machine and about the probes which we will be using. In today's workshop, the maximum, all the blocks are almost superficial blocks. So all the blocks will be done by the linear probe. Now I will hand over to my first faculty, Dr. Rajendra Sahu. I have given an introduction about him. He will be speaking on above clavicle blocks. Over to you, Rajendra, please. Yes, yes, yes.
Good morning, all of you. At the outset, let me thank organizer Rekha ma'am for inviting us and Ritesh bhai for giving a wonderful introduction and talking about the basics of the block and specifically about the ultrasound machine, which is actually the step one approach before proceeding for any kind of block. So we are going to talk about the above clavicle blocks here in this session. And I'm covering the interscalene and the supraclavicular brachial plexus block. Basically, these two blocks are called, kind of bread and butter of majority of the anesthesia practice. You do these blocks day in and day out, not only to cover the surgical anesthesia for most of the upper limb fractures, plastic surgical cases, tendon repairs, but also to provide analgesia following complex surgeries. So basically, to start with, before we proceed to the ultrasound part, so coming to the brief anatomy of the brachial plexus, so you all know that is found by the ventral lemmas of the C5, C6, C7, C8, and T1. C5, 6, they come out and from the upper trunk, C7 continue as the middle trunk, and then C8 and T1 again from the lower trunk. And then they divide into divisions and subsequently cords and the peripheral nerves. So here in the interscalene area, the nerves as they come out of the neural foramen, they travel in between two muscles, that is anterior scalene and the middle scalene muscle. Okay, so and then they form these as they go down, they form the trunks. So the interscalene block is basically done at the level of the root and trunk. Okay, it's not exactly the roots. If you look at the roots, you have to go at the level of the neural foramen to be very precise that you did a root block. Okay, so it's basically root and before they become the trunk, so that is where you do this block. And then when you do the supraclavicular block, it is basically trunk and division. Okay, and then in infraclavicular, it is at the cords and the peripheral nerves at the axillary level. So this interscalene block is basically done for clavicle, shoulder, and the upper arm surgery, basically just above elbow, one can say, those kind of the surgical procedures or kind of acute pain relief also. So when you do this this block, so you deposit the local anesthetic with ultrasound guided. You do at the level of the cricoid cartilage, and you deposit the local anesthetic just between the two muscles around the cervical, around the brachial plexus, root, and trunk. So basically, before they form the trunk. So there are basically two approaches with ultrasound. One is called a periplexus, the other is called a intraplexus. So we'll show you with ultrasound how to identify different cervical nerve roots and how do they form the trunks also. So it is essential to identify each nerve and rootlets also, so in order to avoid any kind of intraneural injection and do some kind of neuropathy subsequently. So with this block, typically you with ultrasound we do around 10, 15 or maximum of 20 ml of local anesthetic. Previously with landmark or the PNS, the traditional it was around 30 or 40 ml as a high volume. And one of the drawbacks with such a high volume or even if 15, 20 ml is that invariably phrenic nerve getting blocked, because the phrenic nerve travels on the surface of the anterior scalene muscle. Okay. So phrenic nerve travels on the surface of the anterior scalene muscle, and when you do this block, the local anesthetic spreads over the anterior scalene and blocks the phrenic, kind of invariably gets blocked. It has kind of not a very significant impact in a healthy individual, but it may cause some kind of respiratory compromise in patient who had severe COPD, severe asthma, and respiratory compromise. So that needs to be kept in mind. And in the recent times, there has been a lot of talk in the literature about the phrenic sparing blocks while doing shoulder surgeries, or provide the kind of analgesia for those kind of surgeries, or maybe like surgical anesthesia also. So talk about that also. I think we'll talk about that when we kind of scan in this volunteer. So it's kind of a very simple block. One other thing, word of caution I would say here, while doing the block, make sure that with ultrasound, make sure that you put the color Doppler and identify the blood vessels. In that area, you may find quite a lot of normal and aberrant blood vessel transverse cervical, then dorsal scapular going through the element of the brachial plexus. That is one thing that needs to be kept in mind in order to avoid any hematoma there, accidental intravascular injection leading to a certain severe local anesthetic toxicity. The second most important thing is this area is again more prone for a neuropathy. Okay, so one has to be very judicious about the concentration of the local anesthetic that we are using. Use the least possible concentration to provide either anesthesia or analgesia. If you're doing anesthesia, also 0.375% of bupivacaine or even 0.5% of ropivacaine equivalent is very good. You don't have to go for 0.5 bupivacaine or 0.75% of ropivacaine to get a dense motor block. Motor block can be obtained with little lesser concentration. That is one thing. And then proximity of the needle tip and the nerve, that needs to be kept in mind. There is an approach, like many people do that also. They do something called intraplexus. They go between the C5 and C6 nerve root, and sometimes as you go down a little bit, the C6 kind of divides into two rootlets. Many people, they kind of confuse themselves that as a C6 and C7 go in between those two rootlets and do the injection, and of course in a good number of time patient may come back in a few weeks down the line with neuropathy in that neural distribution. So that is one thing that should be kept in mind. Okay, and so vascular puncture, this thing, phrenic block, and again make sure that you always see the needle tip before advancing. Okay, the neuraxis is not far away, so you may end up doing with a high volume and going further deep. You may end up injecting and getting epidural anesthesia or kind of spinal anesthesia. It has been documented, reported in the literature, and believe me, death has been reported also with interscalenic catheters, inadvertent local anesthetic going into the neuraxis and causing catastrophe. That is one thing. Then coming down, so this is all about the interscalene part, and then coming down to the supraclavicular area, kind of we fondly call it a spinal anesthesia of the upper limb, because it kind of all the elements of the brachial plexus, they're kind of conglomerated just above the first rib and posterolateral to the subclavian artery. So you just deposit the local anesthetic at the right place, right concentration, you're going to get a dense block in almost majority of the time, say kind of 95-99% of the time you're going to get a good surgical anesthesia, or even if you done appropriately, almost 100% you can say that. So one thing that in the supraclavicular area that we should keep in mind is to differentiate between the first rib and the pleura. Okay, so that is one thing. And the second thing is also the blood vessels. Okay, so pleura, one can see. Just come. Okay, so I think we can proceed with the demonstration part here. So as I'll be scanning here, the camera will be focused to the ultrasound screen to show you pointer and okay, so for most of the blocks like above clavicle blocks here, so this is the position, I think we can just give a little bit of head up position, or the pillow can be kept below the shoulder blade to make sure that this part is nicely exposed. So one thing I just want to highlight here, those who are going to appear for any kind of foreign examination, so make sure that you do a quick checklist. Make sure that what side block, wrong side surgery we have heard of, wrong side block is not uncommon. It has happened also. So make sure that you talk to the patient, look at the radiology consent part, make sure that you are going to do the block in the right patient and the right side. Okay, so it's the right side surgery. Make sure that that has been marked, or you make sure with the patient, all those kind of things, that you are going to do the appropriate block. And then always, as Ritesh bhai has told, high frequency linear probe here. So this is my orientation marker here, and that corresponds to the left of the screen. Okay, so that is the first thing. So here in the screen is a high frequency linear. I'm going to put it over this area, and my orientation marker is pointed towards patient's medial part. That means whatever you are going to see on the left is going to be medial, and on the right is going to be lateral. Okay. Okay, so let me start a systematic scan. So this is like a systematic scan. I'm starting from the midline. One can see all those tracheal rings over there. Okay, and then just on the top, so these are all muscles like strap muscles. This is the big thyroid gland. Okay, and possibly this is the esophagus. If you want to do a stellate ganglion, that is important, but it's not very much important for the regional block. As I move here, one can see this pulsatile structure over there. That is the carotid artery. One can put the color, and you can see a pulsation over there. Okay, so that is to show a blood vessel. Red is not always artery, blue is not as told, but blue away, red towards. Okay, and just taking it out, I have put a pressure. If I release the pressure, the IJV came up. Okay, one can see the IJV, carotid, and this is the sternocleidomastoid muscle in the top. Okay, just moving further little lateral to look for the element of the brachial plexus. One can see a small nerve root coming out there. As I go down, this is another nerve root, C5, C6, and then further going down. So this is kind of from a trunk. Okay, let me go back again to show you. So this is the first nerve root coming out of the foramen. Okay, going there. This is the second one, and okay. Okay, so let us start scanning here. Some people may find it difficult to scan at the interscalene area to identify the nerve roots. So let me give the other way. Some people do it at the supraclavicular area and then scan up. One can very nicely appreciate the subclavian artery. I'm here at the supraclavicular area. Can you show here also? Just show here. Just to show some of the in good number of times people may find it difficult. Okay, so this is I'm scanning at the supraclavicular area. Look in this kind of sagittal oblique axis here. Okay, so with this approach, increase the gain, reduce the depth a little bit. Okay, so here this is the first strip. So these two things. Okay, now two things, both look similar, hyperechoic. Here it is important to differentiate between the pleura and the first strip. Pleura is signing over here. One can see the signing, kind of bit of movement. So can long sliding sign, and there is an artifact. Okay, cometal artifact. And this is the first strip again, bright hyperechoic, and just below that it is the black, that is the acoustic shadow. So that is the first strip. So you differentiate between the pleura and the reeve by that. And if I go a little up, one can see the muscle getting attached to the pleura. Okay, so that is the middle scalene muscle over there. So this way you differentiate between the pleura and the first strip. So this is again to show that this is my medial and this is lateral. As we all know, the brachial plexus lies posterolateral to the subclavian artery. So this is the subclavian artery. Putting the color again, you see the artery there. Okay, on the top of the reef, this is the reef, pleura, and this is all element of brachial plexus, and this appears like a bunch of grapes appearance over there. Okay, while doing this part, always make sure that to find out if there is any aberrant blood vessel, you know, most commonly a dorsal scapular artery or anything like that. I don't see. Okay, there is one. There is one. Okay, here is one little deeper. So you find it quite often actually. So make sure that you make it a habit to put the color Doppler to make sure there is no blood vessel. This is essential because you should not be causing any needle trauma, any hematoma there, or accidental intravascular injection also. And sometimes the blood vessel goes through, like, you know, you'll find here, if this is brachial plexus, that goes like this, that divides the brachial plexus between this upper and middle trunk there. So if you deposit just on the top and feeling that you have blocked the whole of the plexus, you might be wrong, because it will be patchy block itself. Okay, from here, so this is the middle scalene and this is the anterior scalene. As I go up, these are two scalene muscles, one can see anterior and the middle scalene here, and again going up, anterior, middle scalene, and these are all kind of interscalene area. Okay, so here at this level, one can see the identify the roots. Okay, coming now, this is again medial, this is lateral. So here at interscalene area, one can see this is the subclavian artery. Okay, this is the carotid IJV, this is the subclavian artery and the vein. Okay, so here this is the posterior tubercle of the C7, you know, this to identify the posterior tubercle of the C7. This is to make sure that at C7 level there is no anterior tubercle. If you remember the anatomy, the transverse process of the cervical vertebrae divided into anterior and the posterior tubercle. Between these two tubercles, the cervical nerve root, they come out, and in that foramen transversarium, the vertebral artery runs here. One can see two hypoechoic appearance. They look similar. This is the artery and this is the nerve root, C7 nerve root. Let me put color again, artery, and that is the C7 nerve root coming out of the foramen. As I go up, now little up. So this is the C7 nerve root. See here, this is C7. This is the posterior anterior tubercle, posterior tubercle. The Chassagnus tubercle, we call that. Okay, the big pointed tubercle. Okay, so this is to identify the C6 nerve root. This is anterior tubercle, posterior tubercle, C6 nerve root. Going down, now that C6, see here, as it came up, it becomes single nerve root over here. As it slowly goes down, it becomes two rootlets. In the beginning of the literature, the in the journals also, they labeled this is C5, C6, C7. So that means if you do an intraplexus injection, go there, you'll essentially end up doing a intraneural injection. Okay, so now that C5 and C6, they have fused together to form the upper trunk. Okay, so this is the upper trunk there. Okay, so this I have covered how to identify this is the C7. Just to tell that this is the C7 nerve root, vertebral artery. Going up, this is the C6 nerve root. Okay, and then going further up, this is the C5 nerve root between two foramens. Okay, so for now, to do a interscalene block, this is what you do. Now you have seen at least C5, C6, and C7 coming out, and then your needle comes from lateral to medial, like from here, lateral to medial, and you just stop it at this level, just lateral to the roots. Okay, you do not go in between these roots. So that is basically called a intraplexus approach. Okay, both intraplexus and periplexus, they're equally effective, but with intraplexus the chances of neural injury is little higher. So your needle comes from here, from this side, from here, and it stops over here. Okay, it stops over here to do the block. You should not go into the plexus. Okay, so here again 15 to 20 ml of local anesthetic is good enough to provide surgical anesthesia for humerus, for clavicle, for upper arm or the upper humerus surgeries or shoulder joint surgeries. Okay, and then from here moving down to the supraclavicular area, as you saw here now, supraclavicular, a bunch of grapes. This is the first tube and the pleura. So the first, again, needle comes from medial to lateral like this. Yeah, sorry, lateral to medial. You first target the corner pocket. Corner pocket means that is the area where the C8 or T1 nerve root that is just buried below the subclavian artery. First target that one, deposit some 7 to 10 ml local anesthetic over here first, withdraw and go in between. Okay, so that area you deposit rest of the 10 ml of local anesthetic. Usually 20-25 ml of local anesthetic is just good enough to provide a good surgical anesthesia for the supraclavicular area. Make sure that you always see the pleura and the subclavian artery while doing this block, so that at least injury to the artery or even to the pleura is also avoided. That is the most important part of doing this block under ultrasound guidance. Okay, always put a collar Doppler. Let me see, is there any? Okay, see here, there is another blood vessel on the top. Okay, that is a blood vessel on the top of the brachial plexus, just above the omohyoid muscle. So when you do an out of plane approach like landmark, or with a PNS also, there's a possibility of causing a hematoma there also, that needs to be kept in mind. Okay, I think I'm done. Second, Ritesh bhai, where is he? Okay, so maybe like any questions we can take it later. Set the picture in picture as well. It was a battery.
Comfortable achandi tikke 10 minutes or maybe ato empty achide thoda aur is taraf aa jaye. So a very good morning to all of you, and first of all I would like to thank ISA Odisha, Rekha ma'am and Dr. Ritesh to give me this opportunity to be with you all today. And I'm going to cover below clavicle approaches of brachial plexus block, that includes costoclavicular, lateral infraclavicular and axillary block. So I would like to thank Dr. Rajendra for initial introduction, and knobology we have already discussed. So we'll discuss here about costoclavicular space. Once we are approaching costoclavicular, first of all, brachial plexus, when do you need costoclavicular, which approach, how to decide which approach you need to go? Well, few basic steps are that you need to take the consent from the patient, you need to check for the side, you need to check the initial checklist, which side to block, you need to attach standard monitor, and your backup machine and everything should be ready. If you are having a block room, that's very good to have. So for costoclavicular block, they are saying that all infraclavicular approaches are much better to keep the catheter when you are planning for long-term analgesia. Supraclavicular, the catheter dislodgement is more, but one fearful factor for below clavicle blocks is the incidence of pneumothorax. But with the costoclavicular and more towards the lateral infraclavicular, the incidence is much less. So we'll move on to the landmarks here. We are using linear probe here, and this is the marker. I'm keeping the marker towards lateral.
This is not, this machine has a problem. Actually, our location.
So should I proceed now?
You proceed.
Okay. So as we can see here, this is clavicle. Costoclavicular space lies just below the mid third of the clavicle. So for the scanning, we'll keep the probe here. Immediately over the clavicle, you will see the acoustic shadow. So this is my probe here. You focus there. So this is my probe here immediately over the clavicle. So now I'm sliding back here. And I'm freezing. This is the image we got. You can see the depth here. You can adjust the depth. The area of interest should be in the center. You need to adjust your area of interest in the center. I'm going to freeze this image and then I'll explain. As you can see here from above, this is pectoralis major muscle. This is subclavius. This is our area of interest. This is brachial plexus. And you can see it's clustered. All the cords are posterior, lateral, and medial cords all are lying lateral, just lateral to the axillary artery, and they are all clubbed together. So what's the advantage of keeping catheter here is that the less dose is needed for the analgesia purpose, covering all the cords, and the dislodgement, since because the groove is itself giving a safety measure, so the dislodgement of the catheter is less. So as you can see here, this is axillary artery. Yes, this is axillary artery. This above structure, this is thoracoacromion artery taking exit. I can show you the exit here. It is taking, see, this is emerging. I'm just toggling up the probe here. This thoracoacromion artery, this is axillary artery, and this is taking emergence from here. So this is not, we should avoid these structures for the risk of intravascular injection. Here again, if you will go further, you can see this is axillary vein, and this is cephalic vein draining into axillary vein. This is cephalic vein draining into axillary vein. We call it tadpole sign also. This is cephalic vein where it is draining into the axillary vein. So you need to, yes ma'am, I'll come to that. So why I'm showing you this, that we need to avoid these anatomy here. This is not, you need to avoid this thoracoacromion artery, and you need to avoid this intravascular injection. To avoid this intravascular injection, you need to avoid this area. This is our area of interest. I'm coming back here. You can see that tadpole sign, nicely tadpole sign is visible here. These are the veins draining into the axillary vein. Now I have freeze the screen. Now you can do it with dual guidance. There, posterior cord and lateral cord or medial cord response can come. So usually posterior and medial cord response are coming. That is well enough. Marker is not going there. Achha. Okay, then you can see this. Yes, thank you. So needle will come from there. This is the lateral side. Needle will come from here to this side. So this is quite safe to insert the needle here laterally, and little less volume also we can use. So from here we will move to, this is the costoclavicular block. From here we will move, that is lateral infraclavicular block. So again I'm showing you the marker. I'm keeping cephal. Previous costoclavicular I have kept the marker lateral. Here we will keep the marker again cephal, and we will palpate for the coracoid process. And just medial to that, we will put our probe. And you can see the structure. No, focus on this. First focus on this and then focus on that. You can see where I'm keeping my probe. This is coracoid process. I'm just keeping in the deltopectoral groove. Now you can see the image. Please. Yes. Now focus there. So now this is the image which we got once we keep the probe here. Sorry, okay. So now we can identify the landmark. This is pectoralis major. This is pectoralis minor. This is axillary artery. I'll show you how to differentiate between artery and vein by pressing and by putting the color Doppler. You can see the nice nerve bundles here. This is the second part of axillary artery, and they used to take cords, used to take their name by that. So this is the lateral cord, this is posterior cord, and this is medial cord. To confirm, you cannot confirm the identity exactly by the ultrasound. PNS is the sure shot method to confirm which is which cord. Anatomical variations are possible, so you cannot be always sure of that. Okay, here only lateral cord is there or posterior cord. Mostly 90-95% this is the sequence they are following. So as you can see, I'm pressing now that this is vein. Pulsatile structure is the artery. So this is lateral intraclavicular block. This block is also popularized for the sake of putting catheters. Now we'll move on further distal to the axillary block. So the position of the hand is same in all these approaches, be it costoclavicular, be it lateral intraclavicular or axillary. Abduction at shoulder 90 degree and at elbow. Patient should be comfortably lying and the head should be laterally a bit turned to the opposite side. So here we'll keep at the probe at the axilla. Marker again I'm keeping towards cephal. So as you can see here, what are the structure we are seeing now? This is humerus. Is it going? Yes, it is going. Okay, so this is humerus. This is tricep. This is the conjoint tendon. Our area of interest is again axillary artery. You can see the artery nicely pulsating. And these are the nerve bundles scattered around the artery. Okay, depth we can increase a bit. Yes. So I'm freezing the figure now. This will help you to understand the anatomy further. This is the tricep muscle here. So my needle will come again. Marker was cephal. So my needle from above. The ergonomics I'm maintaining. If you can see there that whenever you are standing, it should be all in the straight line. So my needle will come from this area to this area, and sometimes only single puncture will help you to deposit the local all around the artery. And sometimes you need to take redirect like double puncture or redirecting the needle. Axillary we used to combine axillary block with musculocutaneous also, because it used to take exit. Yes. So you can see here, this is coracobrachial. The musculocutaneous used to lie between coracobrachialis and bicep. This one. Yeah. This one. This one you can trace back. Yes, you can trace back here how it is moving. Musculocutaneous taking exit, and now it is lying there. So you can block it here, or you can block it further here even. This one is this one. Okay. So you can see here, you can trace back again further to proximal to distal or distal to proximal. Usually 10 to 15, 3 to 5 ml per nerve you can deposit. For the costoclavicular block, recently a dose finding study has been published in anesthesiology. They are telling that even 13 ml is enough. But the initial article where they have introduced costoclavicular block, they have given a range of at least 20 ml of local can be deposited. So both for costoclavicular, lateral intraclavicular, 15 to 20 ml of local, 0.25% for analgesia and 0.5% for surgical anesthesia is enough. Thank you so much.
So the next demonstration will be by Professor Dr. Siddharth. He will be teaching on chest wall blocks, like one, like two. And thank you for coming.
Okay. Good morning, everyone. This is Dr. Siddharth Mohanty. So far, we have whatever we have covered by Dr. Rajendra, Dr. Neha. It has been regarding nerve blocks. So this will be little different in the sense that we will be depositing the drugs between muscles into the facial planes. So two types of blocks, and due to the advent of ultrasound, it has become easier to give it in between muscles because you can visualize the muscles and accordingly you can do it. So if you can see the chest wall. Close. Zoom. Eta zoom. Zoom. Okay. So this is the chest wall. So basically, if you are talking about chest wall blocks, it can be divided into this medial area, anteromedial, anterolateral, and posterior. So what we are going to discuss mostly here is the anteromedial and the anterolateral ones. We are not going to discuss the posterior ones. So our idea is to give analgesia to this area, a hemithorax, maybe for a pacemaker insertion, a chemoport insertion, for a breast surgery. Patient has a rib fracture, which you need to give good analgesia so that they can breathe well. A video assisted thoracoscopic surgery or a thoracotomy in the sense, sternal, any abnormalities, any corrections. So there's a lot of variety of things. You need to discuss these things with your surgeon so that they have confidence in your abilities, and you should have direct interaction with them as to what you are going to do so that it doesn't interfere in their procedure. That is very important, and consent has to be taken to the patient with the patient. So if we divide this, the sensory distribution of this area is mostly by the intercostals. The intercostals are the ventral rami coming from behind, traveling between the innermost and the internal intercostal, and coming and supplying this area totally. But if you consider only the area which is just below the clavicle, it is by the supraclavicular nerves which are part of the cervical plexus. So this area, if you want to anesthetize, you need a cervical plexus block here. A superficial cervical plexus block will do. It will block only the supraclavicular nerves covering this area. For the rest area sensory innervation, it is mostly the intercostal nerves, which can be blocked not individually, but by giving or injection in between the muscle planes. I will be telling you which muscle planes. So what happens now, we need to cover this area. So what we can do, we start scanning. If you can see the structure here, the right of the picture, screen पर focus करो. Okay, so what we can see, the right of the screen now is cephalad, head end of the patient. So I can see the bony shadow in the, this is the clavicle, the subclavius here, and as I go down and tilt the probe medially, if I am in this position, I am not able to visualize the lips. If I tilt it medially, I will be able to visualize the ribs. So now you can see, again, the right of the screen is the cephalad, the head end of the patient. Here you can see this is the second rib, this one, and you can see the pleura sliding here. Okay, so I will just start tracing down follow the ribs. Here you can see this is the third rib here. And slowly there is a slip here. So 3 layers of muscles. Here this is the pectoralis major, the biggest muscle of the chest wall, covering the almost entire chest wall. And below it is the pectoralis minor muscle, which takes origin from the third, fourth, and fifth rib and travels up to the coracoid process. And then down below is the serratus anterior muscle, which takes origin almost near the mid clavicular line along the ribs from first to eighth rib. So by 8 digitations, it will be traveling back towards the scapula. So that is the anatomy. So here, if you can see, this will be 2 blocks at a time. So if you are giving only a pec 1 block, it is between the pectoralis major and the minor. And if you are giving a modified pec 2 block, it covers essentially both the blocks, like pec 2 original, that is between the pectoralis minor and the serratus, and pec 1 between the pectoralis major and the pectoralis minor. So your needle comes from the right of the screen, that is from cephalad, like this. You go through the pectoralis major, the pectoralis minor, cross the pectoralis minor, deposit the drug. It's better to keep your needle at such a point so that your target is more towards the ribs rather than towards the pleura. You visualize the needle tip, deposit 20 ml of drugs below the pectoralis minor, come out and deposit 10 ml of drugs below the pectoralis major, and you come out. So what we are going to cover by this, by depositing drugs below the pectoralis major, we are covering mainly the medial and the lateral pectoral nerves. The medial and lateral pectoral nerves are mostly the motor nerves. So what it doesn't have any cutaneous distribution. It is derived from the brachial plexus. But what happens when they are doing any surgery on the breast, any radical mastectomies, anything like that, there will be traction everywhere. There will be cauterization everywhere. So this myofascial pain will be taken care of by this pec 1 block. But if you are giving pec 2 block, it has got a wide coverage. The drug spreads and it will be covering the intercostal nerves, the nerve to the long thoracic nerve, the thoracodorsal nerve, and the intercostal brachial nerve, which is derived from the second intercostal nerve. So what happens next? Now we have, again we come back. What we can see now is the second rib. Go down. This is the third rib. Go further down. The fourth rib, and now the fifth rib. So here we have to change the angulation of the probe. Just show you. So at this area, I'll try to travel more towards the bed. That means more posteriorly. At the level of the nipple line, I have gone posteriorly. So you can see here clearly the ribs, the fifth rib. At the level of nipple line, I have just scanned. I'm almost at the mid-axillary level. So here you can see a muscle which is a serratus anterior muscle, and above it we have now got a cross section of the latissimus dorsi muscle. So here is our serratus plane block. So serratus plane block has been divided into 2 components here. if you are depositing the drug between the serratus and serratus, below the serratus, that is, it becomes the deep serratus anterior plane block. This will be good enough to give cover to all our intercostal nerves from T2 to T7 almost. So for rib fractures, maybe this will be a good block. But if you are doing something to give good post-op pain relief for a modified radical mastectomy, then you give it above the serratus, below the latissimus dorsi, which will cover your thoracodorsal nerve, the long thoracic, and all the intercostal nerves also. So this will give a wider coverage to the entire chest wall. And there is a thoracodorsal artery which we can visualize that will tell us about the exact plane. But here also you can, even if you cannot see the artery, you can see the plane because the serratus is the darkest muscle and the lighter one, yes, there is the thoracodorsal artery. And above it, the lighter one is the latissimus dorsi. So latissimus dorsi is finishing here and the serratus is starting just below that. So our landmark is to deposit the drug between these two planes. So that covers mostly our anterolateral chest wall. If we are, this is one area. What happens? Our intercostal nerves come like this. At the level of the serratus digitations, they give off a lateral cutaneous branch here, which divides into an anterior branch and the posterior branch, and the rest continues same below the internal intercostal and above the innermost intercostal, and they travel like this, and here they pierce and come up and become the anterior cutaneous nerves, which has got a medial branch and a lateral branch. So till here we have not done anything to cover this area so far. We have given a block which is covering the entire anterolateral chest wall, but for the anteromedial chest wall, again we'll do a scan here. Exactly parasternal area. Again, go up, start counting the ribs. This is the second rib. Go down, count the third rib. So below the, you can see that because pectoralis major is such a big muscle, it is also its origin is from the intercostal costochondral junctions. So you can see the big muscle, the pectoralis major muscle, and below it is the intercostals. So you can deposit the drug between the pectoralis major and the intercostal muscle. So specifically for the anterior cutaneous branches, you can deposit the drug below the pectoralis major but above the intercostal, keeping a landmark as a rib so that you don't go and injure the pleura. So you can see the sliding pleura below. So it's very important that you are seeing the ribs. So ribs are your end point. So you deposit the drugs. You can deposit the drugs below the intercostal also, but that can be a little unsafe. So it's safer to give it just below the pectoralis major. So thereby you are covering the almost the entire chest wall. Just show again this again. So we gave this area. Okay. So this area we covered with a superficial cervical plexus block by covering the 3 branches of the supraclavicular. This area we covered with a serratus anterior plane block or even a PEC 2 block, which is covering this area. For this area, the anteromedial area, we are covered by giving a block below the pectoralis major and above the intercostal nerves. So almost the entire area is covered but right now. So that's it. Thank you so much.
Thank you, Dr. Siddharth. Now we will be accepting our focus on the
Sorry.
abdominal block. Speak on it. We have with us Dr. Gaurav Agarwal. He's a consultant Department of Anesthesia and Care of proceeding for the live demonstration.
Very good morning. Thank you for giving me this opportunity to speak on this topic here on abdominal wall blocks. So we are shifting our focus down below on the trunk, and we'll be discussing about the blocks on the anterior abdominal wall. So these blocks which we are going to discuss is going to block the anterior abdominal wall. So this area this area of the abdominal wall we'll be focusing on. The blocks will be focusing on this area of the abdominal wall, right? So I will start with the basic classical TAP block. So TAP block is transversus abdominis plane block. Before starting, we'll discuss a little bit of anatomy. The abdominal wall contains mainly three muscles, that is the external oblique, internal oblique, and the transversus abdominis muscle. So the nerves travel in front of the QL, coming ventral rami of the intercostal nerves. The anterior rami travel anterior to the QL and into the TA plane. So the TA plane is between the internal oblique and the transversus abdominis muscle. So while we want to identify the plane, so this is also an interfascial block, intermuscular fascial plane block. So when we first focus on the classical TAP block, so the classical TAP block will block our T10 to T12, sometimes L1 also. So this is the point where we want to place our linear probe. That is a high frequency linear probe, because this is again a superficial intermuscular block. So this is the probe is placed in between at the midpoint in between the subcostal line and the iliac crest. Subcostal line and the iliac crest, midpoint between the subcostal line and the iliac crest. So this is where we want to place our linear probe for a classical TAP block. And then we go to the sonoanatomy and try to identify the planes, different planes. So I will show you from below above. So this is your peritoneal cavity. This is your peritoneum and the transversalis fascia, which is below the TA muscle. So the peritoneum and transversalis fascia cannot be distinguished easily in a sonoanatomy. So we can see a white structure. First white structure above the peritoneal cavity is the peritoneum and the TA transversalis fascia. Then coming to the transversus abdominis muscle, which is a thin black structure you can see here. This is the plane in between internal oblique, that is the biggest muscle you can see here, and the TA muscle. So this is the TA plane, transversus abdominis plane in between internal oblique and TA. The muscle above internal oblique is the external oblique muscle. Okay, so this is the structure we need to identify for a classical TAP block, and this is our target structure, the plane in between internal oblique and the TA muscle. So for a classical TAP block, we can cover the area supplied by T10 to T12 and sometimes L1 also. But the L1 divides earlier into iliohypogastric and ilioinguinal, which we will cover later. Okay, then going to the second block, which is a subcostal TAP block. So for a subcostal TAP block, we need to identify the subcostal margin, place our probe parallel and just below the subcostal plane. Okay, so to identify the sonoanatomy, we need to move from midline to the subcostal plane. Okay, this is how the probe will move. Now let's go to the sonoanatomy. So this is my midline. You can see this is the rectus muscle of the patient's right side, and this is the rectus muscle of the patient's left side. This is the linea alba. This is your peritoneal cavity. when I move laterally, you can see the rectus muscle. You can see the posterior rectus sheath and the peritoneum here. So, and when we go laterally, we can see the TA muscle coming up just below the rectus muscle. So in this area, the TA muscle is attached more medially as an also as an aponeurotic structure, and the muscle also below the rectus muscle. So this then again, if we go more laterally, we can identify the linea semilunaris, which is the lateral margin of the rectus muscle. So the linea semilunaris again is the aponeurotic structure at the lateral margin of rectus. Going further laterally, we can see all the three abdominal the muscles in external oblique, internal oblique, and the TA. Again, identifying from below, we can see the bowel movements, the peritoneal cavity, the peritoneum and the transversalis fascia fused, the TA muscle, the internal oblique, the external oblique. Again, the target area is in between the internal oblique and the TA muscle. So we need to identify this structure and take our needle, guide our needle from the pointer to the target area and slowly open the area in between internal oblique and TA. The target for this particular block is to make your drug percolate laterally in this particular plane. Okay, so we focus on the linea semilunaris, try to inject our drug in the plane, and we the target should be to inject the drug, that drug percolates laterally in this plane. For this block, in a subcostal tab block, we can block the structures from T7 to T9. So if we block if we want to give a total abdominal block, then we can use bilateral subcostal tab and a bilateral classical tab. We can block from T7 till T12, right? So the anterior abdominal wall can be blocked with this 4-quadrant block. Coming to the third block for the anterior abdominal wall is the rectus sheath block. So the rectus sheath block, again we come from the midline. From the midline, go laterally, identify the rectus muscle at the lateral margin. So this is a probe movement, and now let's go to the Suna anatomy. So this is my midline, this is linea alba. You can see the bowel movements here. So this is the peritoneal cavity. When I go laterally, I can see a muscle popping up. So this is the rectus muscle or the six-pack muscle. So you can see the posterior margin, that is, you can see two different lines. So one is peritoneum and one is the posterior rectus sheath. So when we go laterally, we identify the lateral margin of the rectus muscle. And at the lateral margin, we need to deposit our drug in between the rectus muscle and the posterior rectus sheath. So the anterior rectus sheath is attached to the intertendinous attachments. That is why it is not a continuous or a free structure, but the posterior rectus sheath is a free structure. So when we deposit our drug in the posterior rectus sheath, the drug can percolate to various levels. So that is why we identify the posterior rectus sheath and inject our drug in between the rectus muscle and the posterior rectus sheath for a rectus sheath block. So rectus sheath block or the rectus abdominis block, RAM, that is RAB, the rectus block can block the midline. So if we can inject a good amount of drug in this particular block, we can block the anterior abdominal wall in the midline. The midline incisions can be taken care of, the midline pain can be taken care of with this block. Now, why there are different blocks? The nerve travels from the ventral rami travels from anterior to the QL, goes into this plane, in this plane till the mid axillary line, and then gives off lateral cutaneous branches which pierces the internal oblique and goes to the superficial area, the skin. And when it comes to the midline, in this plane, it pierces the rectus at somewhere in midpoint and then gives the anterior cutaneous branches and blocks the supplies the midline, right? That is why there are so many blocks. And the subcostal nerves, that is the T7 to T9, they travel deep to the subcostal area, and that is why we need to block it separately. We cannot cover it in this classical tab block. Okay. Now coming to the L1, that is the ilioinguinal and iliohypogastric block, which is a very good block which we used to give for a field block for any kind of inguinal hernia surgeries or inguinal surgeries. And using ultrasound for that particular block is very helpful. So first we need to identify the ASIS. From the ASIS, we imagine an imaginary line to the umbilicus, place our probe parallel to this line, very close to the ASIS, because our ilioinguinal, iliohypogastric with the anatomy we know that are very close to the ASIS. So first we identify the ASIS. So yeah, you can see this bony structure. This is ASIS. Okay. Sorry. So this is the TA plane. If I go to the ASIS, this is ASIS. So now you can see the muscles. So this is the TA muscle. This is the internal oblique, aponeurotic external oblique, and you can see some small dotted structures with a pulsatile artery here. So these are your target area, ilioinguinal, iliohypogastric area. Okay. So this is your peritoneum, transversalis fascia, and this is your bowel. This is your peritoneal cavity. So this is where your target should be, and a small amount of 10 to 15 ml can block the ilioinguinal, iliohypogastric, right? So this artery is that is a deep circumference. So this is the artery. Okay. So this covers all of the anterior abdominal wall. For posterior, you need to block other nerves. So we'll for the paucity of time, we'll stop here. Thank you. Now hand over to Dr. Ritesh for lower limb blocks.
Thank you, Gaurav. That was a nice demonstration. Now we will be covering the last and final part of the demonstration series. That is anterior approaches of lower limb block. So I will be talking about suprainguinal fossa iliaca block. I will be talking about the femoral, the lateral femoral cutaneous, and the adductor canal block. Now, what is the suprainguinal? What is the fossa iliaca block? Fossa iliaca block is a block where the drug is deposited between the fossa iliaca and the iliacus muscle with the purpose. It's an interfacial block between the fossa iliaca and iliacus muscle with a hope that this drug percolates over the iliacus muscle and goes to block the components of the lumbar plexus, like the lateral femoral cutaneous, the femoral, and the obturator. Because the lumbar plexus block is a very advanced block, so to have that, if you don't know how to do a lumbar plexus block, at least you can give analgesia, post-operative analgesia to your hip surgery patients by using the fossa iliaca block. Initially, it was an infrainguinal fossa iliaca, but the coverage was only the femoral was blocked. So the purpose was not solved. So now in 2011, Hebart came with a suprainguinal approach where if you inject around 40 ml of 0.1% ropivacaine with epinephrine, what they found in 90% of cases, the lateral femoral cutaneous, the femoral was blocked, and in 75% of the patient, the obturator was blocked. And By suprainguinal approach, the articular branches which supplies the hip joint, the hip joint is supplied by the articular branches of your femoral obturator and accessory obturator. They supply the anterior capsule, and the pain is mainly from the anterior capsule. So if you are blocking these three nerves, your work is done. Now coming to the incision part, usually the incision in the hip surgery is in the lateral aspect of the thigh. So if you block the LFCN, it is a complete analgesia. So they came with a suprainguinal approach. Now what is a suprainguinal approach? Please, can you focus here? You feel the anterior superior iliac spine. My marker will be caudad. Okay, anything which is on the blue side, on the dot side is caudad. So this is your anterior superior. उठा ले भाई, हाथ में पकड़ ले, हाथ में पकड़ ले. So this is your anterior superior iliac spine. Palpate anterior superior iliac spine. Just medial to the anterior superior iliac spine, put your probe in a parasagittal orientation. As I put my probe in a parasagittal orientation, I see a muscle. I see a bony structure. इसको ठीक से दिखाना, थोड़ा घुमा ले, इसको कोई दिक्कत नहीं है. I see a bony structure. This is the ilium, okay? And just the muscle above it is the iliacus muscle. And as I go, the cephalad part, this part is the cephalad part. This is the internal oblique muscle. And you can see a pulsating artery. This is a deep circumflex iliac artery, which is a branch of femoral artery. And below a muscle is there. This is the sartorius. And the fossa which is overlying it. The fossa which is overlying the iliacus muscle is the fossa iliaca. Okay, this is the fossa iliaca. This deep circumflex iliac artery is a very good landmark for the needle placement. If you see this deep circumflex iliac artery always will remain above the fossa iliaca. So if you are seeing that your drug is surrounding the deep circumflex iliac artery, it means you are in a wrong plane. As you start injecting, this muscle, the iliacus muscle, should start getting separated from the fossa iliaca. And your needle tip should be always above the pelvic, ahead of the pelvic brim, because as you start injecting, this drug will go track down cephalad or cranially and block the lumbar plexus. This pelvic brim and the inguinal ligament, it pinches the spread of drug caudad. So almost maximum drug stays inside the pelvis and you get a very good blockade. So usually the dose which is being used is around 40 ml. Okay, 40 ml of 0.1% ropivacaine with epinephrine is the dose which is being used. Your needle will come from this side, from the pointer side, and you should always have a shallow trajectory of needle path. Your needle will come from this point. Your needle's tip will just cross the fossa iliaca, and as you start injecting, this iliacus muscle will unzip from your fossa iliaca, from the fossa iliaca. Okay, I think I am clear about it. So this is your suprainguinal fossa iliaca block by using the parasagittal approach. There is one more approach which you can use, is a transverse approach, but I will not teach that, because in that you have to go for a outplane needling, and if you are starting your nerve block, started doing your nerve block very recently, I will not advocate outplane needling. Okay. Now coming to the femoral nerve block. The femoral nerve block provides analgesia to your enteromedial skin of the thigh. Idhar dikha bhai. Enteromedial skin of the thigh. Okay. It gives supplies the osteotome is the femur. Okay. And enteromedial skin, your medial side of leg, almost up to the ankle, is the dermatomal supply. The quadriceps muscle is supplied by the femoral nerve, so that is a myotome, and the osteotome is your femur and the medial side of your tibia. So for a femoral nerve block, I will put my probe in the femoral crease. Okay, femoral crease or the inguinal crease. My pointer is lateral. My pointer is lateral. Okay, this is my pointer. So anything which is towards the blue side is lateral. As I put my probe in a transverse orientation in the femoral crease. Transverse means the God has given a very good anatomic landmark of a femoral crease. Just put your probe according to that. Don't put your probe like this. Then the whole stone anatomy gets distorted and you get confused. Just put your probe the way the femoral crease God has given. As you put your probe in the femoral crease, try to search for the pulsating artery. All nerves, maximum nerves runs along the artery. So always make it a point of first searching for the artery of that area. So I see a pulsating artery, which is the femoral artery. The pulsating artery, which is the femoral artery. And just medial to it is a collapsible vein. Can you see? This is a collapsible vein. This is a femoral vein. Right now, I am seeing two arteries. I am seeing a muscle, which is the iliacus muscle. This is your fossa iliaca. Okay. This is your fossa lata. Now, if I see two arteries, this is the profunda and this is the main femoral artery. It means I am lower down. I am seeing the femoral nerve out here. But if I block here, the femoral nerve has already divided into anterior and posterior division. So I will get an incomplete blockade. So I will move my probe slightly cephalad, maintaining the same orientation of the probe. Just slide my probe slightly cephalad. Okay. As I slide my probe slightly cephalad, right now there is a single artery. And just lateral to this artery, you can see a hyperechoic structure sitting on the superior lateral medial aspect of the iliopsoas muscle is the flat nerve, that is the femoral nerve. This is not the femoral nerve. Okay, this is the artifact, posterior acoustic enhancement. Don't get confused by this enhancement. This is not the femoral nerve. The nerve is always on the lateral side of the femoral artery, and the best landmark, if you are having a fatty patient, always search for the nerve in the superior medial quadrant of the iliopsoas muscle. This correlation is 100% always. So this flat nerve, can you appreciate the nerve? This flat nerve on the superior medial quadrant of the iliopsoas muscle is the femoral nerve. Your needle will come in plane from the marker side. Just cross the fossa iliaca and deposit the drug. Here, since the nerve is anisotropic, to make it a better visualization, tilt your probe cephalad or caudad in the cephalad or caudad orientation in any view where you are seeing a nerve very nicely, needle in that. Okay, so this is the femoral nerve block. Now coming to the lateral femoral cutaneous. Lateral femoral cutaneous is a very important nerve. You should always know, because maximum incision when in the thigh area is in the lateral aspect. So if you are not blocking the lateral femoral cutaneous, your analgesia will be incomplete. So to start scanning for the lateral femoral cutaneous, put your probe the way you do for a femoral. From here, right now I am seeing the femoral artery, the iliacus muscle, the femoral nerve. From here, I start sliding laterally. Dikha to 1 minute. I will show you the maneuver first, then I will show you the sonoanatomy. I have put my probe the way I should put for the femoral. From here, I will start sliding my probe laterally. Okay, I will maintaining the same orientation of the probe. Okay, this is the way your probe from medially, your probe maintaining the same orientation, it is moved laterally. Okay, now I will show what is the sonoanatomic change as I start sliding my probe. Now I am seeing the femoral artery, I am seeing the iliacus, I am seeing the femoral nerve. From here, I start sliding my probe laterally. Right now, it is the iliacus, the fossa iliaca. As I move more laterally, I see a new muscle. This is the sartorius. Okay, this is the iliacus, this is fossa iliaca, and this is sartorius. As I go more laterally, I see a fat-filled pocket in the lateral aspect of the sartorius. In the lateral aspect of the sartorius, this is the sartorius. In the lateral aspect of sartorius, there is a fat-filled space. Okay, this fat-filled space has a small nerve that is the lateral femoral cutaneous. Just lateral to the sartorius, there is a fat-filled space where you have the lateral femoral cutaneous. Okay, can you appreciate this nerve? And your needle will come just in plane and you deposit the drug in surrounding the nerve. There might be situation where you will not be able to appreciate the nerve because it's a small nerve. So just lateral to the sartorius, just pierce this fossa lata and deposit around 10 ml of drug. This is fossa lata. Okay, this is sartorius, this is fossa lata. Just cross the fossa lata and deposit around 10 ml of drug. The lateral femoral cutaneous will be taken care of. If you are not able to appreciate the nerve, if you are able to appreciate the nerve, it's well and good. So slide your probe from medial to lateral, just at the lateral border of the sartorius, search for a black fat-filled space, and there the lateral femoral cutaneous nerve lies. Can you appreciate this nerve? Okay, so this is the blockade of the lateral femoral cutaneous. Here the nerve has already divided, it has divided into two branches. Okay, so this is, if you block the femoral, the lateral femoral cutaneous, your enteromedial aspect and the lateral aspect of the thigh is covered. Now coming to the adductor canal block. So what is the adductor canal? Adductor canal is a intermuscular canal having a boundary superiorly by the sartorius, posterior-medially by the adductor longus in the initial part and adductor magnus in the later part, and anterolaterally you have the vastus medialis. So why adductor canal block? So basically adductor canal, the concept of adductor canal came because if you give a femoral nerve block, your patient might not be mobile in the post-operative period because they will have a quadriceps palsy. So adductor canal concept came so that your patient has a early ambulation following a TKR, right? Because what nerves we block in the adductor canal? The contents of the adductor canal, the superficial, this is the adductor canal. Probe दिखाओ एक मिनट. I have put my probe in the medial aspect of the mid thigh, okay, in a transverse orientation. As I put my probe in a medial thigh in a transverse orientation, I see a pulsating artery. This artery is the superficial femoral artery. Sitting on the top of superficial femoral artery is the sartorius. In the anterolateral aspect, a big muscle is vastus medialis, and in the posterior medial aspect is the adductor longus. And this white membrane is the vasoadductor membrane. Now, what are the contents of the adductor canal? The superficial femoral artery is 100% confirmed content. The saphenous nerve, you will not be able to appreciate the saphenous nerve. It sits in the just lateral to the superficial femoral artery. The saphenous nerve is a confirmed content, but the nerve to vastus medialis is always not a confirmed content. Right now, if you can see, this is the nerve to vastus medialis. This is the saphenous nerve. Can you see it is in a different aponeurotic compartment? So for a TKR, if you want to give a adductor canal block, the blockade of the nerve to vastus medialis is required. If you block only the saphenous and you don't block the nerve to vastus medialis, your analgesia will be incomplete. Okay, so what we do, which is a modified 4-in-1 block for TKR, we put a probe in the mid thigh. From here, we slide a probe, maintaining that same orientation slightly down. It's almost at the distal adductor canal level. Right now, I am in a distal level of the adductor canal. I am not in the mid thigh. Okay, so what we do, we bring our needle from here. We stimulate usually the nerve to vastus medialis lies in this quadrant. We stimulate the nerve to vastus medialis. We inject around 5 ml of drug. Then the same needle goes just perivascular and we deposit around 20 ml of drug. This drug, along with the superficial femoral artery, will percolate through the adductor hiatus and will block the popliteal plexus and will go up, and because at this level the saphenous nerve is also there. So adductor canal block is a block to block the nerve to vastus medialis, the saphenous nerve, which was originally described. We have modified it lower down using the nerve PNS to get the blockade of nerve to vastus medialis, the saphenous nerve, and taking advantage of the artery, because this artery will go along with the adductor hiatus and becomes the popliteal artery. So anything which you deposit in that plane will track down along with the artery in the popliteal plexus. So your all areas which is relevant for analgesia of TKR is covered in a single injection. This is modified 4-in-1 block. I think we are done, ma'am. Yeah, we will move for hands-on. Thanks to all the delegates who were present online, and hope we gave some information which you can go back home and go back to your hospital and start giving good post-operative pain relief to your patients. So I, on behalf of my entire team, thank you all for your presence. Thank you very much. Bye-bye. Take care. Tateved Das. Yes, ma'am, please.
After this, now I would request the delegates which are present here, they form into 5 groups. So we can have the, yes. Machines are, there are 5 in number. So I would request to form into 5 groups so that you move from one station to another. And our resource doctors, they will teach you. They'll have you can have an hands-on opportunity on the patients. And since you have come all the way, and this is the advantage of having it hybrid, you people will have a hands-on, and they are all expert in their field. Some will teach you above clavicle, supraclavicular, some below axilla, some abdominal blocks, lower limb blocks. So they form into 5 groups, okay? And that is how we will go. And yes, and those who are on the online, we have our local coordinators, Dr. Rajat Das and Dr. Pragyan. They will take the questions and they will go to the respective people, to the doctors, and have the delegates' clarifications over the at the table. Okay, that is how we would go about. So now I think we can form groups and yes, sure. We'll take some time to form the groups and all. That will take little time, so you can have a time. And we'll have the patients also on the table.
Okay,
we have ample time.
Okay. We will go to station 2. 3 will go to station 3. 4 will go to 4 and 5 will go to 5. And after every 20 minutes, we will rotate. Okay. And right now, you are going to do hands-on therapy.
कही चलो 1 2 करके जन जन लाइन करी 1 2 3 हां 5 गले 5 गले तब 6 7 असो 8 9 10 11 12 13 14 15 है के 11 12 13 14 15 अगो कर 5 5 कर दो 16 17 18 19 19 18 19 20 तो जाने 3 जन मात्र रहिला 21 22 23 ओके तो 5टा ग्रुप टिके रही जाओ 5 5 है के बसी जाय था वी विल हैव एवरीथिंग गिव अस 5 मिनट्स टाइम
test. Hello, hello, check. Check. 1, 2, 3, check. Hello. Hello, am I audible? Yeah, am I audible? Yeah, the question from Mr. Dr. Saurav Das regarding which block to be given and what is the amount of drug for an indirect inguinal hernia. So basically, the anterior abdominal wall blocks is a part of multimodal analgesia for post-operative analgesia. Multimodal analgesia plan for a post-operative analgesia for the abdominal surgeries and the indications for the abdominal wall block. So indirect inguinal hernia, again, if you are going for an open hernia surgery or a then I would go for a ilioinguinal iliohypogastric block along with my anesthesia and a multimodal plan. Right? I hope Dr. Saurav is here and listening to the answer. And if I'm going for a laparoscopic surgery, I would go for a QL block. So QL block is more advanced in a posterior block along with my multimodal analgesia plan. If I want to go solely for a block, I would go for a GA plus RA technique. I would go for a ilioinguinal iliohypogastric block along with GA and have the analgesia plan with a multimodal. Right? If Dr. Saurav has any other clarity, please type. Welcome. Questions are also welcome. Please type in the chat box so that we can answer your queries while this session is going on over here. Thank you.
to appreciate the nerve because it's a small nerve. This is your fossa lata. Okay, this is your fossa lata. Just bring your needle, pierce the fossa lata, and deposit 10 ml. The drug will track in that plane, and your LFCN will be blocked.
So what is that elliptical structure inside which
This is a fat filled space. It is fat filled space.
No muscles.
No muscles. This is your sartorius.
Sartorius.
This is the tensor fossa lata. Okay? Okay? Done? Okay? And this is your iliopsoas. Okay? Done? So this is LFCN. Now coming to adductor. Now coming to adductor canal block. Put your orientation will always be in a transverse orientation. Your probe should be lateral. So now increase the depth. Put your probe in the anteromedial quadrant and try to find the superficial femoral artery. Dika, this is the superficial femoral artery. Okay, this is the superficial femoral artery. Above this is your sartorius. Okay, this is medial. So posteromedial, you have the adductor longus. Anterolaterally, you have the vastus medialis. Okay, so the classical adductor which is taut, which is given in mid thigh, your needle will come from this side. You just pierce this vasoadductor membrane and deposit around 20 ml of drug at this point, just lateral to the artery. So your saphenous nerve will be blocked, but nerve to vastus medialis can be plus minus. It's not mandatory because many of the times the nerve to vastus medialis is never a part of adductor canal. So you can go slightly down. Okay, come here. You will not block at the mid thigh. I will go at the distal adductor level. Okay, my needle will come from this side. I will deposit around 15 ml of drug here, and while coming out, I will use a PNS and stimulate the nerve to vastus medialis and deposit around 5 ml. Okay.
It is a nerve to vastus medialis.
No. Here is saphenous. This is saphenous. Nerve to vastus medialis usually lies here. Okay. Okay. Now coming to the suprainguinal fossa iliaca. Dharo.
Actually, participants are 100, but in reality they are more because in Barampur all are sitting at one.
Are great.
They are all sitting together and watching on one.
Great. So feel the anterior superior iliac spine. Okay. Now this is anterior superior iliac spine. Feel it. Just put your probe. Dharo. This is anterior superior iliac spine. Just medial to it. Put your probe. Okay. And as you put, go slightly medially. This is anterior superior iliac spine. Medial to it, put your probe. Okay. As you put medial to it, this is your ilium. Okay. The muscle sitting above the ilium is your iliacus. Okay. This is your internal oblique. Okay. This is your deep circumflex iliac artery, right? Pulsating. This is your sartorius. Okay. So now this is your fossa iliaca. Okay. This is your fossa iliaca. Now suprainguinal means you have to give above the inguinal ligament. Okay. So your needle tip should be always above the level of the pelvic brim. Okay. And this deep circumflex iliac artery is a very good landmark. Suppose if you have started injecting and the drug surrounds the deep circumflex iliac artery, it means you are superficial. You are superficial. You are not below the fossa iliaca. So as you inject, as you cross the fossa iliaca, as you start injecting, the muscle and the fossa iliaca will unzip. Okay, it will unzip. And the drug will track cephalad into the pelvic brim. So always put your needle tip should always be above this pelvic brim. Okay? Okay? Your needle will come from this side. Okay? You should have a very shallow trajectory. Remain very shallow. Your needle will come from this side. Put your needle. हाँ? कहाँ इंगुनल लिगामेंट बिलो है भैया यहाँ से पंक्चर हो रहा है ना needle will come like this na obviously you will go like this yes please yes there is one more infrainguinal previously it was infrainguinal why infrainguinal when this is infrainguinal this is the way infrainguinal is done. Okay, this is your iliacus, this is your fossa iliaca. But the infrainguinal approach blocks only the femoral. Suprainguinal approach will block your femoral, the lateral femoral cutaneous, and your obturator. So right now, nobody practices infrainguinal. Infrainguinal fossa iliaca is same as giving a femoral nerve block. Okay. So always give suprainguinal fossa iliaca block. Don't give lumbar plexus block. Not required. This is a very good for postoperative hip surgery. Very good. Okay, and it's quite superficial and a very safe block. Okay. Okay. Chalo.
What about paying block?
Peng. टाइम होगा पेंग सब पढ़ा दो कभी लीनियर चाहिए एक मिनट ट्राई करता हूँ कभी लीनियर चाहिए अरे सुनील कभी लीनियर देना जस्ट चाहिए टाइम 20 minutes ये देखते हैं ना look here this is peng what we do what is peng peng pericapsular nerve block where they block the articular branches of obturator femoral accessory obturator right so for peng block put your probe in medial aspect just like the way you have done for the femoral okay and try to appreciate the femoral head. This is the femoral head. Okay, this round is the femoral head. From here, maintaining the same orientation, slide your probe up and see the change in the bony architecture. Right now, you are seeing a rounded bony architecture. Right? As I go up, the bony architecture changes. Okay, and this is your anterior superior iliac spine. This is your iliopubic eminence. Anterior inferior. Okay. This is your pubic tubercle and this is the femoral artery. Your needle will come from this side. You deposit. This is the psoas tendon. Okay. This is the psoas tendon. This is the iliopsoas muscle. This is your psoas tendon. Your needle will come from this side. Just between the iliopsoas tendon and iliopubic eminence, deposit around. Initially it was 20 ml, right now we are giving 12 ml. Okay? Concentration we give 0.2% ropivacaine, 12 ml, 0.2% ropivacaine, along with LFCN. You have to block LFCN, otherwise the incision site will not be covered. Okay? So PENG plus LFCN is our publication in RFPN. Okay? It's our publication. Okay? So this is the way you do your PENG block. Just see for the femoral head. Okay. Just maintaining the same orientation. Slide your probe up. See the change in the bony architecture. The bony, yes, just cranially. Maintaining the nothing, no tilting cranial. Yes, please. Now, dekho. Put it like this. Put it like this. Okay, this is rounded is your femoral head. No tilting, nothing. Just parallel. Slide up. Just slide up. कुछ नहीं करना, just slide out.
The architecture will itself change.
Yes. And I will suggest, मैं linear से कर दिया, use a curvy linear. The advantage of curvy linear is you get a broad picture. So in one frame you see everything. यहाँ पे क्या है? I will slide like this to see the pubic symphysis. Slide like this to see the anterior inferior leg spine. But in that you see everything in one. Okay? So this is paying block. ठीक है? अतो ओके, कोई स्कैन करेगा तो करो फटाफट, नहीं तो स्टेशन चेंज करूंगा. ओके, छोड़ दे. सुनील फोटो उड़ा है? तेरा तो नौकरी गया आज मैं फोन करता हूँ हितेश को. रुक. You are tilting the probe. What I told, put it like this and just move up. Yeah. Feel the anterior superior leg spine, just medial to it. Just medial to it. Yes. Go slightly up. Probe, move your probe cephalad. This is your anterior deep circumflex iliac artery. Okay? This is deep circumflex iliac artery. This is your which muscle? Internal oblique. This is internal oblique. This is iliacus. Come, probe, slide your probe down. This is sartorius. This is your basically pinch. This is almost the inguinal ligament. Okay? This is your inguinal ligament. This is your fossa iliaca. Okay? Yeah, here. Your needle tip should be here. Your needle will come here from below. From below. Just cross the fossa iliaca, and as you inject, it will open up. And the drug will trickle down. Okay? Suprainguinal facility. Change. Chalo. Okay, chalo. Next batch. Rotate. Rajendra, rotation time हो गया नहीं तो तते हेलीकॉप्टर देवा पड़ेगा मते पारादीप जीवा पर. चिंता
me tell you a little bit about the anatomy. The ventral rami of the intercostal nerves T7 to T12, they come anterior to the QL. After coming out from the spinal root level, they come anterior to QL, then pierce the transversalis fascia TA, and then go in between the TA muscle and the internal oblique. Right. So that is the TA plane, transversus abdominis plane. For this block, we will only block the lateral cutaneous branches and the anterior branches in these abdominal wall blocks. So this is a dermatomal wall dermatomal block only, cutaneous block only. It will not cover any viscera. So this is only for multimodal analgesia for a post-operative analgesia plan. Part of multimodal analgesia. Okay. So for the first block, blocking T10 to T12, sometimes L1 is the classical tab block. In a classical tab block, what we do, we identify the subcostal margin first, iliac crest second. In between these two margins, at the mid axillary line, we put our probe. Okay. Now you can see the sono anatomy. Okay. Pointer. You can see the sono anatomy. You can easily see three muscular structures there. Can you appreciate the three muscular structures? Can someone point? No. So that is the common mistake. You count from below. First, the lower black structure. The lower black structure. This is the peritoneal cavity. This is a peritoneal cavity. The first muscle here is the TA. This white structure is the peritoneum and the transversalis fascia. So we cannot differentiate the peritoneum and transversalis fascia in a sono anatomy. So we are seeing it as a single structure, right? Then there is the TA.
Is there any gap?
Yes, there is a gap. If we do a better sono anatomy machine or a high advanced machine, then probably we can see two different structures. Probably this is a differentiating something. This is something differentiating. Okay. Yeah, you can see two structures here now. Can you see here two structures? So this is peritoneum and this is transversalis fascia. This is TA plane. Above the TA, there is the internal oblique. So this big muscle is your internal oblique. You can see a white line here. So that is the fascia in between external oblique and internal oblique. So this is your external oblique, and this whole is your subcutaneous area, the skin and the subcutaneous area. Okay. So our target structure is in between internal oblique and the TA. So this is the TA plane. Okay.
This sheet should not be pierced.
Which sheath?
Red light.
No, you have to pierce this sheath. You have to inject your drug
beyond this plane.
Yes, beyond this plane. In between the TA and the internal oblique, this will open up as a different structure altogether. Both the muscles will be separated once you inject your drug. Okay, you get your needle from medial to lateral, inject your drug, and try to dissipate your drug laterally. So in a subcostal and a classical tap plane, we would like to inject our drug which dissipates laterally. So this is your classical tap. It will block T10 to T12, sometimes L1 also. Coming to subcostal tap. So a subcostal tap, we identify the subcostal margin. Okay, we identify the subcostal margin, and we need to get our probe parallel to the subcostal margin, just below the subcostal margin. Okay, so I'll come from medially. First, identify linea alba. So this is your linea alba. This is your peritoneal cavity. You can see some bowel movements here. This is your linea alba. This is your rectus muscle. So my pointer is medially. So when I go laterally, I can see the rectus muscle. This is your posterior rectus sheath. You can see the TA coming here. So the in the upper abdomen, the TA sometimes come below the rectus muscle also. Okay, before making a aponeurosis and giving its aponeurosis for the posterior rectus sheath, it comes quite medial below the rectus. When I go laterally, I can see a aponeurotic structure here that is called linea semilunaris. The lateral border of rectus forms an aponeurosis. There is an aponeurosis which is called linea semilunaris. So this is the structure we need to identify, and then go slightly laterally to identify all the three abdominal structures, the abdominal wall muscles. So this is your TA, this is your IO, this is your EO. You get your needle from medial to lateral in this plane again, the TA plane, and try to dissipate your drug laterally. So aapko do pop, you go and cross two pops. First pop is between IO and U and IO. Second is IO and TA.
Direction of needle is
Medial to lateral. Medial to lateral. You try to dissipate or deposit your drug laterally. While injecting, you should see that the drug is dissipating laterally. Okay.
At which angle we should pierce the skin?
You have to pierce in plane.
Right angle to the skin.
No, in plane. You just go 1 centimeter lateral to your probe. 1 centimeter medial to your probe, from medial to lateral in plane. While visualizing your needle tip, enter the plane. Yeah, it's from medial to lateral. This is also from medial to lateral.
This
Okay.
is also from medial to lateral.
Yeah. So, हो गया subcostal tap. Now coming to the rectus. The rectus sheath or the rectus plane block. The rectus sheath block or the rectus plane block.
T8 to T6.
This no T7 to T9. This is T10 to T12. Sometimes L1 also. L1 we can block separately also. I will show you that also. So this is rectus for midline block. Okay. So how is the rectus? You must be remembering the anatomy. This is midline. This is again linea alba. This is rectus of the right side, and this is rectus of the left side. Now again coming to midline, linea alba, peritoneal cavity. Coming to the lateral side, this is your rectus muscle, the anterior rectus sheath, and this is your posterior rectus sheath. Okay. Again the TA is coming here, also slight medially. And the aponeurosis, again the lateral aponeurosis of the rectus muscle or the abdominal lateral, that is linea semilunaris. Again, if you go slightly medially from here, this is the lateral margin of the rectus. You need to deposit your drug here in between the posterior rectus sheath and the rectus muscle. So the posterior rectus sheath is a continuous structure from the xiphy to the arcuate line, right? So below the arcuate line or the linea semicircularis, the posterior rectus sheath is absent, and it is the rectus muscle is lying directly on the peritoneum. Okay. So if we inject our drug in the posterior rectus sheath, we can get a deposit in the whole of the rectus, posterior rectus area. If we give a good copious amount of 20 ml, then a good deposit in the posterior rectus area you can get. Why we do not deposit in the anterior rectus sheath is because the anterior rectus sheath is fused with the intertendons. So the rectus has intertendons in between, जो 6-pack 8-pack बनता है. So intertendons does not allow the drug to percolate in multiple levels.
इसका ऊपर देना पड़ेगा ना.
You give in between the muscle and the posterior rectus sheath. So if you can appreciate a black structure here in between the muscle and the posterior rectus sheath. So that is the space. So this is the space. Some black space is opening up. If we tilt our muscle or tilt our probe and slide our probe. Okay. So you will also get a pop here when piercing, first pop in the anterior and second pop when we are piercing the epimysium of the muscle. So you will get 2 pops here also, and you can inject your drug. This will block only the midline, the anterior cutaneous branches. Only the midline, anterior cutaneous branches. So for a laparotomy, if you are not giving the epidural and you want a superficial block, you can use this as a part of multimodal anesthesia, right? Coming to the ilioinguinal iliohypogastric. So first identify the ASIS, palpate from the iliac crest or from the pubic tubercle laterally along the inguinal ligament. So ASIS, identify ASIS, draw imaginary line ASIS and umbilicus. Put your probe parallel to this imaginary line. So this is the bony structure, that is ASIS. This is the bony structure, that is ASIS, a tall hill. Just medial to that. Can you identify the 3 muscles? So for depth come करेंगे. Can you see a pulsating artery here? This is your TA, this is your IO and aponeurotic external oblique. So this pulsating artery is accompanied with the 2 nerves, that is ilioinguinal and iliohypogastric. Okay, so the L1 divides earlier anterior to the QL into ilioinguinal iliohypogastric, pierces the transversalis fascia, TA comes in between this plane, okay, and provides the cutaneous branches to the inguinal canal and groin.
Above the artery or below the artery?
No, you come to the same plane, the internal oblique and TA plane. So beside the artery, not above, not below, beside the artery. Be careful not to puncture this artery. There is a big artery here, another artery, that is a deep circumflex iliac artery here. So you have to be careful not to reach this area or not to misidentify this artery as the superficial artery, right? Done. So you can scan. Any questions from online? We can take. Hello. Yeah, Dr. Snehashi is asking a question to tell blind technique about tab block. So for blind technique about tab block, you need to identify the anatomical structures. So the anatomical structures, you need to identify the anatomical structures. First is the subcostal margin. So we don't call it a blind technique. We call it a landmark guided technique. So this is a landmark. So this is a landmark subcostal margin. and the iliac crest. You identify these two structures and the midpoint of the structure at mid axillary line. Okay. So there is a petit triangle forming over there with these margins and the latissimus dorsi. There will be a triangle that is a safe triangle. You need to read the anatomy of it, and you use that. Take your needle perpendicular to the skin. You use two pops. First pop will pierce the EO and IO. Second pop will pierce the IO, the fascia in between the IO and TA. So that is your TA plane, and you can inject the drug with small aliquots, with aspirations and aliquots, small aliquots. And you can, after giving some amount of drug, you can disconnect your needle with the block needle and see some backflow in the needle to confirm your plane. Okay. Next question, please. Next question, Manas. Yeah. So you're seeing the three structures. You can identify the three structures. Lower is peritoneal cavity. The first thin muscle is your TA. The big muscle is your IO. Yeah, peritoneum and the transversalis fascia. And then there is TA muscle, then TA plane, IO and EO plane, and EO. Okay. So this is your target plane. Okay. This is your peritoneum and transversalis fascia. This is your peritoneal cavity. So we usually cannot differentiate, but here we were able to differentiate at one point. I'll try to show you.
ml, above pectoralis minor 10 ml. So your entire anterior chest wall is covered by this. So what happens below the pectoralis major and the minor rise the medial and the lateral pectoral nerves. So you need 10 ml of drug to block those. Those nerves don't have any cutaneous distribution, but the pain of retraction, the pain of stretching while they are operating on that area, that myofascial pain will be covered by the blockage of the PEC1. If you need to have cutaneous distribution blocked, then you have to give a PEC2 block. PEC2 is below this, and modified PEC2 is a combination of both. So PEC2 is below the pectoralis minor. That will give coverage to all your intercostal muscles from T2 to T6, the intercostal brachial nerve. And if you are depositing extra amount of drug, it can travel back above the serratus and cover also the long thoracic and furthermore the thoracodorsal. But for those two nerves, you have to really cover and go and give a serratus anterior plane block. So we are still chasing the ribs, the second rib, the third rib, the fourth rib, and needle approach is cephalad to caudate from above down. At the nipple line level, we rotate the probe so that we are trying to go towards the bed where the patient is lying. So as we go down, you can see the serratus muscle progressively from the T1 to T2, sorry, the first rib to the 8th rib, and the digitations are traveling back towards the scapula. So progressively the serratus is getting thicker and thicker, and as we are at the mid axillary line, level, you can see the thick serratus here. This is the rib, and above it the latissimus dorsi is ending. You can see this is the edge of the latissimus dorsi where we have taken a cross section. So if you are depositing your drug between the serratus anterior and the latissimus dorsi in this plane, that becomes the superficial sap block. In these two planes lie your long thoracic, the thoracodorsal nerves, and you are going, if extra amount of drug that you are giving around 30 ml, it will go and cover also your intercostal nerves. This will help in preventing the myofascial pain of retraction for your MRM, the thoracic surgeries, whatever you're doing. But purely if you want to give pain relief for a rib fracture patient, you deposit the drug below the serratus, 15 to 20 ml of drugs, which goes and spreads and blocks the intercostal nerves, which is necessary for your rib fractures, pain relief of rib fractures. But for surgeries, you have to give it superficial to the serratus anterior and in between the serratus and the latissimus dorsi. So this covers most everything almost. Okay. Okay. Intercostal nerve block actually A3 हमारा total टा cover ହେଇଯିବ. यदि हमें serratus और latissimus dorsi भितर 30 ml, it will going to cover the entire area. यदि purely it's only for the rib fractures which are maybe the for breast surgeries, this intercostal block means you have to give multiple intercostal blocks. So instead of giving multiple intercostal blocks, you give multiple intercostal. It will be multiple injections, but the main problem is if you are giving this for approaching the lower border of the upper rib, and then it becomes little difficult. So here, so this is our target area. So then giving multiple injections, vessel marker difficult because very small vessel, even thoracodorsal artery we are not able to visualize so properly. We may have just see the thoracodorsal artery somewhere around here to demarcate the plane between the latissimus dorsi and the serratus, somewhere around here. But instead of giving intercostal block at different levels, if we deposit the drug below the serratus anterior, that is going to cover most of the intercostal nerves. But for surgeries, it is better that it is deposited between the serratus and the latissimus dorsi. 30 ml of drug, 0.3 rupee vacuum. Okay. Again. Again. Left hand अपन धरते हैं आगे ये हाथरा रेस्ट कर दें तो बॉडी पे अपन मूवमेंट इजियर होगा डेप्थ टिक इंक्रीज करछे this is the clavicle. Subclavius muscle, pectoralis major muscle, then comes your second rib. Again, acoustic shadow, pleura sliding, second rib. This is the third rib. At the third rib area, we can see like this. We are getting two muscles actually. The big muscle is the pectoralis major, small muscle is the thinner muscle is the pectoralis minor. So with a single injection directed towards the rib, if the end point is this, we are coming from this direction. Below pectoralis minor 20 ml, above pectoralis minor is 10 ml. So this will cover your medial and lateral pectoral nerves. This will cover even medial and lateral pectoral, along with it the intercostobrachial. Even it will go and give good coverage to T2 to T, I mean the first, second to sixth intercostal nerves. Okay. Fourth rib, fifth rib asila. Fifth rib jagah hame rotate कर लो. Then we see that this serratus anterior is progressively getting thicker and thicker. Depth टिके कमे दो हमें depth एते दरकार नहीं. So serratus anterior getting thicker and thicker as we approach the mid axillary line. As we approach the mid axillary line, above the serratus, the muscle which comes and ends is the latissimus dorsi, the edge of the latissimus dorsi here. And as we go more towards the bed, this latissimus dorsi is going to become thicker. Okay, so our target is to deposit drug between the latissimus dorsi and the serratus here, coming from above downwards. Above it से अपन position से change हिजो मने आगे needle probe machine एंती रहला आगे एटा पूरा superficially advance करिके हमें just serratus ऊपर एठी deposit करिबा. Once the drug starts opening up this area, you can slowly progress with your needle while you are going on scanning like this, so that it goes on expanding. It goes like this. Progressively दे दीजिए पूरा टा. तो drug spread better होगा. Midline सेटा अपन करो ये टा. Just pectoralis major तोड़े and below the third rib depth कमे दवा. Just below the this will first rib तो देखा जी बनी clavicle देखा जी वो clavicle देखा जी वो second rib असला it is second rib असला almost third rib area. It actually costochondral junction assi irani. Okay, so here we can deposit drug. It is third rib asla. Below the pectoralis major, if you deposit, the anterocutaneous nerve should be blocked. So distribution from this side, distribution from here, and for along with that you add the superficial cervical plexus to cover chest wall surgery पूरा cover कर रहा हूँ, पूरा तीनटा का cover. Superficial cervical plexus ପାଇଁ देखिए मुंडो rotate करंतु. So check for the carotid. Carotid. So this is right of the patient. Okay, carotid IJV both we are saying. We start scanning. We go up, up, and up. At one level, the carotid is divided. Okay? Carotid is divided now. So from there, you can see the sternocleidomastoid here. We go to the lateral edge of the sternocleidomastoid. So sternocleidomastoid is finishing here, almost. So we deposit the drug just below the sternocleidomastoid. 10 ml will be sufficient to block the superficial cervical plexus. Okay. Next. I'm have a live now. A baby. Sorry, more over.
Huh?
हाँ बिल्कुल 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 आहो कर दें तापर जो
Thank you for your question, but we have kept this workshop dedicated only to the anterior part of the lower limb. In future, we will be organizing workshop where the posterior part of the lower limb will also be covered. So at that time, we can clear your doubts by practicing you hands-on. Thank you.
ओके हम स्टार्ट करें अच्छा सुनंदु मु एटा केंदी हाथ नै आसीबी हला आपण काम करिवे अच्छा सुन मु कोई this is a over clavicle block. Basically we'll cover two things, interscalene and the supraclavicular. That is mostly for the upper limb surgery. Interscalene is for the clavicle, for the shoulder joint, upper humerus or mid of the humerus, and just below that the base is the supraclavicular approach. Okay, so to start with, always a high frequency linear probe. You can see there's a nerve sitting over here. Okay, the resolution is there. Okay, this is in the resolution mode, and this is MB on. Specifically in this machine, MB is multi-beam. That is a compound imaging setting. You know, as you read the physiology of the ultrasound, you'll come to know that about the compound imaging. If you keep that on, your image is better. So now that see, jil dekha ni, grainy dekha jo ni.
See the difference, MB off. If I put it again, press MB and see, it's better. Okay, resolution. If I put that this is general mode, this is penetration mode. Because again different. Granny देखते ना ना कोणार्क टीवी देखना 90s रा. ये देखा है असले resolution GB is little better. So make sure that it is in nerve setting. Resolution mode is on specifically with this machine, and this MB on multi beam or the compound imaging. Okay. And then this is the orientation marker. Look here on the left side. If I'm putting like this is medial, this is lateral. I'm just showing a systematic scan. Okay, starting from here, this is the thyroid, this is the tracheal rings. Okay, and then as I come down slowly lateral, one can see this is the carotid artery and this is the IJV. Did you see that? With little pressure, IJV gets obliterated. And you see that is, if I put color, blue, white, both will be, as I has been told, this is a Doppler effect. Okay, there is a Doppler principle that you should go and read. Blue away, red towards. With little pressure, the vein gets obliterated. The surface muscle, that is the, what is this muscle called? Sternocleidomastoid. Okay. Remember one thing, we scan. So when you start scanning, look here at the probe. Sometimes you may turn like this. That is wrong again. So these are these, take a munda uthao, two heads. Okay. And then lateral, then this will be scalene muscles. All those brachial plexus run like this, go in this manner. So the scanning technique is perpendicular to the course of the brachial plexus. That means if the brachial plexus is running like this, your probe has to be 90 degrees to the course of the nerve. Okay, so that is important. Make sure that you don't scan this way, not this way. Okay, 90 degrees to the course. And as you do that, this is your sternocleidomastoid, carotid, IJV, and slowly you see two muscles. Okay, this anterior scalene muscle and this is the medial scalene muscle. Did you see that? Okay, two scalene muscles and in between, like butterfly appearance. See the two wings of the butterfly. And then this is the nerve roots. Okay, or the root and trunk before they form the trunk. So this is the interscalene area. Okay, and there is another small nerve. Do you see that? That goes through the middle scalene muscle. That is the dorsal scapular nerve. Okay, see, as I go up slowly, this is one nerve root, this is the second nerve, this is the C6 nerve root, C6. Okay, see anterior posterior, this is C6, coming down again, that is C5. Okay, so now they are from the interscalene area. For an interscalene block, you just keep it like this. Your needle comes from lateral to medial like this and stop it over here. Okay, paraplexus like this. Your needle will come from here and you stop it here at this level to do an interscalene block. And empty. So always it is an in plane approach. There are two approaches. Scanning technique again, short axis, and injection technique is that you hold it this way. So this is a freehand technique. You hold it, let it rest the hypothenar eminence to stabilize the probe, and your needle will come just little lateral to the outer edge of the ultrasound probe and will go in plane like this. In that process, you see the whole of the shaft and the tip. If not shaft, it is essential to see the tip of the needle at all time. That is like, mandatory for ultrasound guided blocks. Okay, your needle will go like this. Okay, so here you see between two scalene muscles here, and this is the brachial plexus. This is the interscalene brachial plexus area. Your needle will come from in plane, from lateral to medial. Will stop it over here. Try to avoid this nerve, dorsal scapular nerve. Okay, that supplies the levator scapulae and the rhomboideus muscle, and then slowly go down. I am reaching the supraclavicular area. See here, this is the pleura and this is the first rib, and you see this is the bunch of grapes appearance, posterolateral to the subclavian artery. You put color here, subclavian artery over there, and see the difference. This is the pleura, shining pleura, and provides artifact there, and this is the first rib, bright, hyperechoic, both are hyperechoic, and there is an acoustic dropout shadow. That means below ultrasound, below the bone, you don't see anything because all the beam returns back to the probe. And this is the muscle. As I slightly, see, I'm here, as I slightly go up, this is the middle scalene muscle. That means you see a bit of black. That is where the middle scalene muscle gets inserted into the part of this first rib. And your needle will come in plane from lateral to medial. We target the corner pocket first to block the inferior trunk, C8T1 here, around 8 to 10 mm of local anesthetic. Withdraw and go inside, and you just deposit another 10 ml. Good 20 ml is more than enough to block Are prathame you go here. Okay, inferior trunk like this. You target that is called corner pocket. Okay, you go it here because if you don't do that, sometimes the corner pocket blocks is little delayed. It can be delayed. So if you do that target that way, it becomes a dense, quick block also. Okay, all those this is CAT1 territory that gets blocked. The all unknown territory gets blocked quickly. Go there. It has middle scalene. This is the anterior scalene. It has middle. See, every 8 hochi. I'm just scanning up. Move puruk jauchu. Dekla, see the difference two muscles. Okay, 80 block kale. This is called lower interscalene approach. If you go here, this is the pura bag. It is a bunch of grace. Pura 8 hoita hello. This is pura whole bunch of grace. So you first go it here. It's when the elevator then pull back and then go. It's with the small nerve. It's white brighter that is all the connective tissue. That provides a lot of cushion here. It is so nerve injury is very uncommon, very rare here. Okay, so the incidence is pretty less compared to interscalene or axilla or maybe like humeral nerve here. Okay, so this is how to do a again supraclavicular. You come from here lateral to medial and stop here and then go here. Okay, make sure that this target this part the first the color put there either make sure that that is not a blood vessel and this muscle on the top is omohyoid muscle. Muscle like an omohyoid theta. This can be a blood vessel also. It a blood vessel be hyper. Sometimes put some color and to make sure that it's not a blood vessel. Okay. It is the first nerve that is the suprascapular nerve. When you do, make sure that you don't go to that suprascapular nerve. That supply the supraspinatus, infraspinatus, and the shoulder joint. Chalo, quickly scan and do yourself. Take some jelly. Understood? Go year, first year, second year? Second year. Okay. That means about anatomy, surface landmarks, okay. No. Don't talk to you. Now, PS ka dakar nahi. Height bunch of grape honeycomb se ka dekha de bro. Mau machi phene mala dekha de. Ko it dekha idal carotid. All of you listen. So this is the thyroid gland. So in ultrasound, there are 4 approaches. One is anatomy surface landmark. Okay, first is machine setting. Make sure that everything is set up properly. Then pattern identification. Okay, pattern identification means you identify which is what. Could a blood vessel, could artery, could a vein, could a nerve, could a muscle, tendon, bone. That is identification. Second thing, don't jump into doing the block. Identify then third is to do the block. Needling. Once you start doing the block, you will find that so needle episode huge. You don't see the needle tip codage. Then that is again another challenge. You slowly learn to overcome how to visualize your needle tip all the time. Okay, so methods achi. Then finally, once you identify the tip and deposit the local anesthetic around the plexus of the nerve, fourth thing, how do you make sure that you did the right approach? Kemti spread hell spread. Okay, do that. Hello. Someone question you want to continue? Continue. बंद कर मैं मुझ स्कैनिंग करके देखे दे हाँ छोड़ दे हाँ एड़ा नहीं जा
Regarding the question on, no, you all carry on. Regarding the question on the needle tip localization, obviously we are not doing a needling workshop. We are not needling our volunteers. And basically there are different techniques by which you can always have your needle tip because obviously it's very mandatory for the safety of in ultrasound blocks that your needle should always be under your vision. First, this is this is practice. Second, there are different manipulations. There's a part manipulation, pressure, alignment, rotation, tilting, so that your needle tip is always in vision. You can do those manipulation. You can jiggle your needle so that you know where your needle tip is. And there is one more technique. If you see the bevel, if you put your needle with the bevel facing up, you can differentiate the shaft from the needle tip. If the bevel is facing up, the needle tip will show a double bubble sign, and the shaft will not show a double bubble sign. So by these are the techniques by which you can have your confirm your needle tip where your needle tip is. Thank you.
That is musculocutaneous. Have you seen costoclavicular and come this way? Whatever you are doing, it should be on a straight line. You always should maintain the ergonomics. It should be in a straight line. We need to increase the depth here. Okay. Okay, no, not like this. So you can see the structure here. Hold it. This is pectoralis major. This is pectoralis minor. This is axillary artery, axillary vein.
They will carry a good message home. Now over to Ritesh.
Thank you to all the delegates who came for the hands-on and who were present online to witness this, learn something from this ultrasound guided nerve block workshop. First and foremost, the most important tip is know your anatomy. First, know your anatomy, then know the sonoanatomy. Okay. If you don't know your anatomy, if your anatomy language is not, anatomy knowledge is not perfect, you cannot correlate that anatomy into sonoanatomy, and every patient has a different anatomy. So, पढ़ाई जरूरी है, ठीक है? So that's the first clinical tip. And second is, you can think of starting, always think, because right now, the future ahead is all the patient will tell you, give me a pain-free surgery. So if you are not in that race, then you are out of the race. So in future, this is a demand, this will be demand from every patient. Practice, attend workshops, because that is a place where you learn many things, and you go back home, practice that. We also we attend workshop, we teach, but we also go to next station to learn something from our co-colleagues who are good in something. Everybody is not good in all blocks. I'm not Rajendra Sahu who's the boss of all blocks. So I have to learn many things. I go to different stations after the workshop is winded up. I go and take some tips and tricks from my co-colleagues. So there is no harm in going telling, मुझे नहीं आता है. Obviously, I cannot know everything. Okay. And now I will give to my colleagues who took out their time to come and teach you all. And thanks to everyone for coming and joining in this COVID time. So a big round of applause for all of you. And special thanks to Rekha Madam for giving us the opportunity. Thank you very much, ma'am. Thank you. Gaurav, you want to wind up?
I would like to thank again Rekha Madam for a wonderful setup here. She has a great setup. We can organize much more workshops and conferences here. So this is a great setup. Thank you, Madam. Thank you, Vijay Uncle. And this is a great setup. There is a wonderful setup. There is another hall there. So there's a big setup here. Okay. So thank you all. Yeah. So Yeah.
And thanks to Sonosite. Thank you. Thank you always. They have been our educational partners. Best part is they don't ask for any money for that.
Again, from my side, thank you to Rekha ma'am and ISA Odisha. And big clap I would like to have for the delegates. They are very enthusiastic and very like interested to learn these things. So I'll just convey the message that keep on learning and keep on practicing. That's it. Thank you.
Yeah, this is actually a good session overall, and we are thankful to Rekha ma'am and the organizers. ISA has come a long way in doing all these things. What basically the message has to be passed that you communicate more, be more frank with your surgeons, what we are going to do, so that it's not that we are always antagonistic to what the surgeons want, but if we tell them what we are going to do and what relief it's going to cause, they are going to be cooperative. It's not that everyone is obstinate. You need to open up, you need to tell, you need to explain your patients also what you're going to do and how good it is going, because the message has to be conveyed. If he gets a good pain relief, he is going to pass this message, because our science, our anesthesia, this thing has to be conveyed to everyone. So this is the better way of passing the message through our patients to the patients who are going to come to you next. So that's very important. And thank you, everyone. Thank you, Rekha.
Madam, thank you for organizing this wonderful platform over here. And SCB guys, so SCB is the oldest and the most premier institution in our state. So you guys must be up to that mark, go back. Because all the SCB guys over here, so I'm just telling for that, Okay.
Yesterday he will get his termination letter from
Okay. So just a lighter note, so that you can pretty much people divide like anesthesiologist, those who know ultrasound, who do not know ultrasound. It is not about the nerve block. You'll have patient who will have difficult cannulation, arterial line, central line, POCUS, point of care ultrasound. So learn that, utilize that. Your life will be much easier, and you'll be one step ahead of others who do not know ultrasound. Okay, this is like very fascinating, and you'll just simply will get addicted to it. Okay. Thank you, ma'am. Thank you very much.
I think we will take a photograph, everyone with the faculties. And it has been a wonderful session. Really, they have put so much of hard work. And I think with this crowd, I think everyone has learned individually very well. That is the best part. And second, I'm also happy a lot of students have got together to watch in a bigger screen. And this was supposed to be discontinued at one point of time, but it continued to be transmitted throughout. So that is a very good thing. So all the efforts have really been very fruitful. And what even a very good message that Siddharth said, you need to be proactive. You need to create this awareness, and you have to show results so that your surgeons are convinced. New surgeons are coming up. They are also very much very inquisitive, and they are also like allowing all this thing to yes, they are cooperating, and they also want to take pain relief way ahead. So we don't think we'll be having this problem. Now we have to institute and implement the whole thing. So we need to propagate this also to lower levels. New students are coming up and all. So thank you all again. Without delegates, nothing would be possible. And I also thank my local coordinators. They have been with me and supporting me, and Sonosite for always being there. In spite of all hurdles, anyway, this would not have been possible without their help. And they're always looking forward to helping also. That is a very good thing in them. And thanks to all again. And we'll all get together, delegates and faculties, for a photograph.
Hello, friends. Good afternoon and welcome to this difficult airway meeting. I now request Dr. Rekha Das and Dr. Nivedita Rampani, the organizers of this ISACON ODISHA, to kindly introduce the program.
The difficult airway management workshop session. The course coordinator is Dr. Sheila Nanan Maitra. As you all know, she is the professor of anesthesia, critical care and pain at Tata Memorial Hospital, Mumbai. She is also the president of All India Difficult Airway Association and the chair of Intensive and Critical Care Medicine, Medicine Committee, World Federation of the Society of Anesthesiologists. and the country lead of International Nosocomial Infection Control Consortium, Argentina. And she will be she has a team who will be delivering you the workshop on supraglottic airway devices, high flow nasal cannula oxygen, video laryngoscopy, tracheal intubations with flexible fiber optic bronchoscope, and emergency cricotherotomy. And they will be bringing to you beautiful case scenarios which we may encounter in a day-to-day practice, and which will give you a real how to handle a real life scenario. With these few words, I now hand over this workshop to Dr. Sheila Nainan Maitra. Dear Sheila, I invite you now to conduct this workshop as a course coordinator.
Thank you so much, Dr. Rekha Das. Firstly, for this very kind invitation, and congratulations on a very successful start of the ISA ODISHA branch meeting, state conference. And thank you for giving us and Team IDA the opportunity to conduct this workshop. Over the next 4 hours, we will be conducting a very comprehensive workshop on difficult airway management. At the outset, I would like to introduce my team before I go ahead and talk about the way we will be conducting this. So first of all, I would like to introduce my professor and head, Dr. Divatia. I don't know if he's here yet. So Dr. Divatia is professor and head at the Tata Memorial Hospital. He's also been the past president of ISCCM and the past president of the IDA. So I welcome sir. We also have Dr. Rakesh Garg. Dr. Rakesh Garg is here, right? So Dr. Rakesh Garg, all of you know Dr. Rakesh Garg, very senior experienced faculty. He is a professor at the All India Institute of Medical Sciences, working in the cancer wing, the Braj Hospital. And he's also the vice president of IDA and a very active speaker at, I can say, almost all anesthesia and intensive care forums. So welcome, Dr. Rakesh Garg. We also have with us Dr. Syed Moeed Ahmed. Dr. Moeed, you're here. Please wave out.
Yeah, I'm there.
Dr. Moeed
Good morning.
was a senior professor and former head of the Department of Anesthesia at Aligarh Muslim University. He's also on the executive committee of IDA, and he's almost synonymous with difficult airway management, and you will see him again at all anesthesia forums. So welcome, Dr. Moeed. We also have with us the duo of Dr. Amit Shah and Dr. Apeksh Patwa, both from Vadodara. These are two airway experts. So please show me your hand, wave out. Yeah. So both are working at the Kailash Cancer Center as consultant anesthetists, and also at WIMS in Vadodara. Very actively involved. They also have developed their own video laryngoscope called the Patwasha video laryngoscope. So very innovative, very creative, and very senior faculty in airway management. We also have with us Dr. Jason Doctor. Jason, please wave out. My colleague at Tata Memorial Hospital. He's also professor of anesthesia in our department, and he is a pediatric expert and also an expert in airway management and on our executive committee. So welcome, Dr. Jason. So this is an entire team of 7 members who we are going to have with us, and all of them are authorities in the field of airway management. So just to introduce the program, what we decided is that time is short and we would have very much liked to conduct this workshop with you there in Orissa, because conducting a workshop online is a little challenging, especially in terms of demonstrating various equipment. So we are going to try our best to have a series of lectures along with videos and make it as interactive as possible. So what we're going to do over the next 4 hours is that we will first have a session where we will talk about the various devices and how they're used. Since we cannot demonstrate these devices, we will try to show you videos, and we will also have a moderator in each of these half-an-hour sessions who will interact with you. So whatever questions you have, queries you have, please put them on the chat, and we will take them up with the speakers in the last 10 minutes of each 30-minute session. Is an interactive session where we will take question answers. Now, followed by these 5 sessions on devices, which is going to be video laryngoscopes, supraglottic airway devices, high flow nasal cannula oxygen. We're going to talk about flexible bronchoscopy. We're also going to talk about various techniques of performing emergency cricotherapy. So following this, what we'll have is we will have the guidelines on management of unanticipated difficult airway, as well as the guidelines for extubation of a difficult airway, both from the All India Difficult Airway Association, which will help you integrate all these various devices, especially when you face an unanticipated difficult airway, and as I mentioned, for extubation of the difficult airway. Then following this, what we will do is we will have a very nice interactive session where we'll put it all together. So whatever you've learned with the devices as well as the various scenarios that we've discussed, we will have a case presentation, and Dr. Devatya will be doing this. So very interesting unanticipated difficult airway cases as well as anticipated difficult airway cases will be discussed. First, we will put it to you and we will ask for your suggestions, and you please put your answers on the chat. And then we will have our expert faculty who will give you their airway plan. And then I think in the last 10 minutes, we will directly, all the faculty will be on the screen and you can directly ask any questions related not only to that topic, but any other topic in difficult airway management to any of us. So this is how we will proceed with the sessions. So without any delay, I would like to introduce invite our first speaker, Dr. Jason Doctor, to kindly speak on supraglottic airway devices and what its applications are and how the troubleshooting will be done. I've already introduced Professor Doctor, so please go ahead, Dr. Jason Doctor.
Thank you so much, madam, for the kind introduction. And I will just go ahead and start sharing my presentation.
The moderator is going to be Dr. Amit Shah. Sorry, I forgot to say that.
Is that visible or?
Yes, yes. And through the talk, please put your questions in the chat box and Dr. Amit will steer the discussion with Dr. Jason. Thank you.
Yeah, so I will be discussing about supraglottic airway devices, what are the various applications and troubleshooting. And at the end, I will try and stick to time and show you a couple of videos for confirming the successful placement and how do you intubate through a supraglottic device. Right, so before I begin my talk, with due respect and regards to this gentleman, Dr. Archie Brain, who was the inventor of the supraglottic airway device prototype, that is the classic laryngeal mask airway, in the year 1981 at a London hospital. This became commercially available in Europe in 1988 and USA in 1992. So what is a supraglottic airway device? It is a device which fills the gap between a face mask and a tracheal tube in terms of anatomical placement and degree of invasiveness. Right? So all of these supraglottic airway devices which I will take you through are actually have two components, the airway tube and the mask, which fits onto the glottic inlet. And it makes the management of the airway very much simpler because it keeps the hands of the operator free to perform other important tasks, right? So this is the level of invasiveness. We're ranging from the face mask to the endotracheal tube, okay? And in between these two spectrums, you have the extraglottic airways, which include the laryngopharyngeal airways, which displaces the tongue from the posterior pharyngeal wall, the perilaryngeal airways or the supraglottic airways, which form the glottic seal along the glottic inlet, and the esophageal blockers, which I will take you through. Yeah, so the indications of using these supraglottic devices could be elective, okay, or as a rescue device in a difficult airway scenario, in a cardiac arrest scenario, as a conduit for intubation, as a bridge to extubation. Now, taking you through the IDA 2016 guidelines for the management of unanticipated difficult tracheal intubation in adults. Similar guidelines were published for the obstetric population, pediatrics, the intensive care unit, where the step 2, that is after the first failed attempt at laryngoscopy and tracheal intubation, you have insertion of a supraglottic airway device or a second generation supraglottic airway device as a rescue device for maintaining oxygenation in the patient. So apart from elective use, this is a kind of a rescue airway in all of these guidelines, ranging from adult, obstetric, pediatric, intensive care. The options following this are, you could either awaken the patient or continue the anesthetic using the second generation supraglottic device if considered safe. You could use this as an intubation conduit with a fiber optic scope only if the expertise and the equipment is available. Okay. and apart from that, you could use for CPR and as a bridge to extubation. So these are the extubation guidelines in 2016 that were published. Okay, and in patients whom you do not want a pressure response or hemodynamic perturbations during extubation, you do not want the patient coughing and violently, like in neurosurgical cases, like in open globe injuries, in ophthalmic cases where you want a smooth extubation to take place, it is a good practice to replace the endotracheal tube with a supraglottic airway device when the patient is under deep plane of anesthesia, reversing and waiting for the patient to wake up spontaneously. This provides a much smoother emergence from anesthesia and is popularly known as the Bailey's maneuver. It can either be done with the endotracheal tube in place, passing it behind the endotracheal tube, or railroading it over the endotracheal tube, or removing the endotracheal tube in a deep plane of anesthesia and replacing it with a supraglottic airway device, depending on the comfort of the operator. So these are the various indications for use of supraglottic device, which I repeat could be elective, as a rescue airway, in a CPCR situation, as a conduit for intubation, and as a bridge to extubation. Now, there are various contraindications for use of supraglottic devices, like any patient who is at a risk for aspiration or full stomach, patients with restricted mouth opening or trismus, obstructed airway, disrupted airway, stiff lungs, and relative contraindications like morbid obesity, pregnancy, opioid medications when they are used in an elective setting. There's a mnemonic called as RODS for remembering all the contraindications like restricted, obstructed, disrupted airways, and stiff lungs with poor lung compliance, because you may exceed the seal pressure of these devices and cause gastric insufflation or accidental dislodgement and displacement of the supraglottic airway devices. Coming to the classification of supraglottic devices, Miller's classification divides these supraglottic devices into three basic types, that is perilaryngeal sealers, pharyngeal sealers, and cuffless pre-shaped sealers. I'll take you through each of them. In the perilaryngeal sealers, they form a glottic seal around the laryngeal inlet. They may or may not have directional sealing depending on how the cuff inflates. A pharyngeal sealer has a cuff which inflates in the oropharynx, okay, like the Cobra device, or has a esophageal sealing cuff which obliterates the lumen of the esophagus. And you have cuffless pre-shaped sealers like the iGel and Basca. This is one method of classification of supraglottic airway devices. Another technique of classification of supraglottic devices is depending on the generation, the first generation and the second generation. The first generation only has an airway tube. The second generation has an airway tube with a gastric channel, a bite block, integrated bite block, and has higher seal pressures because of various modifications in the design of the equipment to enable controlled ventilation at higher airway pressures, so that they can be used in slightly COPD kind of patients or stiff lungs, or in patients in whom there is a pneumoperitoneum and slight amount of airway pressures are higher. Okay, so this is the second method of classification. A third generation supraglottic device has been described in literature by a few, and some of them do not accept this as a classification, in that with each positive pressure breath, the mask seal of the supraglottic device improves with each breath over the laryngeal inlet. So these are the classification techniques, how supraglottic airway devices are classified. Coming to the first subgroup, that is the perilaryngeal sealers. A lot of companies are involved in designing these supraglottic airway devices, one of which is the Teleflex, or the company that designs the LMA Spectrum. This is the prototype of the LMA devices, which was first invented by Dr. Brain. And it has an airway tube and a cuff with aperture bars which prevent downfolding of the epiglottis. It has a pilot balloon, okay, and which inflates and sits on the laryngeal inlet, a 15mm endotracheal tube connector, which connects to the airway breathing socket. All of us are familiar with this. I'll not go into details of this, right? So this is the classic prototype LMA. After this, a lot of other LMAs have been designed like the LMA Flexi, which has a flexometallic tube which can be moved away from the field of the procedure. The LMA Unique, which is a disposable variant of the first generation LMA Classic. The LMA Classic XL, which is similar to that except that it facilitates intubation through the first generation supraglottic airway device, which has an epiglottic elevating bar, a universal connector which can be removed, and a wider airway tube. All of this have become less popular because of the availability and the advancement in having second generation airway devices, because the seal pressure is much higher and it allows you to pass a nasogastric tube into the stomach. So what do you understand by seal pressure and intracuff pressure? Intracuff pressure is the pressure inside these cuffs and is measured by a cuff pressure manometer. The perfusion pressure of the mucosa in the pharynx is 60 centimeters of water. So the pressure of the cuff, air pressure inside this cuff should be aimed to be less than 60 centimeters of water. Otherwise, it can cause sore throat because of ischemia of the pharyngeal mucosa, and it can cause compression paralysis due to injury to various nerves around the airway structure. This is what you mean by intracuff pressure. The seal pressure is the pressure above which, if your ventilation is going higher than the set pressure, than the recommended pressure, it is likely that you are like either your LMA is not properly positioned, or you are going to insufflate the stomach because of dislodgement. So the seal pressure that is recommended for a first generation device is 20 to 25 centimeters of water, and for a second generation supraglottic device is 30 centimeters of water. So this is the difference between seal pressure, by which he seals the laryngeal inlet, and the intracuff pressure, which is the pressure inside the cuff of all these supraglottic airway devices. Now, this is the second generation, which was the first second generation supraglottic airway device, the LMA Pro Seal. I'm sure all of you all have used it and know about this, that this has a drain tube and an airway tube integrated into one common tube with a bite block. It has a cuff. The drain tube opens at the terminal tip, which fits onto the upper esophageal sphincter. The drain tube prevents downfolding and occlusion of the airway lumen by the epiglottis. Okay, and it has a pilot balloon. Now the difference in this is that it has a dorsal cuff. So when you inflate this cuff with the pilot balloon, there are two cuffs which inflate, one along the perilaryngeal seal and one in the dorsal cuff, which moves this cuff away from the posterior pharyngeal wall, improving the seal at the laryngeal inlet, which is why the seal pressure is higher, that is 30 centimeters of water. So that is about the second generation LMA Pro Seal. The LMA Supreme is another advancement with a preformed PVC tube, airway tube, and a disposable variant with a drain tube and a bite block. The advantage is it has a preformed curve, so it fits into the oral cavity, and the method of and the technique of insertion is much easier because of this preformed curve. The disadvantage of using this is that the airway tube is elliptical and narrow and does not allow passing a fiber optic scope. So if you need to intubate through this device, you need to have an entry intubating exchange catheter. So that is about the LMA Supreme. These are the various sizes of the LMA that are available. 1.5 ranging from that to adult size, more than 100 kilos, a size 6. Okay, and these are the recommended volumes of inflation of all these supraglottic airway devices. Now, after all these devices, this was the ILMA, which was designed in 1997 and was ideally used for intubation through this supraglottic airway device. The technique was although blind. So it has a supraglottic airway with a preformed rigid steel tube, a fast track endotracheal tube with a soft silicon tip, a vertical, an epiglottis elevating bar which prevents downfolding of the epiglottis, and a stabilization rod which helps in intubation through this supraglottic airway device. Now, with the available of cheaper fiber optic scopes and with the guidelines recommending that all of these intubations through supraglottic devices are preferable to be done under vision with railroading of the endotracheal tube over the fiber optic scope passing through the supraglottic device. This device is used, but only with a fiber optic scope, because the tip of this tube can injure the arytenoids And if it is not correctly aligned, it can cause injury, and intubation can be unsuccessful. Right. So this is the LMA Fast Track. It is available in 3 sizes, 3, 4, and 5. Now, when we describe this device, a maneuver known as Chandy's maneuver is very popular, that you move the handle of this device, okay, in a coronal and a sagittal plane, and you lift this up. When I show you the video, we will see how this maneuver is done and how it helps in aligning the supraglottic airway device with the laryngeal inlet to facilitate successful introduction of this fast track endotracheal tube by aligning the axis with the supraglottic airway device. So this is the Chandy's maneuver. Okay, with the newer LMAs coming into vogue, this is one of the newer batch of LMAs, the LMA Protector, which is also a second generation device, which has a bite block, a silicone non-phthalate containing cuff, which causes lesser incidence of sore throat, a second seal technology. That is, if you see the distal drain orifice, it is widened and occludes the upper esophageal sphincter. Okay, it has a connector, and it is a newer advancement in the supraglottic airway device. This pilot balloon can also be replaced with a cuff pressure indicator. So these are available in 3 sizes, 3, 4, and 5, which can accommodate corresponding sizes of endotracheal tubes and corresponding sizes of orogastric tubes. This is the most recent of the LMA devices that has been invented. Okay, and it is specifically directed towards using the supraglottic device for endoscopy. It has an endoscopic channel, the LMA Gastro, which can allow the passage of a gastroscope or an endoscope, and an airway tube which is at an angle in which you can continue ventilation and monitor the capnograph. And this is what I was talking about, that the pilot balloon is replaced by this cuff pressure indicator. So you always have to be in the green zone. If it is in the red zone, that means the intra-cuff pressure of this is higher than 60 centimeters of water, and it is advisable to deflate the cuff till the mark is at the green zone. So these are the various LMAs. How do you identify successful and correct placement of the supraglottic airway device? By visualizing adequate chest rise, absence of an audible leak. The tidal volume should match the set tidal volume, and the peak pressure should not cross the recommended seal pressure of the device. A suprasternal tap test, that is, if you have a blob of jelly in the drain tube and you put pressure on the suprasternal notch, the meniscus of the blob of jelly moves up and down with each pressure on the suprasternal notch. There should be no leak. A Riles tube can be easily passed through the drain tube channel, and a gold standard is use a fiber optic scope through the airway channel, and you can see that the vocal cords are correctly aligned in line with the airway tube. So these are some of the techniques to verify the correct placement of the supraglottic airway device. The recent uses of LMAs and controversial uses are in laparoscopic surgery, obesity, non-supine positions, that is prone position and altered different positions, non-fasted patient pregnancy. Now, if you are comfortable and if you are an expert and if you can deal with the airway with in all these altered conditions, only then is it recommended, because the evidence is sparse. There have been a few trials which are showing that use of a second generation supraglottic device is okay in laparoscopic surgery. But again, I would warrant a high level of caution when you are using this as a replacement to an endotracheal tube. And mind you, again, pregnancy I have listed here. In the obstetric guidelines, the step 2 is insertion of a supraglottic airway device, but that is as a rescue device and not as an elective choice for supraglottic airway device, as a choice for elective management of an airway undergoing in a pregnant lady undergoing general anesthetic. Right? Then I come to the second company which manufactures supraglottic airway devices, that is the Ambu-laryngeal mask, the Ambu Aura Straight, the Ambu Aura Flexi, the Ambu Aura I, which has a preformed curve and a wider airway tube, which permits intubation through this supraglottic airway device. The Ambu Aura Gain, which is the ProSeal or the supreme equivalent or by the Ambu company, which has a LMA, which has a drain tube, a preformed curve, and a bite block, okay, with a higher seal pressure. The Air Q, which is also designed for intubation through the supraglottic airway device. It has a shorter and a wider airway tube, a airway universal connector, which is color coded for the size and which can be disconnected to facilitate intubation through this device, and a keyhole shaped mask opening to prevent downfolding of the epiglottis. So this is another of the perilaryngeal sealers. With that, I come to the second type of the Miller's classification, that is the cuffed pharyngeal sealers, that is the cobra. Okay, so here you can see that this looks like a cobra head and it is a pharyngeal sealer. So this balloon inflates in the posterior pharyngeal wall and lifts the tongue away from the posterior pharyngeal wall, and the grills and the airway tube align this with the aryepiglottic inlet so that you can continue ventilation through this device. A laryngeal tube which has a pilot balloon which can be connected and simultaneously inflate both these cuffs with the airway venting channels. The distal end of this can either be blind in a laryngeal tube or can allow the passage of a nasogastric tube in case of a laryngeal tube suction. It has a universal color-coded airway connector. So these are all pharyngeal sealers because the esophageal balloon inflates and the pharyngeal balloon inflates, moving the tongue away from the posterior pharyngeal wall, and ventilation can take place through this device. So this is the laryngeal tube suction that I spoke to you about that allows the passage of a nasogastric tube through the tip. Then last of all, we come to the cuffless pre-shaped sealers, which are the iGel, which is quite popular. I'm sure all of you all must be using these. So it's made up of soft thermoplastic material, which is a gel-like material. There is no inflation. It has a bite block and a buccal stabilizer. It is elliptical, occupying the oral cavity, has an orifice for the drain tube and a universal connection for the ventilation with an integrated bite block. Okay. And last but not the least, the Baska mask, which is a recent addition. I think it's invented in the early part of this decade. Okay, and it has an elbow color-coded connector which passes the drain tube, a universal connector, and a hand tab for facilitating insertion. Now, the beauty of this device is with each positive pressure breath, the seal of this around the glottic inlet improves. So you have to see it to actually understand what happens. And that is why some of them claim that this belongs to the generation that is the third generation. It also has a gastric luminal opening for allowing drainage of gastric secretions and passing a nasogastric tube. Now, after I have completed all the different supraglottic devices which are popular and available in the market, a word about troubleshooting and what are the troubles with supraglottic airway devices. Either you can have an insertion failure. So in this condition, the patient should be adequately deep with the jaw relaxed. Person can give jaw thrust to assist you in insertion of the supraglottic device. You can have accidental dislodgements, malpositions, regurgitations, trauma. These are some of the troubles of using a supraglottic airway device. And the supraglottic device can either be too outside. It can have the drain tube within the airway, which I will show you. Okay, and that can lead to collapse of the reservoir bag. The pressure of ventilation, that is the seal pressure, may be exceeded, and there may be a high pressure alarm if the supraglottic device is either rotated or malpositioned or folded on itself. There you can have difficulty in passing a nasogastric tube through the drain channel, and if you exceed the seal pressure if the lung compliance is very poor or if it is malpositioned, you can cause abdominal distension and gastric insufflation while ventilating through the supraglottic airway device. So the distal cuff can either, so these are the different malpositions that you can face. Either it can be in the oral cavity or in the vallecula. The tip can be in the vallecula. The solution to this is removal using a correct size with a jaw thrust and insert it to the correct depth. Either it can be too out, or if you have a supraglottic device with the drain tube within the airway, it can cause leak of the ventilated tidal volume through this drain tube and leading to collapse of the bag. The corrective measure that can be done is you can pass a bougie through this drain tube, which I will show you a video about, and do a pharyngoscopy and pass this bougie into the esophagus and railroad the supraglottic airway device over this bougie. You can have folding up of the cuff, that is the cuff can fold over itself causing difficulty in passing a nasogastric tube, higher peak pressures. Again, the solution to this is you can remove it and pass it and railroad it over a bougie, enter into the esophagus. You can have epiglottis downfolding and occluding the airway tube, which can cause a rise in the peak pressure and unsuccessful intubation attempts through the supraglottic airway device. So solution to this is reinsert with head and neck in extreme sniffing position, give a jaw thrust, and pass the supraglottic device with the correct size into place. Again, if you use a larger supraglottic device than the recommended size for that particular weight and age, and if you inflate it too much from both the sides, the cuff can approximate and occlude the airway lumen by coming and impinging onto each other in the midline. Again, the solution to this is using a correct size or deflating the cuff and making sure that the intra-cuff pressure inside this cuff does not exceed 60 centimeters of water. So these are some of the troubles that you would face. I will go through a few videos, please. And
Dr. Jason, we'll have to hurry a bit, huh?
Yeah. I'm nearly done. The videos will be just 2 minutes.
That's fine. Please put your questions in the chat box.
Just a minute. So I'll take you through the bougie guided insertion.
This video demonstrates a bougie guided insertion technique for the LMA. This method was devised by Dr. Brimakon. A gum elastic bougie is lubricated and passed through the drain tube of the Procele LMA. Once the patient is the bougie is gently passed into the esophagus and the Procele LMA is passed over it to correct position. The success rate of correct placement of this technique is very high and prevents the LMA from downfolding or upfolding on itself and aligns the drain tube with the upper esophageal sphincter. The success is as high as 100%. However, the disadvantages of this technique is that a pharynxoscopy needs to be performed thereby causing some pressure response, and the bougie being a rigid structure can cause some esophageal trauma.
There's another video. The position confirmation.
This video demonstrates the method to confirm the correct placement of position of LMA. The first method is adequate tidal volume delivery with adequate expitidal volume without an increase in the peak pressures. The second confirmatory test is the gentle to and fro motion of the meniscus of a blob of jelly with each breath when placed in the drain tube. If there is spillover of the jelly bubbling, it indicates that the LMA is incorrectly positioned and the tidal volume is escaping out through the drain tube. The third confirmatory test is the smooth passage of an instrument through the drain tube of the Procele LMA without any tidal volume loss. It indicates that the drain tube is aligned correctly with the upper esophageal sphincter.
Yeah, and I have a last video that will show you how a Chandy's maneuver works. Yeah, so this is how a supraglottic airway device is used, the ILMA. this is insertion of an ILMA with the patient adequately anesthetized and deep. Okay, once you insert the ILMA, you inflate the cuff and confirm that the placement is correct. The tidal volume is being delivered. The peak pressure is not exceeded. Okay, then you have, once you fix it, you have a fiber optic scope with a railroaded fast track endotracheal tube over it. Okay, and once you enter, you can see the epiglottis elevating bar, and you can see that the epiglottis is down folded here. So you ask an operator to give the Chandy's maneuver and lift this. Okay, and you can see that the epiglottis elevating bar is elevating the epiglottis with the Chandy's maneuver, aligning the axis and helping and facilitating endotracheal intubation under vision as recommended by the guidelines through this LMA fast track. Once you've done this under vision, you remove the fiber optic scope. Okay, and you can confirm that it is in correct position by checking the capnograph through the endotracheal tube. You can use the stabilization rod. All this is done under vision as recommended. Use the stabilization rod and remove the supraglottic airway device and push the endotracheal tube and hold it at the angle of the mouth. Right, so I have completed my I'm happy to take any questions, please.
Yeah, thank you very much.
Thank you very much.
Jason. Amit, Dr. Amit, if there are any questions, or you can ask 2 or 3 questions, Dr. Jason, if you can unshare, and I will share my screen meanwhile. Maybe Dr. Amit, we can take 2 or 3 questions. I would like to share my screen, please.
So, Dr. Jason, excellent presentation, excellent coverage of all supraglottic airway devices. I think hardly anything left. You have covered everything in this short period. But I would like to get your experience about use of supraglottic airway in pediatric patients.
Yeah, so we routinely perform a lot of procedures like insertion of chemoports or any procedures which are short duration, non-GI surgeries in the pediatric population using supraglottic airway devices. And we have changed our practice to using only second generation supraglottic airway devices because that is the recommendation now. And we prefer to use either Proseal or LMA or again, Ambu or again, all of these. And intubation through a couple of them we have done of intubation through the supraglottic airway devices. And we've always done it with a pediatric fiber optic scope available and using a microcuff tube through the supraglottic airway device. Again, here, the important thing is when you remove the supraglottic device over the endotracheal tube, you have to be very cautious so as to not disturb the endotracheal tube and accidentally extubate. That is the important crux here.
Second query is on similar line. Suppose if I have inserted iGel.
Correct.
For a patient where I wanted to intubate and I could not intubate, I inserted iGel.
Yes.
Obviously, what are the further steps? Should I continue or should I abandon the procedure? I was not like I failed to intubate and I introduced supraglottic airway, say for a surgery like laparoscopic cholecystectomy. What should I do?
So ideally speaking, it depends on the experience of the operator. A second generation supraglottic device in place is a good device, but mind you, here you have a failed attempt at intubation and you are using it as a rescue device. If the device gets accidentally dislodged during the procedure, then it will be disaster. So if you ask me for a personal opinion, I would prefer to intubate through this second generation supraglottic device using a fiber optic scope and if expertise and equipment is available. If you do not have the expertise and equipment, I would like to reschedule this patient for another day, especially in a surgery like a laparoscopic cholecystectomy, because in case you face an accidental dislodgement or if because of intra-abdominal pressure, if the peak pressures exceed and you have a problem in between the surgery, then it is likely that you will be in trouble.
So unless you have a next step ready, you should not venture into the surgery if you have failed to intubate. Now, one more point is, suppose this is gel, and introducing tube through that with the help of fiber optic is possible, but removal of supraglottic airway over into endotracheal tube is sometimes difficult. So, what is your experience about using entry catheter for that?
Correct. So entry catheter, again, whenever you use any...
Dr. Jason, if you could tell us the steps of how you could perform intubation using an entry exchange catheter.
Perfect. Okay. So if you have a supraglottic device in place, you have a entry catheter which has been railroaded over the correct size of the fiber optic scope. All this has to be done beforehand. So once you railroad this entry catheter over the fiber optic scope, under vision, you go through the supraglottic airway device. Once you reach the carina and you're sure that you are in the airway, you pass the entry catheter over this fiber optic scope into the airway, remove the fiber optic scope. You can continue oxygenation through the entry, remove the supraglottic airway device, and railroad an endotracheal tube over this entry catheter. Okay, so I have a video because due to dearth of time, it's freely available on YouTube. So I'm sure all of y'all can just check that how to use an entry catheter over with a supraglottic airway device, and you will be able to.
You have intubating LMA which are dedicated and designed for intubation through supraglottic airway. It is always advisable to use entry catheter. Entry catheter allows a proper size of tube insertion from any supraglottic airway. Otherwise, it is directly intubating through supraglottic airway with the help of fiber optic bronchoscope may not allow a proper size of endotracheal tube to be inserted.
Correct.
So, Dr. Jason and Dr. Amit, I think the real point that you're trying to make is that if you put in a second generation device, or you put an intubating LMA and it's easy to intubate through that, go ahead with firstly, never blindly, always under vision, only if you have the expertise to do it. So I think if you are, if I'm right, 2 points are very important. One is you should do it under vision using a bronchoscope. And second, you should have the expertise to do it. Otherwise, you continue oxygenating the patient with the supraglottic airway device and get an expert who is able to do this. And the important point is never remove the supraglottic airway device which you put in as a rescue, because subsequently you may not be able to reinsert it. And here you're able to oxygenate the patient. Am I right? This is the point you're making, right, Dr. Amit? And also that never mind which supraglottic airway device you put in, if you can't intubate through that, using an entry exchange catheter, even using a Supreme LMA, using the entry exchange catheter, you will be able to intubate using this tube exchange technique. So it's a very important, useful tool in armamentarium, and people should learn how to use the entry exchange catheter to intubate through a supraglottic airway device rather than remove it and try to intubate the patient.
Yeah, absolutely.
Any more questions, Dr. Amit?
No, I think it is very well covered.
All right. Thank you very much, Dr. Jason, and thank you, Dr. Amit, for steering the discussion so beautifully. In the interest of time, I'll move on. I am the next speaker. I've already been introduced, and I'll be talking about high flow nasal oxygen. And to moderate this session, we have Dr. Rakesh Garg. Dr. Garg, please stop me at any time if there are any questions. I'd like this to be as interactive as possible. And otherwise, I'm happy to take questions at the end of the session. Now, I'm sure many of you are using high flow nasal oxygen. Many of you who didn't use it earlier, especially in the COVID era, there's more and more people using it. Initially, we were worried because of the aerosol generation that was thought of. But now we've realized, especially in COVID, that you can prevent a lot of intubations using this. So the real protection is your personal protective equipment. And you could still use the high flow nasal oxygen. So I'll discuss very briefly in the next 20 minutes what are the various applications, and also clarify some confusion that people have about these devices, and also how to optimally use it, and the setup, showing you some videos. So now remember, there are all many terms that are used for this technology, so don't get confused. People say OptiFlow, Thrive, HFNO, high flow nasal cannula, HFNCO, high flow oxygen therapy, nasal high flow, apnox. Okay, so different terminology, but they're all using high flow nasal oxygen. Now, when we use this device, it uses this device that gives high flow of oxygen. And when we say high flow, it is something more than 30 liters of oxygen. And why 30 liters? It has to be more than the peak inspiratory flow rate, so that you don't entrain air. Okay. So usually what is understood by high flow is a flow more than 30. And as you know, when you give high flow of oxygen, this is not tolerated by any patient. You cannot give dry oxygen to a patient for, patient will have a lot of discomfort, and in addition it can cause some trauma, bleeding, etc. So high flow is not tolerated, so we have to give this heated and humidified. So basically what you're giving is there'll be a special flow meter, I'll show you all this, and you are having a humidifier here, so that there you're giving heated, humidified oxygen using a very special cannula. And this is what high flow nasal oxygen is all about, and these are the various terminologies. So let us all be on the same page. They all involve giving high flow nasal oxygen. But there are two fundamental things that I want you to understand, that when you give high flow nasal oxygen, there are two ways you can deliver it. One is during apnea. Now, when you give it after paralyzing a patient, this technique is called Thrive, which I'm sure all of you know that Anil Patel has popularized. It's used both in the operating room as well as in the ICU during tracheal intubation, both for pre-oxygenation as well as for apneic oxygenation. So remember, when you use it during apnea, it is called Thrive. But you can also use it during spontaneous breathing. And this is not Thrive, because in Thrive we use 100% FiO2. Obviously, you have paralyzed this patient, you're giving 100% oxygen. But during spontaneous breathing, you have a blender in the device where you can give different variable FiO2 in a spontaneously breathing patient. So let us look at the various indications for this high flow nasal oxygen therapy. So the commonest is to pre-oxygenate this patient and then continue this nasal cannula delivering oxygen during what we call apneic oxygenation during attempts at tracheal intubation, rapid sequence intubation, also various surgical procedures of the airway. And I'll describe this in detail. Now, these three first are used when a patient is paralyzed, apneic patient. Whereas the other four that I'm going to describe are in a spontaneously breathing patient. So please understand the fundamental difference between this, because everyone broadly calls this Thrive or Apox, and you have to understand, am I giving it in a spontaneously breathing patient, or am I giving it in a patient who is having apnea? So you can also give it in a spontaneously breathing patient for any procedural sedation, or for example, you're in an MRI suite or you're somewhere else where you can give this awake fiber optic intubation during the procedure. Patients with acute hypoxemic respiratory failure who present to the ICU, like in the COVID era, you can use this to prevent tracheal intubation, avoid tracheal intubation, or also after extubation, you can use high flow nasal oxygen, especially in high risk patients, to avoid a reintubation. So remember the indications in apneic patients and the indications in patients who are spontaneously breathing. Just some basics of physiology. So coming to the oxygen dissociation curve, and as you can see, this demonstrates the various saturations for various levels, and you can see that there is precipitous fall and drop in the PaO2 as your saturation goes down from 90 to 80, and you can see the fall, and this is the zone of hypoxemia. So we are very concerned as anesthesiologists, and we don't want to have patients to be hypoxemic. So we give them a good amount of pre-oxygenation, especially in patients whom we anticipate a difficult airway, so that we have enough safe apnea time. What do we mean by safe apnea time? We mean the time from when the patient stops breathing to the time to which there is critical desaturation. So we should have a longer safe apnea time, so that just in case your tracheal intubation is difficult or airway management is difficult, you have some buffer time and the patient does not desaturate. So this is the rationale for pre-oxygenation. So why do we give pre-oxygenate patients, and this is to bring the patient's oxygen saturation to 100%, to denitrogenate the residual capacity of the lungs, so maximize the oxygen stores in the lungs. And so this pre-oxygenation, as I mentioned, will help you extend the safe apnea time, and I'll tell you in a minute how. And some ways to optimize your pre-oxygenation, patient positioning becomes very important. Now try to give a patient a 20-degree head-up position. Of course, you can't keep him at 80 degrees. That will make your intubation also difficult. Now why? Because this is more comfortable for a patient to take full breaths, versus a flat position. If you see a patient who is very hypoxic and coming to you, he'll always be sitting and bending forward. He'll not be someone who's lying flat. And in the flat position, what happens is the posterior portions of the lung become more prone to atelectasis and collapse. So it's good to give about at least a 20-degree head-up position to this patient when you're pre-oxygenating. Now, the methods and the duration of and endpoints of pre-oxygenation are very important. So try to pre-oxygenate for at least 3 minutes with good tidal volume breathing, and pre-oxygenation followed by forced exhalation followed by tiding breathing is also more effective. And if there is leaks in the mask, then you can prolong your pre-oxygenation for 5 minutes. Or if you have very less time, you can give 8 vital capacity breaths for 60 seconds. This is an alternate method that can be used. And a little more enhanced way is to give PEEP using non-invasive ventilation, that is pressure support along with PEEP, especially in high-risk patients who can rapidly desaturate, like patients with already having existing lung pathology, ICU patients who come into the operating room. And here you can achieve, avoid rapid desaturation during attempts, because their safe apnea time is very short, and also their response to pre-oxygenation may not be very optimum. Now, if you have end-tidal gas monitoring, remember, don't just go by the time to pre-oxygenation, but you should look for a target end-tidal oxygen of more than 90%, at least more than 85%, and end-tidal nitrogen of less than 4%. So this is the endpoints on pre-oxygenation. Now, to understand how your apneic oxygenation works, you have to understand a little about safe apnea time, okay? So while breathing your room air, say 450 ml of oxygen is present in the lungs, and this amount increases to about 3000 ml when a patient breathes 100% oxygen and you're pre-oxygenating. And this patient breathing room air will have a total of about 1 liter. So if you are presuming that the oxygen consumption per minute, as we know, is about 250 ml per minute, and you have a reserve of about 2 to 3 liters, then this patient 250 ml per minute, so you will have about 8 minutes when a patient is breathing high FiO2. So that's the kind of apnea, safe apnea time approximately that you will have if you have adequately pre-oxygenated the patient. Whereas if you don't pre-oxygenate this patient and you don't fill the FRC with oxygen, then this patient will rapidly desaturate in about a minute. So always, whether you anticipate a difficult airway or not, it's always better to pre-oxygenate the patient appropriately before paralyzing him and going ahead with tracheal intubation. Now, about apneic oxygenation, people always wonder, how does this apneic oxygenation work? Because the patient is not breathing. So how is it that during apnea, the patient gets oxygenated? Okay, so how it works is, so as I mentioned, about 250 ml of oxygen will move from the, is the consumption. So this will move from the alveoli into the bloodstream. However, only 8 to 20 ml of carbon dioxide moves into the alveoli. And because of this difference in the oxygen and carbon dioxide movement across the alveolar membrane, and this is of course because of the difference in gas solubility in the blood as well as the affinity of hemoglobin to oxygen, this causes a kind of net pressure in the alveoli, and this is up to 20 centimeters. So kind of sub-atmospheric pressure is created, and because of this sub-atmospheric pressure, it generates a mass flow from the pharynx into the alveoli. And this is how, even during apnea, without any breathing, the air can move from the pharynx into the alveoli, and the patient can get oxygenated during apnea. So very important not only to pre-oxygenate, but also give apneic oxygenation during attempts at intubation so that you can prolong the safe apnea time further. So this high flow technology has various physiological effects. As I mentioned, there's also washout of the nasopharyngeal dead space. So your reservoir, the nasopharyngeal cavity, this is filled with oxygen, and because it reduces the dead space and the CO2 that is present, so this way it helps. There's also reduced work of breathing. You're also giving heated, humidified oxygen to this patient, and also reduced nasopharyngeal inspiratory resistance, decreases the resistive breathing efforts. Then alveoli gives some amount of PEEP also to the patient. Again, the amount of PEEP that it gives is because you're expiring against a resistance. So this again depends on the flow rate, and the mouth has to be closed. The mouth is open, the PEEP is lost, and it also depends on the size of the cannula in relation to the nostrils. Then you can have more accurate inspired oxygen, and also because of the warm gas that is delivered, you can have maintain the mucociliary function because of the heating and the humidification. So these are the various physiological effects that you get because of this high flow nasal oxygen therapy. Again, coming back to what I mentioned as Thrive, remember Thrive is one type of high flow nasal oxygen therapy that is given in patients that are apneic paralyzed patient, and this was popularized by Dr. Anil Patel. So what does Thrive stand for? Thrive stands for transnasal humidified rapid insufflation ventilatory exchange. Okay, that's what the full form of Thrive is. And this is essentially a physiological method of increasing the apnea time in patients with difficult airway. So loosely people say, okay, give Thrive to a patient in acute hypoxemic respiratory failure, but that's not possible because the patient is spontaneously breathing. When a patient is apneic, we're talking about the ventilatory exchange. So Thrive is largely given during tracheal intubation. You pre-oxygenate with the same equipment, and after you paralyze the patient, you continue delivering the oxygen nasally using this high flow, and this is what Thrive is all about. So this is what the equipment looks like. Okay, this is special nasal cannula that is there, and it is very, very comfortable for the patient. Very soft, kind of device that can be easily worn by the patient. And as I mentioned, you're giving very high flows, so you cannot just give this directly without heating and humidification. So the oxygen is passed through a heated humidifier, and so warm oxygen, humidified oxygen goes, and you're giving high flows. So you're giving something like almost 50 to 70 liters of humidified oxygen. So initially you cannot start at very high flows. You can't start at 50 liters. So we start with 30 liters. And as the patient tolerates this, you can increase the flow to 40, 50, 60, and you can go up on the oxygen flow. So as I've mentioned, during how does it work? During apnea, the net pressure in the alveoli, I've already talked about it. It becomes subatmospheric. So it generates a mass flow from the pharynx to the alveoli, and it produces the CPAP during pre-oxygenation and apneic oxygenation with gas exchange by this flow. And in addition to this, because of this high flow, there's also a flow dependent flushing of the dead space. So what happens is if you have a patient who's apneic and you're giving apneic oxygen, like if you're giving through a nasal cannula just 15 liters of oxygen, you'll be able to prolong the safe apnea time. Say from 8 minutes, you'll be able to prolong it to 12 minutes. However, the CO2 will rise. Every minute the CO2 will keep rising. But with Thrive, because you're giving very high flow, there's also a flow dependent flushing. And so the CO2 does not rise to the same extent. It does rise, but not to the same extent as if you're just as during apnea. So this method of Thrive, it significantly prolongs the safe apnea time, and thus it allows securing a definitive airway during difficult intubation or failed intubation to be in an unharried manner. For example, if you give apneic oxygenation using Thrive, you can extend the safe apnea time up to 30 to almost 45 minutes to sometimes even 1 hour. Again, it depends on the patient and what is the condition of his lungs. So just imagine if I can keep the saturation after paralyzing the patient for almost 30 minutes to 1 hour. I have enough time even to do a tracheostomy or do a cricothyrotomy or whatever. So the biggest fear that an anesthesiologist has is of losing the airway, not being able to ventilate, not being able to ventilate even using a supraglottic airway device, as Dr. Jason has beautifully shown us during rescue oxygenation. So in this kind of situation, if you've used Thrive for pre-oxygenation and then continued it for apneic oxygenation, you will be able to keep the oxygen saturation up for a very long period, during which you can make a plan in an unhurried manner, and you don't have to rush to a few seconds and quickly to do a cricothyrotomy, and you can plan this better because of the prolonged safe apnea time. And this is the original paper on Thrive from Dr. Anil Patel, and I'm sure you've seen this paper many times. And what I was talking about, the carbon dioxide levels, unfortunately this is in kilopascals that they have used. We don't use kilopascals, but you can see that as the time is prolonged, there isn't a proportionally steep rise in the CO2 level. So it does rise, but not to the same extent as it would during routine area. So this is what the Thrive equipment looks like. Like I told you, you have a special flow meter because you cannot give 30 to 70 liters of oxygen using a normal flow meter. And then you have this oxygen which is going through this heated humidified device, and you have to set the temperature here, and I will show you a video for this. And then there's a special tubing, and this is attached to the patient, and this is how we would attach it to the patient, keep it comfortable, start at 30 liters and go on increasing this. So when during the initial pre-oxygenation, you can give 30 liters because the patient can tolerate it well. And after this, when the patient is under anesthesia, you can increase from 30 to 40 to 50. You can go up to about 70 liters. Now I'll just show you, there's a video, and this I've got from Fisher and Paykel. There's a video with Dr. Anil Patel in it. I hope this plays. I will just show you the setup of this. This is just how the equipment is set up. So this is what the kit looks like. Okay, this is the disposable component. You just slide the chamber onto the heated humidifier. Now you have to fill sterile water into this and fill humidified chamber with sterile water. There is a level above which you have to fill it. Okay, and don't fill above the maximum fill line. Then you turn the humidifier on, and there's a default temperature setting that's there, usually 36 to 37. There's a short tubing. This is connected to the flow meter, and the other end is connected to the heated humidifier. Okay, then there's another tubing that goes to the patient. Okay, so you have the device completely set up and ready for use with a filter, and you can see here the nasal cannula. Okay. Now we'll just show it through how you can use it up.
Hello, sir. You okay? Yeah, fine. Very good. I'll pop a probe on your nose. Is that okay? Should be nice and warm, nice and comfortable. Is that okay? Yeah. Comfortable? And you're just going to feel something warm drifting in through your nose, okay?
Right. So this is just a video showing you how you could set it up before tracheal intubation, and that is currently Fisher and Baker. And then again, the indications for high flow nasal oxygen are also during surgical procedures involving the airway, especially short procedures involving the larynx, vocal cords, etc. Now this is just for subglottic stenosis and using it. Now what does a surgeon want? Now when you ask a surgeon what does he want, firstly he does not want any movement, right? So you have to paralyze this patient. Now normally when you paralyze this patient, either you put smaller size tube, he's working on the airway or sharing the airway, so you're putting smaller size tubes, or you can use a jet, you can do jet ventilation, or what you can do is something, a technique, apneic technique that we call, where you put a tube and while he's doing the procedure, you remove the tube and you keep monitoring the saturation. Every time he desaturates, you put the tube back in. Now in all this, what happens is there is a lot of interference. So surgeon wants three things. He wants some patient to be paralyzed. He wants nothing in the field exactly like it is, like this, and he wants no interruptions. Every time the patient desaturates, you don't want to go on. So this technology is excellent for airway surgery. Okay, so short procedures that are done, that are not for full procedures, but short procedures, you can use apneic oxygenation. So you pre-oxygenate with the high flow nasal oxygen, and then you use Thrive during the procedure, and you can prolong for at least 20 to 30 to 40 minutes, during which time the surgery is over. And these are the various large series, both from Anil Patel and various series, where they have used apneic oxygenation for airway surgery, and this is the mean time, 18 minutes, 19 minutes for DL scopies, ML scopies, various procedures you can use it. Now, the question people ask is, can you use this for laser? If you use it for laser, yes, we do use it for laser surgery, but you have to understand the fire triangle very, very well. You have to understand that you're using very high flow of oxygen, so there is a chance of combustion. However, for anything to burn, you have to understand that there has to be, you have the laser source, you have oxygen, but there has to be something to burn. So there has to be, if you don't have this, the triangle is not complete and there cannot be a fire. So there should be no tube, no gauze piece, nothing in your way that can burn. Your skin and mucosa will not burn. So in this kind of setting, you can consider using in experienced centers with doing. So in our center, when we do this, we have a timeout between the nurse, the surgeon, and ourselves, and we make sure that everyone is aware that we are using Thrive for this procedure. We don't use 100% oxygen; we use a little lower flows, but we make sure that there is no fuel, nothing to burn, so that in case the should be in your way, no tube, nobody should use the cautery or anything like that when this is going on. So in experienced hands, in people who understand that fire triangle very well, yes, high flow nasal cannula oxygen Thrive is an excellent technique that can be used, and our surgeons are really happy with this now, because the patient is completely still. There's no tube, no device, nothing in their way, and there is no interruptions for oxygenating this patient, and the saturation is maintained at 100 until the procedure is over. Now, these are all the indications during apnea. Now, I will come to how you can use it during acute hypoxemic respiratory failure, procedural saturation, and also extubation. Now, these are largely indications in the ICU. But before that, I'll talk a bit about procedural sedation and awake fiber optic intubation. Now, if you plan to give some sedation or even propofol while doing fiber optic intubation in patients who are not very cooperative or sedated, a good thing to do is to use high flow nasal cannula oxygen for pre-oxygenation and continue it during your fiber optic intubation, so that in case the patient gets sedated more, or there is some short periods of apnea, this will help you tide over that period. And this is especially useful in very high risk patients in whom you're doing fiber optic intubation, and also any other kind of short procedures that you're doing even outside the operating room, where you're giving sedation or you're doing the procedure under TIVA. It's quite useful to use Thrive. So this can work during spontaneous breathing, as well as if there are short periods of apnea, it can extend keep your patient oxygenated for longer periods. Now, in the intensive care unit, as I mentioned, it's for use for acute hypoxemic respiratory failure. And this device is a little different from the Thrive device that I showed you. The fundamental difference is that this also has a blender. And because it has a blender, you're able to use different FiO2s. So the oxygen is mixed with air. So in Thrive, you give 100% oxygen. As I mentioned, Thrive is used only in apnea. So you need to give 100% FiO2 during pre-oxygenation and apneic oxygenation. But when you're giving it in a spontaneously breathing patient, you can give lower FiO2. So this is what the airway monitor looks like. It has, in addition, the same circuit and everything, but in addition, it also has a blender. So I will just see if I can show you how this. Okay, so this is called the Airway 2. Again, this is also from Fisher and Paykel. This is what the device looks like. But it has some extra buttons on it, not as simple as just giving 100% oxygen. The same heater and humidifier, okay, and the same circuit connected to the patient interface. But as I mentioned, it also has a blender, so it entrains air, and so it can give you various different levels of FiO2, which can be set on the device, right? So it's not just a simple flow meter. It has some special settings that you have to make, and based on how much flow you set and how much is the FiO2 that you set, you can have various settings. As you can see, there are a lot of buttons on top of this, and I'll just come to this in a minute. Okay, so exactly the same kind of setup. The only difference that you see is that it has the various buttons. Now I'll show you what these, so if you look at this device and you look at the buttons on this, you can see that, and this is, I'm just showing you a close-up view of the setup. So I will just show you this. So first you have to, of course, switch on the monitor, and it has three settings, one of the temperature, one of the flow, and the other one of the FiO2. So when you set up this and the same way as you do the Thrive, only thing is that you have to make special settings. As I mentioned, you have temperature, you have the flow, and you have the FiO2. So you have to press both these buttons together. And once you press both these buttons together, the temperature, as you see, will flash. And then you can increase or decrease depending upon how much you want to set the temperature. And then it is locked. Then you go to the next setting, that is the flow. Okay, again, you press both and then it will flash. Once it flashes, you can either increase or decrease, and your range is 10 to 60 liters. And the same way, you can also change the FiO2. To change the FiO2, you have to alter the flow meter. So as you change the flow, the FiO2 will change. And as I mentioned here, you don't need to give 100% FiO2. You can alter it. For example, a patient comes in acute hypoxemic respiratory failure. First, I might want to give him 100% oxygen. But afterwards, once he's comfortable, I will come down on the FiO2. I need not give him 100% because this is not an apneic patient. So depending upon the saturation, you can come down on the FiO2. So this is how you said the machine is pretty much the same, but only in the one that you're using for spontaneous breathing, that's the EVO, you have the special setting of additional flow setting, which is not present in Thrive, because Thrive you are always giving 100% FiO2. Okay, so this is the first study, that is randomized controlled trial, that was comparing, a high flow nasal cannula oxygen for acute hypoxemic respiratory failure. And this was the Florali 1 study, multicentric study that was done in France. And what they found was that in patients, when they compared NIV, which was conventionally used before as a bridge before tracheal intubation, to high flow nasal cannula oxygen, the primary endpoint, they didn't find any difference. However, in a subgroup of patients who had PaO2 FiO2 ratio less than 200, they found that high flow nasal cannula oxygen was far superior to using non-invasive ventilation. And as you know, the patients in the intensive care unit, they are a high risk group. They start with a lower FRC. Okay, they already have some lung pathology, pneumonia, and ARDS, etc., and they rapidly desaturate after a muscle relaxant is given. So when you do tracheal intubation in ICU, these are high-risk patients. You have to give a little better pre-oxygenation. So not just your conventional face mask pre-oxygenation, we try to give either non-invasive ventilation, or we try to use high-flow nasal cannula oxygen. And if we're using high-flow nasal cannula oxygen, we also continue it through attempts of attempts at intubation. And this not only gives you good oxygenation, but also provides some amount of PEEP that is required in these patients who already have some lung pathology. And this is the Florali 2 study, which has compared NIV versus giving high flow nasal cannula oxygen for pre-oxygenation and continuing during attempts at tracheal intubation. These compared these two modalities that have been used in ICU. Again, in the primary endpoint, they did not find any difference. Their primary endpoint was number of episodes of saturation less than 80 during intubation. There was no difference. However, interestingly, in the subgroup of patients with PaO2 FiO2 ratio less than 200, they found non-invasive ventilation was superior to give high flow nasal cannula oxygen. And this is because you can provide more effective PEEP using non-invasive ventilation. But this is in the high-risk group. But remember that both these therapies of pre-oxygenation are superior to using just conventional oxygen therapy. And this is a very interesting study. This is a proof of concept study that comes from France, from the group of Samir Jaber. It's called the Optiniv trial. So what they've done is they've done something very interesting. This was a randomized controlled trial, and they have combined both non-invasive ventilation and high flow nasal cannula oxygen, of course, in these high-risk ICU patients that are likely to rapidly desaturate. And what they have done, in one group, they gave only non-invasive ventilation, and they had a very nice blinding technique for, and the other group, they pre-oxygenated, they used non-invasive ventilation and continued apneic oxygenation using high flow nasal cannula oxygen. So they use a combination of NIV plus apneic oxygenation with high flow nasal cannula oxygen, and they found this to be superior to using just NIV alone. Now coming to extubation. Now you can also use high flow nasal cannula oxygen during extubation, especially in the high risk patients. And this is a meta-analysis where they found that this was superior. So we extubate a patient, we give them conventional oxygen therapy. In high risk patients where you're worried, borderline cases, you're worried about a patient getting re-intubated, these patients you can actually use high flow nasal cannula oxygen as a bridge, and rather than just give conventional oxygen therapy to this. And this meta-analysis have found HFNO to be superior. So high flow nasal oxygen therapy can be used immediately post extubation to provide oxygenation, and this can be used as an alternative to conventional face mask methods. It also helps, especially even in post surgical patients, those that are major abdominothoracic surgery, high risk for atelectasis, etc. You can use it, especially in these high risk cases. And this was a review that we published along with Audrey De Jong and Jonathan Casey in Intensive Care Medicine. And this I'll very quickly summarize the applications of using non-invasive respiratory support in patients with acute respiratory failure. So the three indications are initial oxygen strategies. So this is in patients with acute hypoxemic respiratory failure. And here, high flow nasal cannula oxygen is superior to your conventional oxygen therapy. Now, whether you use NIV or high flow nasal oxygen first is still debatable, but definitely both are superior to conventional oxygen therapy. Now, this is with regard to initial oxygen strategies in patients with acute hypoxemic respiratory failure. When you're talking about tracheal intubation, if you have to pre-oxygenate in high-risk patients, that is moderate to severe hypoxemia, then NIV is superior to high-flow nasal cannula oxygen. Otherwise, both are equal. definitely you should use it during apneic oxygenation, and you use gentle mask ventilation even during RSI, because ICU patients are at a high risk for desaturation. And coming to post extubation, both NIV and high flow nasal cannula oxygen are superior to conventional oxygen therapy, especially in patients who are at high risk. So, this is a current evidence. I don't want to go through the studies on non invasive respiratory support before and after and mechanical ventilation. And you can see that this is the All India Difficult Airway guidelines that are going to be presented both for unanticipated difficult airway in adults as well as in our ICU algorithm. You can see that throughout all the steps we have talked about continuing nasal oxygen, so big emphasis on apneic oxygenation. Are there contraindications? Can you use it for all? Now, if the patient is very agitated, uncooperative, non-consenting patients, then you can't use it. But let me tell you that in comparison to non-invasive ventilation, high-flow nasal cannula oxygen is much better tolerated. In fact, people ask for it and want it because they feel a little suffocated when they use NIV mask. Procedural oxygen during high risk, because high risk of aspiration, perhaps you can not avoid this, but again that is debatable. If there's complete airway obstruction, maxillofacial trauma, or some skull base fracture, again remember, if you want the airway to work, you have to give proper positioning to the patient, and the most important thing is that the airway has to be patent. If there is any airway obstruction, this therapy will not work. And the other very important thing about high flow nasal cannula oxygen is you have to adequately pre-oxygenate. The apneic oxygenation will not work if the pre-oxygenation is not adequate. So there has to be a patent airway, and patient has to be pre-oxygenated. Thrive and therapies like this is not a rescue therapy that patient is desaturating and you just attach high flow nasal cannula oxygen, because it will not work if you have not adequately pre-oxygenated the patient. So in conclusion, I'd like to say that high flow nasal oxygen has multiple applications in anesthesia and ICU, both during spontaneous breathing and in patients under neuromuscular blockade. The most convincing evidence of this advantage of these methods is the provision of apneic oxygenation, that is Thrive, as developed by Dr. Anil Patel, where you can prolong the safe apnea time to up to almost 40 minutes to almost an hour. And very, very important that proper positioning, adequate pre-oxygenation, and patent upper airway are required for them to work optimally. Thank you very much for your attention.
Thank you, thank you, ma'am, for a wonderful session. I think uh, with many of us, there is some confusion how to use the terminology of high flow nasal cannula versus Thrive versus airway O2. So you have made it very clear. There is one question from Dr. Viswajit Jena. He says that though we are talking about HFNO and Thrive, the equipment per se may not be available at many places, maybe because of the resources and financial issues. What do you suggest? Can we use combination of 2 or 3 oxygen resources which supplies 15 liter each as a replacement of such therapies, ma'am, in a low resource setting?
Well, again, I don't understand this terminology, low resource settings, because I see that most of the most advanced equipment are available in the smallest of places. So it is about understanding the equipment, understanding the importance, and getting the equipment. So I don't think we should use this as an excuse when you see the benefit of the therapy. Again, when you're using 15 liters of oxygen, that is what we call no DSAT. That is nasal oxygen during efforts at securing a tube. That also can be used during apneic oxygenation. But the only thing about that is it's 15 liters. It's not like 30 liters. Like I mentioned, when you're using Thrive, you're using higher flows. And this is more than the peak inspiratory flow rate. So not only do you get the oxygenation and more prolongation of safe apnea time, but you also have the CO2 not rising to the same extent. Whereas with no DSAT, the disadvantage is that it can prolong your safe apnea time, say from 8 minutes to about 10 to 12 minutes. It can give you a few minutes extra, but the CO2 will rise at the same rate as when you don't, during apnea. So this doesn't give you as much benefit. So what I would say is that definitely use apneic oxygenation. Not necessary that you have to use Thrive for all patients. Even in routine cases, use pre-oxygenate well with your mask, and use a nasal cannula, simple cheap device which you can use to prolong your safe apnea time during attempts at laryngoscopy. Make this your routine. The All India Difficult Airway guidelines have recommended apneic oxygenation for all patients. But in select group of patients which you're very worried, you're going to anesthetize, give muscle relaxants, and you're really worried that you may lose the airway, then it is worth definitely using Thrive in those kind of high risk patients if resources are constrained and you cannot use it. But I would say that this is a technology that one should try to get. I know in COVID times, many hospitals have the one device that has been selling is high-flow cannula oxygen, and this has definitely avoided intubations in COVID patients. So if something can avoid intubation, and we know the complications of intubation, it is worth investing in this kind of technology. Are there any other questions? You're muted, Rakesh.
I think COVID has already made its usefulness in various ICU setup for COVID patients, and I think majority of people are. But with the data and personal experiences of all the experts, it is worth investing into it. It's cost-effective equipment. It's not so costly. Vis-a-vis, if you keep the patient on mechanical ventilation, the cost factor will be multiply more as compared to using these devices.
Right. So is there no more question? Yeah. Is there another question?
Yeah, one more question to you, ma'am. Sometimes there is a concern about in a critically ill patient about the oxygen toxicity. So do you have any concerns to say about, because people will ask giving 70 liters, any concern for oxygen toxicity, ma'am?
So again, we have to make the distinction between the flow and the FiO2. Right. So what is very interesting is that, as I mentioned, with the OptiFlow, Evo, you can give different FiO2 to this patient. So with toxicity, you're worried about the FiO2. You want to bring the FiO2 less than 60 at the earliest. So initially, we start with high FiO2, but very quickly, if the patient saturation is fine, we come down. So the concerns about oxygen toxicity are not there. Another point I want to make is that setting the FiO2 and the flow are not in parallel as you set PEEP and FiO2 in ICU patients. So your FiO2, of course, you start initially with high FiO2, 100%, but your flow, you start at 30, and you go on increasing the flow as the patient tolerates. Again, the flow depends upon the work of breathing. So you look at the patient, how comfortable he is. If he's on quite comfortable, you can keep the flow a little lower, and the FiO2 you set independently depending upon the saturation. So if my patient is maintaining above 90 saturation, I don't keep the FiO2 so high. I would come down even to 30 of FiO2. So it doesn't move in parallel. And as you rightly said, because of concerns of oxygen toxicity, we try to get the FiO2 less than under 60 at the earliest using the Evo device.
Thank you so much, ma'am, for clarifying. Any more questions from
Rakesh, Dr. Apex here. So regarding this oxygen toxicity, in most of the cases, most of the people are not using 100% oxygen just because there are higher chances of absorption atelectasis, and which can lead to the consequences of this thing. So when you are using high flow nasal oxygen with the closed mouth, is going to generate 4 to 7 centimeter of H2O CPAP, and which keep the alveoli open. So in such way, it's already decreasing the chances of oxygen toxicity.
Yeah, I think that's a very important point. I missed saying that in the ICU patient, you are really concerned about this atelectasis. In the operating room, when you're using it as Thrive, you're using it only till the tube goes in, which is very quickly. So you're not worried about giving that 100% FiO2.
So I think message which
benefits
ma'am,
are far better. Yeah,
Dr. Pik, using it for difficult airway management, high flows, we are not concerned about oxygen toxicity at all.
Yeah.
Because oxygen toxicity will take 24 hours to start with.
The benefits far exceed the risks.
Yes.
Far exceed. So for difficult airway management, be very clear, use high flows where you having any doubt about the airway management. For critical care setup, as Dr. Apeksha and Sheila was also already clarifying, that we have the option of decreasing the FI for these patients, and definitely once the patient is getting stabilized or optimized, we can obviously come down with the FI and titrate accordingly. So definitely the beneficial effects of using this therapy are much higher than the possibility of say atelectasis, the possibility of say some amount of oxygen toxicity is much less, and they are manageable to a large extent. So that's the big issue.
Right. If there are any more questions, or I think we will just wind up in the interest of time.
Thank you, ma'am.
Thank you so much. Thank you, Dr. Rakesh. And I'll move on to our next speaker. The next talk is going to be on video laryngoscopy. And I have already introduced Dr. Amit Shah. As I mentioned, he's someone, they are developing their own video laryngoscope, and he's an expert in this technology. So no one better to speak to you than Dr. Amit Shah. So over to you, Dr. Amit Shah.
Thank you, Dr. Rekha and Dr. Nivedita, for giving AIDA this opportunity, and thank you, Dr. Sheila, for keeping me part of this team. I'll be speaking about video laryngoscopy. tips and tricks. So, as Dr. Sheila has already mentioned, we have developed Patwas eye video laryngoscopes, and we expressed here are our personal experience and belief. And we are not here to compare device with our device. Now, this is our laryngoscopy goal. As soon as we do direct laryngoscopy, video laryngoscopy, whatever we do, the moment we have a good view of larynx, that is what gives us sort of final satisfaction, and then tube insertion is almost certain. How our laryngoscopy achieves this? We try to give sniffing position. And how sniffing position achieve this is what we have so far understood, that oral, pharyngeal and laryngeal axes are coming together in sniffing position. And that is what we have been taught, we have understood so far. But Ednet contested this. He said that during sniffing position, these three axes are never matching, and this is anatomical myth. And he also did this in unanesthetized patient and later on in anesthetized patient. So the question still remains: how sniffing positions improve our axis if it is not matching the three axes? So Dr. Keith Greenland gave a two-curve theory. What he said, there are two curves: primary curve, that is oropharyngeal curve, and second laryngeotracheal curve, that is secondary curve. And by giving sniffing position, you reduce the upturned these two axes, and then only part remains is the tongue, which you have to take away with the help of a direct laryngoscope blade. Now, whatever you do, how good sniffing position you give, you many times ends up in such a situation. But from this situation, what are the rate of failure? We don't fail many times in spite of achieving this, and we try to achieve intubation after such a view is with the help of multiple attempts, a senior coming in, use of aids like bougie and manipulation and multiple attempts. Is this an ideal situation? No, this is not an ideal situation. This is considered near miss. So the anesthesiologists started thinking how to avoid this near miss situation. And if you look at this Keith Greenland theory, the only part which comes in our way after giving sniffing position is a tongue. If you don't have tongue, obviously we won't have any problem and we can see directly inside. But obviously, fortunately and unfortunately, tongue has a lot of important functions and we cannot avoid tongue. So what we can do? Instead of looking from outside, if we can take our eyes beyond curvature of tongue, then situation changes. We overcome the primary curve, you look at the secondary curve, you don't need to align any axis, proper position is not mandatory, force may not be necessary, and you have a fantastic large field of view. When you do direct laryngoscopy, you see a very small area. But when you if you go beyond curvature of tongue and look inside, you see entire larynx and there is a large field of view. So device which looks around curvature of tongue is called indirect laryngoscope. And when you replace this with a camera, it is called a video laryngoscope. So video laryngoscope by definition is a device wherein a video camera is used in place of line of sight visualization to accomplish endotracheal intubation. Either you can use CCD camera, CMOS camera, there are many technologies. With direct laryngoscopy, our options were limited. We don't have to think much. We just have to look at the Macintosh blade, maybe a McCoy blade now, or sometimes in a pediatric patient, we used to look at the Miller blade. But with video laryngoscopy, options are multiple. There are many, many types of device. So in this lecture, what we'll try to do is to we'll try to differentiate them. We'll try to classify them because there are so many devices. And then we'll try to learn how to optimize intubation with each type of device. Now, if you have seen closely video laryngoscope devices, the blade part, which is the most important part, has almost all type of devices have slightly different shape and angle. So the device, the part which goes inside, which is called blade, has different shape and angles, and each device has its own characteristic. So on the basis of shape which has been made, we can make three generalizations. The first type of device which was to be introduced, first device which was introduced by John Pacey was glide scope. And what he designed was a device for so-called the anterior larynx where we were facing the difficulty. So tip of such device almost points towards vallecula, and we can call them anatomically curved. That is, this is anatomically curved device, but hyperangulated. Then we realized that there are a lot of intubation problems with those, and we wanted to introduce a channel into it. And to introduce channel, then the next type of device which were invented was a anatomically curved but less angulated. So this device tip actually points towards larynx rather than a vallecula. So they were less angulated compared to the hyperangulated device. And of course, later on, it was always going to happen that the Macintosh camera lights were replaced with the camera, and you have a Macintosh type of a device which is not anatomically curved, and you can call it Macintosh type of a design. So on the whole, we can identify this video laryngoscope device into two types of device. One is anatomically curved. It could be angulated, or it could be hyperangulated device. While the second variety would be non-anatomically curved, and their majority of them are Macintosh type of a device. The more conventional video laryngoscope classifications which you see in the textbook and the literature is like this. The classification is based on the way you intubate these patients. One is non-channel. Second would be channel, where there is a dedicated channel for the passage or the passage of the endotracheal tube. And when you railroad the endotracheal tube over a device, that is a video stimulator. Now, non-channel would be again two types: hyperangulated and Macintosh type. While channel we already know, and the video stimulator, there are many versions. Earlier, they were not considered part of a video laryngoscope classification, but now they are part of a video laryngoscope classification. So we'll look at these three devices: hyperangulated blade, channel anatomically shaped device, and the Macintosh type of a device. Now, to understand and optimize intubation with video laryngoscope, you have to further understand three things. One is what is angle of blade, which we already see, direction of camera or angle of vision, in which direction the camera is looking, and what is the area which is visualized. So we already seen the angle of blade. It could be angulated, anatomically shaped. It could be anatomically shaped but hyperangulated, and then the Macintosh type. The camera placement is slightly different in each type of device. In anatomically shaped, less angulated device, camera is looking actually straight, because they look in the direction where tube trajectory. So they are more or less looking straight towards larynx. Well, in case of hyperangulated device, they are slightly nearer and they look up towards larynx. So they are looking up towards larynx versus anatomically shaped, less angulated device, which is channel devices, where it looks straight. And of course, in Macintosh type of a devices, it looks straight, but when we introduce Macintosh blade into the oral cavity, we usually look down. Also, what is the area which is visualized is also very, very important. One type of camera, because each device has a different type of camera, and each camera, as we know, in our mobile phones, there could be 50 megapixel camera, there could be 5 megapixel camera. So how much area visualized is also important. That is called field of vision. Some camera might be showing you an entire picture of oral cavity, including larynx, while in other case, very small area is seen and you might be seeing only larynx. Now, how it is important? I'll just show you a video here. If you see this video, this is quite wide vision. So here in this wide vision, endotracheal tube takes a small part of it. There is a lot of area seen surrounding this. And when you pass tube, if tube goes not in the direction of larynx, you know where exactly it is going. And then maneuvering becomes very, very easy. Versus second video laryngoscope device, where larynx is seen beautifully. Larynx is entirely seen, but you don't see any other structure surrounding that. Now, when you have such a device where endotracheal tubes take a lot of part of a screen, if it goes out of your picture, it becomes very difficult for you to maneuver. So it is very much essential that you always look at the field of vision which is seen with the video laryngoscope device. Also, one more problem with the video laryngoscope device is that earlier we were looking in the direction of the oral cavity and the larynx and then intubating there. Now the screen is somewhere else and we have to look somewhere else and then intubate in the oral cavity. So we have to develop hand-eye coordination when we have to learn this. So in next segment, what we'll do is try to, on the basis of differentiation we have made, how to optimize our intubation condition. So first we'll look at the non-channel hyperangulated blade. They are there with the glide scope. CMAC has a special blade called D blade, and McGrath has X blade. And majority of now other available video laryngoscope may have one or other blade which is hyperangulated. Now, what does it? How does it perform the intubation, or how do we perform the intubation with anatomically shaped hyperangulated non-channel blade? We already seen the tip looks towards almost towards vallecula. Camera looks up. So when you are looking from down to up, epiglottis will not block your view, and your need for force is almost minimum. So you just introduce device, put it in proper place, and then you see a wonderful view of a larynx. So your requirement of force is minimum with such blade. Problem is that this is hyperangulated shape, and our conventional PVC endotracheal tube is not shaped like that. So if you try to do it even in mannequin without stellate, try this in mannequin when you try to introduce such devices and then try to put tube will always go into esophagus because it is not shaped like hyperangulated one. So what you need to do? You need to change the shape of endotracheal tube with the help of a stellate. Majority of the device has supplied their own stellate with the device. This is because each has a different angle, and according to their own angle, they have supplied their stellate. If you don't have one, what you can do is to change the shape of endotracheal tube with the help of stellate according to the curvature of your blade. Whatever curvature, you change the shape according to that curvature, and then when you intubate, the tip of endotracheal tube will go where the vision is. So once we have given hyperangulated shape and then the tube reaches larynx, that is where we have another problem. When you advance it beyond vocal cord, it will go and hit anterior tracheal because it is hyperangulated. So it will go and impinge on the anterior tracheal wall. If you force, it will go in, but it may create trauma, or it may not go inside at all. So at this point, once you enter into vocal cord, what you need to do is to withdraw or hold the stellate at larynx and only advance endotracheal tube. You cannot advance endotracheal tube with the stellate, which is a conventional technique when we do direct laryngoscopy. When we are doing direct laryngoscopy, if you are using stellated endotracheal tube, we'll insert both together, and when it goes into the trachea, then only we'll try to pull out the stellate. But here you cannot allow endotracheal tube with stellate to go in. What you need to do is to hold the stellate at the laryngeal opening. This is CMAC D blade. You get a wonderful view of larynx without much of the force. And when you introduce endotracheal tube inside oral cavity while looking inside, once it goes at the laryngeal opening, observe my finger movement. I am holding stellate there and I am allowing only endotracheal tube to go in. This is necessary, otherwise you will have impingement or trauma. What position of the head? The sniffing position for direct laryngoscopy works well. Here for the angulated blade, that is anatomically shaped hyperangulated or channel video laryngoscope blade, sniffing may not work well. This article was published for the hyperangulated blade, but similar situation also happens with the angulated or anatomically shaped blade. So your neutral or ramped up is okay, but sniffing may give you a more difficulty. It can be an independent predictor of difficulty. So again, coming back to the main important points of anatomically shaped hyperangulated non-channel blade, it looks up towards larynx. Epiglottis will not block your view and need for force will be minimum. You need specially shaped stellate to reach there. And when you advance this specially angled tube beyond larynx, you will hit the anterior tracheal wall. So you need to hold or withdraw the stellate at the larynx and advance only endotracheal. Now the second type of a device, anatomically shaped but less angulated, and majority of them are channel video laryngoscope. So channel video laryngoscope has a dedicated slot, and there are many versions available, King Vision, Pentec and AirTrack devices, which are having dedicated slot for the endotracheal tube. They are already less angulated and they look straight towards larynx. So majority time epiglottis will come in your view and may partially block your view. So you need to use some amount of force to lift the epiglottis. So always you have to lift it to take epiglottis away, then your vision will improve. Since there is a dedicated slot of endotracheal tube, when you push endotracheal tube through that slot, it will go towards your view. And if the if glottis and your view are aligned, then endotracheal tube will go past beyond glottis into trachea without any difficulty. So you don't need to do any further maneuver if your endotracheal tube is going towards glottic opening. But problem comes if it does not go towards glottic opening. Because tube tracks and view axis are connected, if it is not going in that direction, you may need to do something to alter direction of endotracheal tube. Either you need to do something with the endotracheal tube or with the device. What are the maneuvers which you can perform is, now if you look at carefully here, as endotracheal tube is coming out of the slot, initially the direction is on the lower side. Now, if your vocal cords are too close to your blade, then what will happen? It will hit the interarytenoid membrane. So if you are too close to the larynx, then you are likely to face difficulty and you need to go little away. And after going little away, you lift the entire blade of your video laryngoscope so that when tube goes further, it goes up towards laryngeal opening. So lifting and slight withdrawal is needed if you are too close to the glottis. Also, if your tube trajectory is not matching with the glottic opening, you can do side-to-side movement of your video laryngoscope device. When you do side-to-side movement of video laryngoscope device, the tube trajectory will match the glottic opening and then you can push the tube further. It has been also found that since the tube slot is on the right side, right aryepiglottic fold impingement, that means when you introduce tube inside, it will go and hit the right aryepiglottic fold. That is one of very common impingement site. And to overcome that, what you can do is to twist the tube as you are passing it into the slot. When you twist it to the counterclockwise, what will happen? The tube trajectory will, instead of going in the center or straight, it will go towards left. And that is how you can overcome the right aryepiglottic fold impingement, which is one of very common impingement when you use channel video laryngoscope. So rotating or twisting clockwise or counterclockwise if you are hitting the opposite side while advancing. So all in all, you need to lift up. You may require slight withdrawal or side-to-side movement of a video laryngoscope blade, or you may need to rotate or twist the endotracheal tube while you are advancing in the channel. So when we compare these two anatomically shaped device, both device needs to be introduced from center of mouth. New users may find it difficult in insertion because we are introducing from the center, while for our regular habit is to introduce from the angle of mouth. Sniffing may lead to difficulty in intubation. Anatomically hyperangulated device gives better visualization without any force, while in case of anatomically shaped channel video laryngoscopes, you may require slight force to elevate epiglottis. In case of hyperangulated device, you need pre-shaped stellate, and you require to hold the stellate while you are passing it beyond vocal cord, so it may take slightly longer intubation time. While in case of anatomically shaped channel video laryngoscope, do not require stellate, and intubation time is almost comparable to direct laryngoscopy. Anatomically shaped hyperangulated non-channel video laryngoscope, there are chances of risk of pharyngeal injury as passage of endotracheal tube with the stellate is blind if you are not very careful and if you are not carefully observing that entire passage. While that chances of pharyngeal injury are less with the anatomically shaped channel video laryngoscope. Now the third variety, that is a Macintosh type of a device. There are many devices available which are currently available in the market, which are like CMAC, GlideScope Mac, McGrath Mac, and UE Scope, and there are many other devices. Now there are they are like a conventional Macintosh laryngoscopy. So you may or may not require stellate. The device can be introduced from angle of mouth and may require to displace the tongue laterally to see the larynx. So procedure pressure and displacement are almost similar to conventional laryngoscopy. So this is a very good for the teaching, because if you are given this device to a novice and he is asked to intubate directly by looking inside as a direct laryngoscopy, while teacher can observe what is happening on the screen. But its role in the difficult airway is still questionable, because you still require to give that much pressure and your difficulty may be there. Here I'm trying to perform a direct laryngoscopy with the help of Macintosh type of a video. This is CMAC video laryngoscope. When you routinely see a good picture, you can directly introduce endotracheal tube without stellate also. So you may or may not require stellate. Conventionally, it has been identified that bougie is of less help in a video laryngoscopy. So bougie may not be that much helpful as it is there in the direct laryngoscopy. But in our personal experience, this is another type of a video laryngoscope which is very commonly available. There are many type of such devices. This is a Macintosh type of device. And here I'm trying to use bougie, and it is only my personal experience, not much of evidence is there, but we can use bougie in such a situation. If you see here, it is grade 2A view, and here I was not able to introduce endotracheal tube, but I could use bougie. So bougie can be used in similar situations, but not routinely. So 10 important rules for a video laryngoscopy are: first, earlier with the direct laryngoscopy, we are just checking the device. Here you have to check device, you have to look for the battery charging, and you have to ensure that anti-fogging mechanism is working well. Angle or channel blade video laryngoscope device are introduced from the center of oral cavity. Sniffing position may not be mandatory, and neutral may be helpful, especially in the anatomically shaped device. Whenever you are introducing something into the oral cavity, either a blade or endotracheal tube, in case of stellated endotracheal tube with hyperangulated blade, you always look inside oral cavity. Otherwise, if you go blindly, there are chances of injury to the pharyngeal structure. So whenever you introduce something inside oral cavity, you look inside oral cavity, not on the screen. Excuse me. Experience with standard Macintosh laryngoscope does not equate to the skill with a video laryngoscope. Experience with one type of video laryngoscope does not equal skill with the other video laryngoscope. And good view of larynx does not mean that you will always intubate easily. You may have difficulty in passage of endotracheal tube. Bougie may not be solution when there is a difficulty, as it was there with the direct laryngoscopy. And video laryngoscope chosen must be selected according to the indications. Now we can generalize these three, these devices into three sort of indications. One is when there is a situation of rescue or anticipated difficult airway. I think hyperangulate anatomically shaped device or hyperangulated blade will work well. For a routine new users, the Macintosh type of device is really helpful because you are already experienced with the direct laryngoscopy. And with little experience, you can use less angulated device, anatomically shaped, that is channel video laryngoscope. But if there is blood in the airway and you may have to look directly inside if nothing is visible on the screen, then only Macintosh type of device will work. So this is all about three general type of a video laryngoscope device. And I think this is now open for any queries or questions.
Thank you very much, Dr. Amit. Who better to steer this discussion than Dr. Apesh Patwa, who's another expert in video laryngoscopy. Over to you, Dr. Apesh.
Thank you, Amit. It was an excellent deliberation of the video laryngoscopy. But most of the department, if you look at most of the department of anesthesia, they are having either one type or max two type of video laryngoscope in their department. Once the PG who has been trained in these two type of devices, and when they go out and they have been handed over the another video laryngoscope device, do they require specific type of training with the another video laryngoscopic device?
Yeah, in the sense, not exactly specific type of a training, but you should know the basics. And you require, there's some learning curve. So you cannot say that, okay, I am okay with the CMAC Macintosh type of device, and tomorrow if I am given a channel video laryngoscope, I'll straight away intubate easily with the channel video laryngoscope. You have to understand the basics of these video laryngoscope devices, and then you have to have some learning experience. You straight away cannot say that, okay, I'm good with CMAC Macintosh device, so I'll be good with the channel video laryngoscope device, because it is a different requirement.
Yeah. So the same type of question, Amit. Suppose someone is passing out from the one institute and they want to purchase one video laryngoscope. Which one they should buy?
You said it is from the institute.
No, they are going. See, they have passed out from the institute. They are now going for a practice or going in the corporate, and they wanted to purchase their own video laryngoscope. Which one they should use?
Many considerations while choosing a video laryngoscope device. If you are facing many difficult airway, then I'll probably choose a hyperangulated blade, because that is where it is more indicated. If I'm performing routine type of intubation more often, then I'll probably go for a device which has a Macintosh type of a device, and maybe provision of hyperangulated blade should be there in that part of that type of device. So it is very difficult to make generalization that, okay, one device will actually help me. That is a very difficult situation, and it is not possible to do that. So you have to decide depending upon your practice and what situations you are likely to face.
Dr. Amit, if I may ask, if you permit me, Apeksha, so you showed devices with the screen on the handle and screen away. So what is preferred and what is better?
Again, it depends upon the experience which you have, but gradually the evidences are building up for the devices where the screen is in front of you on the device. Earlier, the first device which was made was a glide scope, and the screen was somewhere separate. Then, in fact, CMAC device also had a screen which was separate, which was available earlier. But now gradually all devices are coming where they have a screen directly attached on the device. So while you are going inside, you have a screen right in front of you. So you don't have to change your view that often. So screen right in front above the device is more preferable compared to screen which is separate.
Also makes it more portable, right? Especially
more portable.
in a field area. Yeah.
Yeah, Amit, one more queries from many of the clinicians. So suppose they are using the video laryngoscope as a first attempt of intubation and they fail. Should they change over to conventional laryngoscopy, or should they use the second type of video laryngoscope?
Now, majority place, I don't think that second type of video laryngoscope will be available. We cannot say that, okay, once we have failed with video laryngoscopy, we are always going to fail with direct laryngoscopy. I don't think that is the correct answer. You can always attempt if you are good with a direct laryngoscopy, number one, and number two, you feel that, okay, this is going to help me. So it's not necessary that once you are failed with video laryngoscopy, you cannot attempt direct laryngoscopy. There are many instances where you are facing difficulty of video laryngoscopy because of different reasons, right? Your blade was not appropriate, your tube was not going in. While direct laryngoscopy, you may be able to perform intubation. So if you are within those 3 attempts, you should change the device. You have to have
the operator, because I think there's a learning curve even to video laryngoscope. So you have to be experienced with the tool. Just having a video laryngoscope will not help you overcome difficult airway. And one question to you, Dr. Amit, is about the bougie versus the stillet, because as far as possible, people recommend not to use the bougie with the video laryngoscope. Is this because it's a floppy device? So unlike a stillet, which is more stiff, so more likely because your line of sight, I mean, the curvature and the axis in which the tube is going and the camera is not at the same axis. Is that the reason for this?
Yeah. So still, bougie, since it is not having a fixed shape, it is floppy type of device. When you try to introduce, it will not go towards larynx, especially in a hyperangulated device. Hyperangulated device and also angulated channel video laryngoscope device. It will be difficult for you to push it towards larynx. But with Macintosh type of device, now there are some studies also which have come up where they have used the bougie effectively. So bougie can be probably, as from my experience of these 3 types of video laryngoscope, bougie can be used with Macintosh type of devices, but cannot be used with hyperangulated device for sure. And you may have some difficulty if you are using channel video laryngoscope.
I think this is a very important point because I've seen people having an excellent glottic view with a hyperangulated blade, trying to pass the bougie and not being able to pass the bougie. So this is a reason where a stillet is
More
preferred.
important in hyperangulated.
Yeah, especially in hyperangulated.
Amit, one last
can I-
question.
Okay.
Yes, Mohit, Dr. Mohit.
I just wanted to add to what Amit was saying. One is, as you said, as Sheila was asking regarding the monitor which is right in front of you. Actually, this improves your coordination. Most importantly, because you need an eye-hand coordination when you talk about video laryngoscope. But when it is right in front of you on the handle, the monitor is on the handle. Probably the coordination is much more better and easier and faster. First. But then the disadvantage is in certain situations where you think, especially in this COVID era, when you think that your face should not be as close to the patient's face, probably in that situations, the monitors would be better, which is separate from the handle. I mean, that would be advisable. That adds to your safety.
Also,
the other thing which I would,
resolution of
the other thing which I would say, the other thing which I would like to ask Amit is, so depending upon your discussion and your suggestion and your advice as well, would you like to ask your residents to go ahead with the video laryngoscope and forget about direct laryngoscopy?
I'll tell you, because at my institute for the fellowship of advanced and difficult airway, we use 100% video laryngoscope. But I don't think that it is direct laryngoscopy is a skill which you were ready to forget. And as a postgraduate residents, I think they should learn direct laryngoscopy. That is for sure. I think we should not forget direct laryngoscopy while we have started doing video laryngoscopy. Video laryngoscopy is the future, but they should know both. I don't think that we should ask them to forget about direct laryngoscopy.
The first training should be on, I think, direct laryngoscopy. Subsequently, they can adapt the technique of video laryngoscopy, but without direct laryngoscopy
will help, because Macintosh type of a device will allow them to do direct laryngoscopy while you are actually looking at the screen. The teacher is looking at the screen while the resident is performing. Gradually, he can change over. Gradually, we can ask them to look at the screen, but first they have to look inside on the direct laryngoscopy.
Dr. Mohit, just last question from the audience. How to ensure 100% sterilization of video laryngoscopy in COVID era? Before you give the answer, I am having few queries. I am having one, what Dr. Mohit has said. I think you can go ahead with the answer, then I'll
nowadays we have that disposable blade. So that is one thing which you need to use disposable blade for video laryngoscopy. You cannot use the same blade. So that is, especially in Macintosh, CMAC video laryngoscope, you would always, but then CMAC can be autoclaved. CMAC can be autoclaved. So that is the advantage with it. So you can use that CMAC blade, but other blades like King's Vision, there it is a disposable, so that can be used. But the other handle component and the monitor component needs to be autoclaved as well, or it needs to be Sidexed. So these are the things which probably I don't know exactly what has to be taken care of, but this is how you can go ahead with it.
Yeah, Dr. Mohit, I agree with you, but I am having a different opinion related to the first previous question answer session. I am not agreeing with you. You should have all PGs should have first training in the direct laryngoscopy. I have a different opinion. Ideally, they should have complete training in video laryngoscopy, then they start with the direct laryngoscopy.
Dr. Pesh, I just like to add to that. So if you just go by the evidence, today the evidence in operating room, not in the ICU, in the operating room is very clear that video laryngoscopy is far superior to direct laryngoscopy, even for routine airway management, not only for difficult airway management. And like you said, you may have different tools, but the hand-eye coordination is something that needs to be practiced and learned. So even if you use a different device, training the resident with this hand-eye coordination is very important. And if you see the new trainees, we have learned with direct laryngoscope and then moved to VL. They are so familiar with it. If you give them a choice, they want to use that first. It is like, do you know a cardiologist who would treat mitral stenosis today just by oscillation? So they have moved to, no one will make a diagnosis. So why are we using the same tools, Macintosh and McGill's of 43 and 45? Why are we not moving away from direct laryngoscopy? So I think unless you replace, and I think Dr. Amit made a very good point, when you have a kind of blade which is a Macintosh blade, where you can do direct laryngoscopy. So you can teach your trainee to do direct laryngoscopy while you can observe, monitor. So it is safe. You don't have to keep on looking into the mouth to guide the trainee. And at the same time, you can also teach him video laryngoscopy. So I think the era has come where, yes, while you might do direct laryngoscopy, we should be more proactive and try. All our trainees should be trained in using video laryngoscopy, so that definitely, if not routinely, during a difficult airway management, it is not the first time that they are using the device.
Thank you. I think we should move to the another topic now.
So thank you very much, Dr. Amit. Your talk was excellent, and you covered most of the kind of queries, and you gave us a lot of tips for troubleshooting. And thank you, Dr. Apesh, for giving all these kind of, nudging him with all these controversial kind of statements. And our next speaker is none other than Dr. Apesh, who's going to be talking to us about flexible bronchoscopy. And to moderate the session with him is Dr. Moid. So over to you. Looking forward to an interesting discussion.
Thank you, Team ODISHA, Dr. Sheila, for giving me this platform to share my knowledge. I think so. I'm going to talk on flexible endoscopic intubation, preparation to intubation. But because of this time concern, I'm mainly going to focus on the technical part rather than a preparation part. So ideal word to be used in fiber optic intubation, it should be flexible endoscopic intubation, because there are a number of technologies involved in the flexible endoscopic. So one of them is the fiber optic scope. So usually with skill hand, fiber optic or flexible endoscopic intubation takes 55 to 65 seconds to finish the procedure. But to finish within this time frame, you should have proper technical preparations, proper coordination of the staff, technical knowledge of using equipment, and over and above that, patients should be comfortable and cooperative. So always, before starting procedure, always explain the need of procedure into his or her case. Take the patient into confidence. If required, make judicial use of sedations and then proceed. This will decrease the troubles and increase the success rate of the fiber optic intubation. And we'll go in different way. We'll think what are the troubles we can get during the actual fiber optic or flexible endoscopic intubation and how to solve it. So what are the stages where we can get the troubles? First, during the preparation of equipment, handling and instrumentation of the procedure leads to many troubles, but I'm not going to focus on that because of time constraints. Another trouble we can get is problems or troubles related to actual endoscopy and troubles related to passage of the endotracheal tube and placement of the endotracheal tube. So I'm going to focus more on the troubles related to endoscopy, passage of the endotracheal tube, and placement of the endotracheal tube with the flexible endoscopic intubation. Usually, awake nasal fiber optic or flexible endoscopic intubation are having 4 steps. First, from nasal passage to oral passage. From nasal passage to larynx or larynx, second step from larynx to subglottic area. Third, from subglottic area to carina. And step 4 is railroading of the tube, that is the passage of the endotracheal tube. So if you think, okay, which type of trouble you can get during the first step, means you are passing the scope from the nose to the larynx. Suppose you are not getting the proper adequate size of the adequate passage in the nasal cavity, means narrow nasal passage. After introducing the scope, you are not able to identify the anatomical landmark. You can get lost, not able to identify, in spite of yourself is having the oral cavity, you are not able to identify the glue stick structure. Bleeding, excessive secretions. These are the troubles you can get during the first step. How to overcome these troubles? Always check the nasal patency before proceeding for a flexible endoscopic intubation. There are a number of ways. And if you are in availability of the head and neck scan, check the patency in the scan and go ahead. And usually, according to these publications, there are 2 passages, nasal passage for the flexible endoscopic intubation. One passage inferior to inferior turbinate and second passage superior to inferior turbinate. Always select the passage inferior to inferior turbinate because it's having a larger space and there are less chances of trauma and less chances of transmitting bacterial mucosal flora from nose to the larynx if you use passage inferior to inferior turbinate. And to go inferior to inferior turbinate, you need to pass your endoscope perpendicular to face plane. So right direction of introduction of the flexible endoscope is perpendicular to face plane into the nasal cavity like this. It should not be cephalad. So look at, as I am approaching towards the oropharynx through the nasopharynx, my scope is perpendicular to face plane and flush to the floor of nose. So it's giving surety that your scope is inferior to inferior turbinate. So another troubles during the first step cannot identify the anatomical structure because of not having appropriate knowledge of endoscopic anatomy. Because of secretion or because of some technical issue or because of bleeding, you can get lost during the scopy in oropharynx. So how to overcome that? For that, you need to have proper endoscopic anatomical knowledge once you enter in the nasopharynx and at the level of the mid nasopharynx. So how to precisely identify the structure when you are doing endoscopy? For that, suppose this is a patient just in front of me and there is a cut section. So this is the left nostril, this is the inferior turbinate, this is the middle turbinate, this is the superior turbinate. And if you look, the passage is like, air passage is like this L. And if you look at the right side, this is the inferior turbinate, this one is middle turbinate, and this one is superior turbinate. And passage is like mirror image of L shape. So if you look at the air passage in nasal cavity or nasopharynx, is like L, and the base of L is at 6 o'clock position when you are doing the scopy from the front of the patient. And when always base of L, if it is towards left, there is a left nostril, and when base of L is towards right, then it's the right nostril. Now suppose you are doing or performing the scopy from the head end. So now you are doing the scopy from head end. So you'll get the base of L at 12 o'clock position. And you'll get the base of L is towards right, means you are doing from the right. And base of L is towards left, means you are doing from the left. Now suppose, say each endoscope is having their own field of vision. Suppose you are passing the scope inferior to inferior. This is the scope inferior to inferior. Is having its own field of vision. So you will be going to get the vision of this much of area when you make entry of the scope into the nasopharynx, and you will get the huge protuberance on left side when you are entering the scope on the left side. And the passage of air passage will be like inverted L, and base of L is towards the left side. This is how you should be able to identify your entry, which nostril you are passing the scope. And if you are passing the right side, the base of L is towards the right, and you will get the huge protuberance of the inferior turbinate on right side. Just have a look on the endoscopic video. Look, here, this is the inverted L, and base of L is towards left, and this is the huge protuberance of the inferior turbinate towards the left. So I am passing the scope from left nostril. This is how you should be able to identify the anatomy. Now, let's have another video. Here, look at this. The base of L is at the top, and base of L is towards right. Means I am passing the scope from the right nostril, and you will get the huge protuberance of inferior turbinate on the right side if you are passing your scope inferior to inferior turbinate. So this is how you should be able to identify the nasopharynx and inferior turbinate. And this is very clear. Which area I am going to? I am going inferior to inferior turbinate, and inferior turbinate is towards my right. So I am passing from the right nostril. So at the same way, when you are entering into oropharynx from the nasopharynx, you should be able to identify your entry from nasopharynx to oropharynx. So if you measure the length from ala of the nose to tragus, and if you insert the scope perpendicular to the face plane into the nasopharynx, and if you just bend the tip 30 to 40 degree, you'll get the view of epiglottis. Another way of identifying your entry into the oropharynx, see, nasal passage is a slit-like structure. And when this slit-like structure converted into horizontal oval-shaped opening, that is your entry into the oropharynx from the nasopharynx. Look at here. As I'm passing my scope through the naropharynx, it's a slit-like structure. Gradually it converts into oval-shaped opening. That is your entry into the oropharynx. And at the top, at the 12 o'clock position, if patient is awake, you will get the uvular movement. That is your entry into the this. Look at this. Here you will get the uvular movement. So this is entry into the oropharynx from the nasopharynx. Another way of identifying the air passage is by color perceptions. How many colors are you able to pursue in this video? Usually you are able to pursue 3 colors. One, pink, second, white, and third, black. The pink color represents tissue. White color represents reflection of light from the tissue. And black color is your air passage. So when you get more white color, it suggests that you are more near to tissue. Get away from the tissue. And follow the black. So if you blindly follow the black, you will be in the air passage only. So just keep your eye on this cursor. I'm just following the black in this video. I'll be automatically in the larynx. So I'm following the darkest black. So I'm for this oval shape opening, entering into the oropharynx. Again, I'm going towards the black. So now, which one is the darkest black? Is here. So I'm going towards that area. Which one is darkest? So you will be automatically in the cord. So follow the black in case of trouble. So another troubles you can get during this phase is excessive secretions. So do not advance your scope when your vision get obscured by the secretions. Wait, do thorough suctioning, make the visor clear, identify the anatomy, and then go ahead. So there are a number of ways you can suck out the secretions. You can suck out through the instrument channel, from the opposite nails through a nasal catheter, or from the oral cavity. And if patient is awake, ask the patient to swallow the secretions. It will be the easiest way. He will be able to clear all the secretions and then identify the anatomy and proceed for the flexible endoscopic intubation. So this is one of the video we have taken with the secretions. So this is how secretion obscure the vision. Just suck it out, make the clear vision, and then proceed. So now coming to the second step, means from the larynx to subglottic area. This will be a little bit tricky step because see, trachea is usually placed anteriorly, and you are passing the scope parallel to posterior pharyngeal wall. So as you are approaching toward the trachea, you need to flex your tip down. So maneuvering of the scope is required. Sedations create its own problem during this step. As you are much nearer to the airway, there are higher chances of fogging, laryngoscopasm, coughing. So we'll discuss it one by one how to overcome these problems. So as discussed, you are passing the scope from the nasopharynx parallel to posterior pharyngeal wall. And larynx is placed anteriorly. And to make entry into the larynx, you need to flex your tip down to visualize the larynx and visualize the tracheal rings once you make entry into the vocal cord. Look at in this video. As I'm approaching towards the vocal cord, I'm flexing my tip down to make entry into the vocal cord. And after making entry into the vocal cord, again, my tip is going down. And do not advance
tube once your tip is just entered into the vocal cord. Advance your tip to visualize the carina, then and then slide your tube. Otherwise, there are higher chances of accidental removal of your tip of the endoscope from the vocal cord. Another problem during this second step is fogging. And fogging again obscure your vision. You will not get the clear-cut anatomical appreciation. So how to overcome fogging? Just insufflation of oxygen to the instrument channel clears the fog. Or if you are expert, you can make the tip touch with your tissue, wipe out the fog, and then proceed. This is the way to clear the fog. And CPAP and high flow nasal oxygenation during fiber optic or flexible endoscopic intubation, it prevents the fogging, it generates the space because it generates the CPAP, and it maintains the oxygenation. So if there is availability of HFNO, always use high flow nasal oxygen along with the flexible endoscopic intubation. So how even a sedation creates a problem? According to this way back 1994 publication, there are three narrowest portions of the upper airway: retropalatal space, retroglossal space, and retroepiglottic space. And this space, even with the sedation, minimal sedation, decreases its diameter. Look at this. In awake state and asleep state, there are MRI. In asleep state, there is significant narrowing. There is a no space, no retropalatal space. And CD is a retroglossal space. Still, there is a significant narrowing in asleep state and significant narrowing in retroepiglottic space in asleep state. So, and this is the video we have taken in our clinical practice. Look at this. This awake FOI, epiglottis is lifted up. And in asleep FOI, epiglottis wall is touching the posterior pharyngeal wall, minimize the anterior-posterior depth of the pharynx, which creates the difficulty in negotiating, advancing the scope towards the larynx. So coming to the step 3. So trachea is not a straight tube. It travels downwards, posteriorly, and towards right as it approaches the carina. So when you are passing the scope into the trachea, many times it automatically shifted towards right because trachea is shifted towards the right in most of the cases. And many times you get significant bulge or significant decrease in the anteroposterior depth of the trachea once you are entering the trachea. This is because of esophageal bulge into the trachea. Do not advance your scope or tube when you get such type of decreased space. It's called dynamic airway collapse because of esophageal bulge. It tends to perforate the posterior tracheal wall. So allow esophageal peristalsis to pass away. Ask the patient not to deglutate. If there is enough space to advance the scope and tube, then and then advance and scope and tube. The another problem, coming to the passage of the endotracheal tube, the another problem with the endotracheal tube passage is not like a straight, with direct laryngoscopy, we are creating a direct line of sight and we are creating a channel for the passage of the endotracheal tube. But with the flexible endoscopic intubation, the passage of endotracheal tube is like nasopharyngeal laryngotracheal curve. It's S-shaped curve. So many times, because of narrow nasal passage, your tube can get lodged, impinge at the nasal inlet. Then use with proper lubrication, rotation of the tube over the scope may overcome the nasal impingement. But many times tube can get lodged at laryngeal inlet. See here, scope is inside, tube is getting impinged at the right arytenoid space. In another picture, here scope is inside and tube is getting lodged at interarytenoid space. In this picture, scope is inside and tube is impinged at the left arytenoid tissue. So tube can get impinged anywhere over the larynx. So how to diagnose that your tube is getting resisted or tube is getting impinged over the larynx? So if you get the resistance of the over the tube at 13 to 17 centimeter from the nasal inlet, it's always laryngeal impingement. How to overcome this laryngeal impingement? Withdraw the tube 3 to 5 centimeter, make 90-degree counterclockwise rotation, make Murphy's eyes or tip anteriorly and beaming facing posteriorly, this, and then slide the tube inside the larynx. This will overcome almost all type of laryngeal impingement. So this is on another interesting publication of 2004, or 15 years back. They have stated that awake fiber optic intubation is having higher acute laryngeal injury. 3 years after, one another publication in the same journal, fiber optic intubation is safe regarding vocal cord sequelae. What to believe? Why there is a difference of opinion, difference of conclusion in these two publications? Because in the later study, they have used different type of endotracheal tube and they have optimized the gap between the endotracheal tube and fiber optic scope. So this means that selection of endotracheal tube and minimizing gap between the endotracheal tube and flexible endoscope improves the success rate and decrease the laryngeal morbidity. So there are different type of tubes are available: PVC, flexometallic, Parker flex tube, pre-curve tube. So if you are using PVC tube, there are likely chances that your tube can get resisted, impinge, or lead to laryngeal morbidity in 35% of the cases because of stiffness of tube, because of sharp tip. So this laryngeal morbidity can be decreased and success can be improved by changing over the tube from simple PVC pre-shaped tube to flexometallic wire reinforced tube. Even the design of tip are also having impact on the success rate and having impact on the laryngeal injury and laryngeal morbidity. So there are different type of tips. This is simple tube tips, Parker flex tip, and silicone rubber tip. So if you look at the Parker flex tip, the tip is pointing to the center, which minimizes the gap between the scope and tube. So because of minimizing gap, lagging is less, so which increase the success rate and decrease the laryngeal injury. So it's having higher success rate compared to Parker flex, compared to PVC tube. And silicone rubber tip is a very soft tip. Is also pointing towards the center, and it can easily take the shape of oropharyngeal laryngeal cup, and it improves the success rate and decrease the laryngeal injury. So first choice for the flexible endoscopic intubation, it should be silicone rubber tip with the wire reinforcement. Even the gap between the endotracheal tube and fiber optic scope having impact on the success rate and impact on the laryngeal morbidity. So higher the gap, higher the lagging, higher the chances of laryngeal impingement, and higher the chances of laryngeal injury. So what should be the optimal gap between the endotracheal tube and the scope? So endotracheal tube size should not be 1.5 mm larger than the diameter of the bronchoscope. So if you are using 6 mm scope, your tube size should be 7.5 mm. This will improve your success rate and decrease the chances of laryngeal injury. So tips for just selecting a tube: first choice, silicone tip fast track tube. You can use PVC, but make it malleable by keeping in the warm water. But again, sterility is a problem. And internal diameter of the tube should not be larger than 1.5 mm than the diameter of the scope. Tips for the maneuvering of the scope and tube: if your tube is getting resisted at the laryngeal inlet, means 30 to 70 centimeters from the nasal inlet, is a laryngeal impingement. Withdraw the tube 2 to 5 centimeters, make 90-degree counterclockwise rotation. This will overcome the impingement. And keep the bevel up in nasal and down in oral is called undo technique. So it's time to place your tube properly or optimally. Your tip of the tube should be 5 tracheal ring proximal to carina. So you should be able to count 5 tracheal ring distal to the tip of the tube, because 1 centimeter of trickle in adult, 1 centimeter of trickle length covers the 2 centimeter, a 2 ring. So if you are 5 rings away from the carena, means you are 2.5 at least each away from the carena, which prevents the endobronchial intubation, or it prevents the accidental extubation. And if you are doing from the head end, you will, or front end, you will, when patient is in a sitting position, you will get the exactly opposite or reverse image as you are doing from the head end. So art of endoscopy basic, your best chance is your first chance. Oxygenate through any possible route. Keep endoscope straight and taut. See, endoscope is there to intubate the patient. Endoscope wants to do the endoscopy. It is you who is doing it or not doing it. Stay in the midline, get off the mold. Force is wrong. If you are required to give force, withdraw the scope little bit, identify the proper anatomy, and then proceed. To finish the procedure faster, always slow down. And when you are doing or when you are performing flexible endoscopic intubation, think that you and endoscope are one. Thank you.
I think I've been, I'm not, I mean, they must, please switch on my video. They're not asking me, allowing me to go inside. Start my video, please.
Yeah.
Okay. Thank you so much. It's an excellent talk, Apex. I think it's a mesmerizing talk, I must say. I think I think I could not divert myself from your talk. It's an excellent talk. And the most important thing is the way you have touched all the salient features. Probably I don't think people would have any questions to ask me, but still I'll see whether there is any question in the chat box. No, there's no question at all, but from any audiences. But then I mean, just to carry on the discussion, probably if I could ask you some basic question. I mean, it's all been answered by you, most of them. One thing is, as you said, you should stand straight and tall and taut, isn't it? So
Yes.
nowadays we are having, I think this was the teaching when we had the fiber optic scope, means where we had fiber optics there. But nowadays we have that 5. Do you think we still need to have very tight and straight, tall and straight for doing a fiber optic now?
Thank you for this interesting question. See, Dr. Mohit, there are 2 types of technology are available. One, flexible video endoscope. Second, flexible fiber optic scope. See, in fiber optic scope, there are a number of fibers which tend to rupture during the abrupt maneuver. But in video bronchoscope, there are no fibers. So if you make a movement, there are less chances of damaging the scope. But important thing that, so while I'm insisting on the keeping straight and taut, because if you require to make a right and left movement, if you are not keeping your endoscope straight and taut, you are not able to make the right and left movement of the tip. That's the another reason you should keep. So whenever we are giving training for a flexible endoscopic intubation, not only for intubation, even for a bronchoscopy, we are asking them to keep the scope straight and taut, because until unless you keep your scope, whether it is a flexible video or flexible fiber optic, if you are not keeping straight and taut, you are not able to make the tip movement right and left.
Okay. So thank you for the answer. The second question is, yeah, would you like to add something, Amit?
Yeah, no, not add. I wanted to ask, suppose if you have a adult patient and I have a pediatric scope, how do I, improve the?
Yeah, that is what I was asking one by one. Anyway, it's a good question. So he says that Apex, I think you'll be able. I mean, it's a very common question which has been asked in most of the examinations also. That how would you use a pediatric bronchoscope in an adult patient? The question is simple.
Yes. So you can easily use pediatric scope with the adult tube, you can intubate. But what's the difference? The main thing, if you are using pediatric scope with the adult tube for an adult patient, there will be higher lagging. there will be a higher gap between the scope and endotracheal tube, which decreases the success rate and increases the laryngeal injury, increase the laryngeal morbidity, increase the laryngeal injury. So to minimize injury to larynx, minimize impingement, and improve the success, you need to minimize the gap between the scope and tube. That can be done by using a different hollow tube that's called entry catheter. So you can shield your scope with the entry catheter is having internal diameter of 4.6 and external diameter 5.5. And if you're using 3.5 mm scope, load the entry catheter over the scope. So advantage of loading the entry catheter over the scope is two. It shields the scope, it minimizes the damage, and it minimizes the gap between the endotracheal tube and the entry catheter, and which improves or increases the success and decreases the laryngeal injury.
The other way which you can do is you use your pediatric endotracheal tube, you pass it through it, and then over it you railroad your a bougie, and then take out and pass an adult size tube. So that is also you can go ahead with it.
Yeah. See, there are a number of ways we can play with the airway, but you should play when you are having confidence and you are having expertise.
Exactly. So the other point is, do you think, Apex, you said that at the time of entry, especially there's always a chance that you hit the anterior commissure. Do you think, especially in patients who are a bit sedated, I mean, and in situations where the patient is supposing a temporomandibular joint ankylosis, right? Or a patient who's having clipping or dental wiring. In those situations, how do you think you would especially prevent negotiating between the epiglottis? Because that's always a problem.
With the pediatric scope or with the adult scope?
Sorry?
With the pediatric scope or with the adult scope?
Yeah, with the adult scope as well. With the adult scope.
Adult scope and negotiating it's very easy. You just need to maneuver the tip movements little bit anterior. You can negotiate your scope inside, but the passing of tube require little bit of manipulations. So in such case, when you are just going near the vocal cord, your tip is going near the vocal cord, make the 90-degree rotation of the tube, make the bevel posteriorly, and then advance the tube. This will overcome this type of problem.
Mohit, if I may just, if you permit me to just add on to that, I think what you're saying is when the patient is sedated and the epiglottis falls down, right? And the space is very narrow to maneuver the tip of the bronchoscope. So one of the things that you can do in this situation that can overcome this is giving a jaw thrust.
Yeah, that is what
when you give a jaw thrust,
Sheila,
this often happens.
Sheila, I gave a question in cases where the patient has a temporomandibular joint ankylosis. Now, there you cannot go with a jaw thrust. That is
in that it's difficult, but routinely, if you see when you're sedating, the patient is sedated, this is often a problem because you can't negotiate the tip of the bronchoscope, leave alone the tube. So a jaw thrust definitely helps, or any maneuver you can do to open up the airway will help in this situation.
Yeah, Dr. Mohit, just a minute. Another thing, so there is a decreased anterior posterior depth of the pharynx. That's the problem. So jaw thrust will create the space. If you are not able to give jaw thrust, another way of creating a space is a CPAP. You can deliver the CPAP from the opposite nostril, or if you deliver the high flow nasal oxygen, it can generate 3 to 4 centimeter of H2O CPAP into the oropharynx, which is through which you are able to generate the adequate space and you can negotiate the scope.
Actually, the problem why I wanted to put a temporomandibular joint ankylosis is there are two problems here. One is you cannot go for a jaw thrust. Second is you cannot ask the patient to protrude his tongue. Both the things could have created a space which could have lifted your epiglottis. The other thing which we can do is
head tilt chin lift may help.
Sorry?
A head tilt chin lift will also help sometimes.
No, but that is the problem. We cannot go with that. Temporomandibular joint ankylosis will not permit you to do anything of that sort.
But jaw thrust may not be possible, but sometimes tilting the head does help.
No, you can ask the patient to donate. You can ask the patient to donate if at all. That can create a space between your epiglottis and your tube. That is one thing which you can ask because of the pressure, because of the airway pressure from the lungs that can lift up the epiglottis a bit.
That is CPAP. That's what.
That is from external to insert, but I'm talking about from internal to outside. So when the
Yeah,
patient donates,
I think this is a very good point you brought up, Mohit, because of course not in TM joint ankylosis, but we have faced this problem
Yes.
in routinely, and Chaudhras definitely helps in this maneuver, in this situation. But good points, both externally and internally applying people to be able to visualize, because once you can visualize, then you can quickly pass the scope, and then the rest becomes
exactly
easy.
Yeah. The other point is, Apex, a
Yes.
very common question which is being asked by most of the people: how do you sterilize your bronchoscope?
See, in our institute, we are having a auto sterilization unit in our setup. So we are using auto endo sterilization.
Endoscopic auto reprocessor is
Yeah.
there in our institute, but if you don't have that high level disinfection with the help of Sidex is the answer. High level HLD, high level disinfectant with the various solution, and most common is this Sidex.
Sidex for 30 minutes is enough. People
2% glucuraldehyde for 20 minutes at the room temperature higher than 20 degrees centigrade. These are the requirements.
In the interest of time, may I ask Dr. Mohit to wind up the session, and Dr. Amit to please take the next session forward.
Thank you so much once again, all the faculties along with Apex. I'm thankful to the organizers as well, ODISHA ISCON. Thankful for giving me a chance to be moderate this session. I hand over the session to Dr. Rakesh and Dr. Amit. Is it Amit?
Next speaker is Dr. Rakesh Garg, who is Vice President of All India Difficult Airway Association. Needs no further introduction. He has many accolades, so I don't think that we can, otherwise it will take his entire lecture time. So over to Dr. Rakesh for the session, which is, everything else fails, and that is what you are staring at and what we probably have to do, emergency cricothyrotomy. Over to Dr. Rakesh, and this session will be moderated by Dr. Jason. Is Jason around? Dr. Jason?
Yeah, I'm around.
So moderated by Dr. Jason. Okay, please, Rakesh, go ahead.
Thank you so much, sir. Thank you for the kind words, and thank you, ISA Odisha, for inviting me, especially Dr. Rekha Das and Dr. Nivedita Pani. And thank you, Dr. Sheila Maitra, also for making this nice module of online airway workshop, which is going very well, and very nice interaction and good questions from the participants. So I'll be talking about the aspect of surgical airway, when and how to do it. So that is always a big concern and a big issue when we are talking about the management of airway, because is the screen visible, sir?
Yes.
Yes, sir. Right. So we'll be talking about the surgical access in airway management. We have talked about the use of supraglottic airway devices. We did talk about the video laryngoscope. We did talk about using the endoscopic intubations. But there will be situations wherein we'll be landing up in difficult aspect from various modalities of airway management. And we will be landing up in a situation where we'll be labeled it as failed intubation, and then we need to think of something different, and which is usually as a rescue measure and remains to be the emergency cricothyrotomy. So when is it required to do it? So we need to identify the triggers in the management plan, as we're discussing in the previous sessions also. We need to have understanding that which is the right time to do the surgical access, because now the airway armamentarium is increasing, and we have so much of gadgets, and that was being discussed by the previous speakers and moderators also, that we need to identify, we need to have some tips and tricks or uses of each equipment to make them more successful. And definitely there is no replacement of having experience with them to make them more successful. But still, there could be a situation, and we are already talking about the unanticipated difficult intubation, which has been given nicely by All India Difficult Airway Association, wherein we have talked about the stepwise approach, and we'll be discussing later in the today's workshop itself about the various steps. So I'll not be going into detail. But the point is, when we are talking of the various steps here, say first will be the laryngoscopy intubation. If fails, we talk about SCD. If it fails, we talk about rescue ventilation. If it fails, then it's a point where we need to think of the next step, and which is usually obviously calling for help also, but usually it will be requiring something which is will be labeled as a complete ventilation failure. So we are moving it away from the CICO because we believe that with the availability of equipments, which Dr. Sheila was also talking about, HFNO and TRIVE and all those equipments, probably oxygenation can be maintained to a certain extended duration nowadays because we have equipments, we have understanding of maintaining oxygenation. But then if the ventilation is not happening, these patients at some point of time will succumb to the adverse events of absence of ventilatory efforts. And that's why we need to have something which will save the patient, which will prevent the patient from not only just hypoxic injury, but also the other issues. So this oxygenation, is the prime thing. And that is why we are emphasizing in the previous session also, in the guidelines also, to maintain oxygenation at each step by using various modalities that has already been discussed in the previous session, because we know that the oxygen reserves are limited inside the body. They will tend to get depleted if they are not replaced. And that's why we already talked about the THRIVE and the high flow nasal oxygen cannulation, oxygenation in these patients to ensure it. Having said that, we are ensuring maintaining oxygenation, but we are land up into a situation of a complete ventilation failure. Now, this is the point wherein we need to think of the emergency cricothyroidotomy, and this is the trigger that we should be talked about. But simultaneously, I will also try to clarify one more aspect here, that though we are talking about the stepwise approach, but if the patient in the first step itself is having desaturation, is having signs of hypoxia or hypoxemia, then it's a time that we need to skip the steps and directly we can go for the emergency cricothyroidotomy. So that's another trigger that we need to remember, that it's not mandatory to follow all the steps in case if the initial first point of time, first interaction with the patient is hypoxic. Then we need to think of which is the fastest way we can look for ensuring that the patient gets oxygen. And that is what we can sometimes skip the steps and reach for the emergency. And this is applicable not only for adults, but also for specific group of population like obstetrics. We are talking of 2 lives. It's also applicable for pediatric patients, again, where we land up into complete ventilation failure. And definitely it is for intensive care unit also, where again, if we have failed in the previous steps, we need to think of the emergency cric. So these are the triggers that we need to remember in each group of patients, whether they are focused patients like in ICU or generalized in the operating room. We need to think of what we can say. And this is what the All India Difficult Airway Association has commented, that emergency cricothyroidotomy is deemed necessary when there is a complete ventilation failure, when intubation, ventilation using SAD and face mask have also failed after giving the best attempt, even though oxygenation will be maintained. And now we have already discussed that there are modalities to maintain oxygenation, though we cannot continue with them without having some definitive airway that needs to be used. We already talked about the oxygenation aspect, and we have already talked about delivering the apneic oxygenation. Why I am putting it here is, when we identify the trigger, yes, we are going for an emergency airway access, emergency cricothyroidotomy, but this is the point now. We have sufficient data that we need to continue them, putting them on oxygen supplementation using various gadgets. Even if you remember, which will be discussed subsequently in the algorithm session also, that we are using the neuromuscular blocking agents in case we are stuck up. And then probably the apneic oxygenation is a good option where we can supplement oxygen and maintain the hypoxia. So this is what the triggers are in a difficult airway scenario wherein we need to put up. And secondly, sometimes, especially in a trauma patients, we are also wherein we think that there is need for the protection of airway and the upper airway is damaged. Those are the again situation where you can think of the emergency cricothyroidotomy. Now, how can we do it? The first thing is we need to understand the anatomy of a particular patient in general, because we are talking of securing the airway access from the cricothyroid membrane. And that is the emergency aspect. We should not be confusing with conventional tracheostomy, which is elective procedure. which should not be a replacement of emergency management of an airway in case of a failed intubation. We need to look for an access which is subglottic, which is cricothyroid, and we need to identify them, these structures very well. We should be able to identify the cricothyroid membrane. We should be able to identify the cricoid ring. We should be able to identify the thyroid cartilage, and so on and so forth, so that in an emergency situation, we are very, very clear that this is the site. So remember, emergency access of the airway as a rescue situation should be from cricothyroid membrane, not a conventional tracheostomy from tracheal rings. Patient positioning and preparation, patient should be laid supine. Neck extension can be done if it is allowed. We can put pillows under the shoulder or dropping the head over the operating table. Try to follow whenever possible aseptic techniques and universal precautions. Identify and mark the thyroid membrane before the induction of anesthesia in case if you are suspecting, though there is some controversy that with the patient change in the positioning, with the patient struggling with the airway, the cricothyroid membrane may tend to move up and down, but then it will be a good idea that if you can identify them, you can palpate them. If you can identify them, it will be a little reassurance for you that in case if you land up in a difficult situation, you'll be able to mark it. The other thing is the stabilization of the larynx also. This is one of the good described technique, and it has been recommended by All India Difficult Airway Association as well, the laryngeal handshake technique. This technique is very, very important when you go for emergency cric, because when the patient is requiring some rescue measure, if the patient is not under the influence of neuromuscular blocking agents, patient will have some struggling action, and the laryngeal whole structure will try to move because patient will be trying to have some inspiratory efforts. So that's why it will move, and that's why the stabilization is very, very important. And this technique remains a good option to identify the cricothyroid membrane and then continue with the emergency thyroidotomy. Now, in this, the first step will be the palpation of the greater cornea of the hyoid bone, and you use your, as you can see in the first figure, you use your index finger and the thumb to identify the cornea. And then you try to roll the larynx from side to side to identify using the middle finger, and the fingers and the thumb side. You just try to slide it down to identify the thyroid lamina, and just move it down and try to identify with the index finger the cricothyroid membrane, the first indentation that you feel after the thyroid lamina is crossed. So this will make you identify the cricothyroid membrane without missing it, and this is the structure that needs to be targeted for emergency cricothyroidotomy. The options available, we have the option of a surgical cricothyroidotomy, or we can use a needle cricothyroidotomy. So these are the two basic options that are available. Selection between them is a matter of concern, but both the options are acceptable. The needle cricothyroidotomy could be a narrow bore, which is usually a cannula over needle technique, or it could be a wide bore. Usually certain commercially prepared equipments are available which have an internal diameter of more than 4 mm, and they are cannula over trocar method. So these are options, and now we are also available with wire guided technique, or you can simply say a Seldinger type of technique, which are available for the emergency cricothyroidotomy. Now, just remember that when we are talking about the needle or the narrow bore, they cannot be ventilated conventionally using the ambu bag or the bag and mask assembly. They would require a jet ventilator with them. On the other hand, the large cannula or the surgical cric can be ventilated through conventional ventilators. Now, having said that, I've just mentioned you 4 techniques that can be used. Which technique is the best technique? Any technique which can be accomplished rapidly, they're easy to learn and perform, and a high success with minimal complication should be the ideal technique. But if we compare regarding the evidence of the use of a particular technique, no technique which we have just mentioned is ideal that guarantees 100% success with no associated complication. But there was an interesting evidence which came from UK during the National Audit Project. They mentioned that the success rate was 37% with narrow bore, 57% with wide bore, and 100% with surgical cric. So this appears that probably we should, if we can learn a surgical cric, probably the success rate is much, much better. On the other hand, the use of needle bore or the wide bore again will depend upon the experience, but this project, this NAP4 project, has reported a little lesser success rate. but then all the techniques are doable. And IDA recommends the performance of any cricothyrotomy technique based on the familiarity of anesthesiologist and availability of equipment. But it is said, as the other experts were also discussing, that we should be well versed with the all techniques, and the concerned required equipment should be available. And these type of workshops where we can awake and just try to learn them, they're easy and it becomes much more easier. The surgical cricothyrotomy, the most commonly technique and easier also, is a stab, twist, bougie technique. Here the incision through a cricothyroid membrane and the tube, usually the endotracheal tube or maybe at times tracheostomy tube, is inserted through this incision. What you require is you just require 3 equipments, and they are easily available. You do not require any equipment which may not be available or require just commercial things. A bougie is always available. A cuffed endotracheal tube size 6 is always available, and scalpel blade is always available. So you just have a kit of 3, and you can go ahead a surgical crick, stab, twist, bougie, tube technique, which is very easier. And how to do it? You need to make the patient supine and do the neck extension. That is what is required. As we mentioned earlier, oxygenation should be continued in these patients. If you have the availability of high flow nasal cannula or Thrive, you can also use them in these patients. What you need to do, let's see this video. This is a very, very simple technique and can be done very faster. So what we require is we can just need to have this bougie ready with us, a size 6 tube, which should be ready with us. Just need a size 10 blade, stab blade. And what you need to do is just palpate cricothyroid membrane, which we just mentioned how to do it. So once you have palpated, give a nick, give a stab nick, and rotate the blade by 90 degrees. So now this needs to be stabilized, and then you can go ahead and use a bougie. Since the space is created, you just take the blade in the other hand, stabilize the blade, and insert the bougie. The angle tip should be inserted first. And then you can insert towards the trachea. So once the bougie is inside, try to ensure by movement of the bougie that you are in the right track. So you can remove the tube, and this is the point wherein a helping person can insert the tube over this, railroad over this. And in case if you want to just try to look for the things, you can always check it. So this is how we are using this simple technique. But sometimes it may be an initial failure. You can use the modified technique, which is scalpel finger bougie technique, wherein you try to dissect, because at times when the patient is obese, there will be a lot of tissue mass. In those, you can try to dissect after the scalpel incision that you have given for 8 to 10 centimeters. Try to identify the cricothyroid membrane, and then you can go ahead, put up a bougie, and then railroad endotracheal tube over it. We do have commercial sets available that can also be used for the same purpose, but then the bougie, the tube, and the scalpel is easily available things. For the narrow bore cannula technique, we can use any small cannulas like this, which are commercially available also, like for Revison, and you need to have a pressure regulated jet ventilator along with you. You can use that. So for this, the technique is simple here. You just need to identify, you need to get this needle, which is commercially prepared, or even you can use other cannula over the catheter over the cannula, which is available. And you need to identify the cricothyroid membrane as we did earlier. You attach the syringe, saline filled syringe, ensure that you are in the right place. You can see the bubbles coming out the normal saline. Once you are very sure, try to put the catheter in, remove the stylet. Once again, you check it that your catheter is in the right place, and then you can go ahead, use the jet ventilator to ventilate. Though commercially people have tried to use the ambu bag or the ventilator is not a good option. And when you're using jet ventilator, how to initiate it? You need to give an inspiration of around 1 second, and gradually you can increase the pressure. So if you see the knob here, this is for pressure regulation. So once you try to regulate this pressure, you can see the readings. You can start with 15 to 20 psi, and your endpoint should be a visible chest rise here. So if you can see a visible chest rise, that will be sufficient. So give the jet for 1 second and wait for around 4 seconds or so for the expiration to happen. So this is how you can use the needle cricothyrotomy technique, narrow bore technique for ventilation. For wide bore cannula technique, you have to have some commercial commercial equipments like this with a wide bore, and you can use them for ventilation. They are commercially available. They are less invasive than surgical cric, and they avoid the need for jet ventilation. They can be ventilated using conventional ventilator and breathing circuits, and you can use them. For this, these commercially available devices are available. They can be done very easily. You identify the cricothyroid membrane, and once you identify the cricothyroid membrane, these devices can be easily. They have some safety devices inbuilt into them so that you are not going through and through the posterior tracheal wall. So give a small nick, identify, take this commercial wide bore cannula available to you. If you did see this cannula, these are spring-loaded one, and you can see a marker on the top. So moment you puncture them, these will hinge back, and they will ensure you that you have gone into the tracheal lumen. So this is how this type of safety mechanism will ensure that you are not going into the posterior tracheal wall. So this is how you need to hold perpendicular in the beginning, already after a nick has been given, and try to push in, go in. You continue to look for this marker which is available, and as you go in the tracheal lumen, if you see here, as you puncture the tracheal wall, go inside the tracheal lumen, you can see the bounce back of this marker here. Right, so this is how this marker will change. This ensures that you are in the right place. You have already punctured the tracheal wall, the cricothyroid membrane, and you are inside the trachea. You can ensure again using an saline fill series that you're in the right place. Now this is the point again, when this is touching the posterior tracheal wall, again this plunger will come up. So this is again a safety mechanism that you ensure, and at this point of time, you need to angulate it and just go into the trachea. And this is the point wherein you try to push the external tube over the cannula inside the tracheal wall. So this is how internally it looks like. So now you are sure that it is trachea, and this is the point wherein you need to push the tube inside the trachea by stabilizing the stylet and removing it later. And then you can confirm it. Also need to remember that cricothyrotomy, if you are using needle cricothyrotomy or a narrow bore cricothyrotomy, it needs to be converted to tracheostomy at the earliest, because these catheters for a longer duration can make tracheal stenosis to happen. So you should be very, very careful. You should also be looking for the complications that can happen, though we are sure that the oxygenation is being maintained, the airway is secured here, but you should be looking for hemorrhage, false passage, pneumothorax, deterioration of respiratory parameters because of the pneumothorax, subcutaneous emphysema, and these are all can lead to some mortality and morbidity. So once the tube is in situ, you should be looking for these complications and manage them accordingly. But these are all manageable events and can be managed easily. But remember, though we have said surgical airway is the rescue measure, it may not be possible in all patients. We should be very, very cautious about identifying the difficult surgical airway also. And in case these are difficult, like in obese patient, we are not able to palpate the cricothyroid membrane, the newer equipments or newer modalities has come into picture. The use of ultrasonography in the management of airway has helped us to identify these structures nicely. You can see here the tracheal rings, the cricoid membrane here, and this will help you to identify cricoid membrane even in patients who are obese. So this is what we have talked about, the difficult airway management, reaching to surgical access. But remember, when we have this situation, it's always good that we need to document everything. And in this sense, the IDA difficult airway alert form should be very good, because these patients may require subsequent some surgical procedures. So we should be giving this difficult airway alert form to the patient, so that subsequent person who are managing the airway knows what exactly the difficulty was and how they have been taken care of. So to summarize, surgical airway remains an important rescue for difficult airway. The procedure is challenging, but it is learnable. We can learn it very easily by having workshops of surgical access. And IDA is already conducting surgical access workshops wherein this simple life-saving measure can be learned easily. And we just need to know knowledge, anatomy of the area and the surgical and little experience, which we can easily learn on mannequins and even on the animal models. And this remains one of the easier technique to learn and doable technique and a good rescue technique for patients having difficult airway. Thank you so much. And we are open to questions now.
Thank you, Dr. Rakesh. That was an excellent overview of cricothyrotomy and complete ventilation failure. And I can't see any questions for you in the chat box, but I'm actually a little curious to know a couple of things. So taking this forward, like you mentioned that it's a good practice to get skill that is not very often in use. So how do you suggest keeping your skills up to date? So you've learned it maybe 10 years ago or 5 years ago, attending a workshop, and then how do you keep updated by doing this on a regular basis?
A very good, important question, Dr. Jason, you have asked it, because in airway management, skills are the important aspect. Planning is important also, but skill is equally important, and skills perish if we don't practice it. So the point here is we do have mannequins, we do have animal models, we can learn it. This is one point. Second thing is it's a good idea. Say I said the failure rate can also be because of not identifying the cricoid membrane. So why not to just identify cricoid membrane in each and every patient which we are anesthetizing, so that at least even in a difficult obese patient with short neck, we know that the cricoid membrane is identifiable. And there are studies in which people have failed to identify correctly the cricoid membrane, and this was one of the reasons for the failure of the cricoid. This is one. Second thing is, though this is not one of the options people are doing it, we have moved from the invasive anesthetization of the airway when the transtracheal modality of anesthetizing airways, we are not using them nowadays because other techniques are safer. But those who are using it, again, identifying and puncturing it is a very good option, because when you do it even for some time, I think it's really good. The animal model, even the goat models, or they can be done. I think in that sense, people should approach IDA for conducting this workshop. They are very small modules workshop, and mannequins and animal models are easily applicable. I think we need to have these type of workshops, not just maybe every 6 months, because the point here is the earlier speakers, Dr. Apex Patwa will be very, very eager to do fiber optic intubation. Dr. Amisha will be fond of using video laryngoscopy, and Dr. Jason you will be using supraglottic airway devices. But you will get the opportunity to do it on a routine way. You can do it, but we cannot do a surgical access on a routine way just for the sake of learning. So that means a limitation for us, and in that sense, keeping models and sometimes even indigenous techniques of using them will be helpful.
Great. That is a fantastic summarized answer. So I would like to say that all teaching institutes should take the responsibility with IDA to conduct these teaching sessions on a regular basis and take this forward. And like you rightly mentioned, that transtracheal needle injection of local anesthetic or transcricothyroid membrane puncture for local anesthetic injection for an awake fiber optic is a very good technique of keeping your skills in place. So that is an excellent overview. Acha, the other question that I had here was IDA recommends any of these techniques, and from the evidence that you rightly pointed out, the NAP4 audit says that surgical cricothyrotomy is one of the best techniques with a 100% success rate. But in your opinion, what would you suggest as a single technique if you had to train? So what would you recommend? And what would you recommend keeping in your armamentarium or as a departmental infrastructure to take this forward?
I think if you ask me personal experience, and I think that is being collaborated with the evidence also, and with the few cases that I have done in my experience also, I think the surgical cricothyrotomy using a boozy, a scalpel and tube remains the best technique. The reason is, if you use a narrow bore needle cannula, this is just to buy time for the other expert to come and chip you in and help you. And maybe you can use it for 30 minutes, 45 minutes, and then you have to be converting into it conventional cricothyrotomy or probably a tracheostomy. But in case if you are able to secure the cricothyrotomy, maybe for whatever reasons you are anesthetizing that patient, you have sufficient time to get it done. And then the patient will have better outcome. And the equipments required for this, the three equipments that we have talked, I think it's available at all places. Boozy is there, always our difficult airway card. Scalpel plate in a surgical OT will always be there. And size 6 tube is always there. So we don't have to search for the things, especially when we are talking in the emergency area or in the ward, where we'll not be able to get the transtracheal jet ventilator. Jet ventilator may not be available. And there is evidence that the conventional connecting a connector and using an ambu bag through a needle is not a good option, because the pop-up valve will leak everything. Nothing will go inside. This is just for our oxygenation rather than patient oxygenation. So in that sense, I think using the surgical cric remains the choice and should be preferred. And it's easier to learn.
Perfect.
I think in the interest of time, Dr. Jason will wind up. So thank you very much, Dr. Rakesh and Dr. Jason, for an excellent session. I think the important message here is that whatever the technique you use, try to use one that you're familiar with, but do an emergency cricothyrotomy in a timely manner. And remember, as Dr. Rakesh said rightly, that cricothyrotomy is just a stopgap to buy that time. Whichever technique you use, you need to convert that to a tracheostomy, because you're very close to the vocal cords, high chance of subglottic stenosis when you access through the cricothyrotomy. So you cannot keep the cricothyrotomy for too long. You'll have to switch to emergency tracheostomy. So I'll move on now to the next session. And this is the IDA guidelines session. And these are the guidelines that IDA developed in 2016. Of course, we don't have time to play the full guidelines, but I'll request 2 of our guidelines of the 5 guidelines. That is, one is the adult guidelines for the management of unanticipated difficult airway and the extubation guidelines. Again, it is only the algorithm that we are going through in detail, and this will help you prepare for any unanticipated situation. So I request Dr. Amit Shah to please take forward the adult guidelines for the unanticipated difficult airway. Dr. Amit Shah.
Good evening once again, and I'll be taking you through the algorithm part of a IDA 2016 guideline for the management of unanticipated difficult tracheal intubation in adult patient. This was guideline 1, and we must understand that the flow chart which I am going to go through should always be used with conjunction with the text, and that this guideline do not represent minimum standard of practice, nor they substitute for a good clinical judgment. The algorithm starts with the step 1, where you are unable to intubate during your first attempt at direct or a video laryngoscopy. You might be doing any technique. But before going this technique, there are a lot of more important points which are suggested in the form of pre-operative assessment, preparation, pre-oxygenation, positioning, use of various induction agent, neuromuscular blocking agents, and all other things, which everyone should go in detail through the guideline, and then go ahead with the performance of a direct laryngoscopy or a video laryngoscopy. Unable to intubate, that means the failed attempt at direct or a video laryngoscopy, first and foremost, most important thing to be done is call for help, and call for help should be continued till you receive the help throughout your entire step of algorithms. So call for help is the first and foremost. Once you've done that, you are not able to intubate with the direct or a video laryngoscopy, you continue nasal oxygen with the help of oxygen flow at 15 liter at least, and that is you continue with the apneic oxygenation. After that, only 2 more attempts. So after one failed attempt, 2 more attempts are allowed, provided saturation is more than 95. In between, you continue with the mask ventilation, optimize position, use external laryngeal manipulation and release cricoid pressure. Consider changing device, technique and operator between attempt. If you are successful, then confirm tracheal intubation using capnography. But if you fail to intubate with these 2 more attempts, that means total 3 attempts, declare this as a failed intubation and resume mask ventilation with 100% oxygen and consider next step, that is use of supraglottic airway to maintain oxygenation. Again, continue nasal oxygen with the help of oxygen flow at least 15 liter per minute. Use preferably second generation of supraglottic airway, and only 2 more attempts are allowed provided your saturation is more than 95%. If you successfully ventilate these patients with the help of supraglottic airway, then there are 4 options available to us. One is, and most important and best would be, wake up the patient and do procedure next time with proper preparation. You may consider continuing anesthesia using supraglottic airway, provided it is considered safe and the exit options are available to you. If you decide to intubate through supraglottic airway, it should be done with the help of fiber optic bronchoscope only, and provided you have expertise available. And you may consider doing tracheostomy if the situation demands tracheostomy later on. But if you fail to ventilate with the supraglottic airway, then you are staring at a situation where you're not able to intubate, you're not able to ventilate with the supraglottic airway, and then you are staring at a situations where you may have to do surgical airway. Before doing cricothyrotomy, you must consider one more attempt at a rescue face mask ventilation. Continue nasal oxygen using oxygen flow at 15 liter per minute. And while you are doing rescue face mask ventilation, ensure proper neuromuscular blocking and optimal technique with the adjunct. If you are able to ventilate with the rescue face mask ventilation, you can continue ventilation till you can wake up the patient. But if you are not able to ventilate at this stage, that means you are looking at a situation where you are not able to intubate and ventilate with either supraglottic airway or face mask, and waking up option is not available. It is possible that your oxygen saturation may be normal because of apneic oxygenation. We have termed this situation as a complete ventilation failure, and at this stage you should consider emergency cricothyrotomy. You should immediately call for additional help who can come with the fresh mind and can understand the situation and help you better. For the emergency cricothyrotomy, again, continue nasal oxygen using oxygen flow at 50 liter, and efforts at rescue face mask ventilation should be continued by the other person. And you can consider performing one of the cricothyrotomy technique depending upon your experience, expertise, and equipment available to you. You can either perform surgical cricothyrotomy, you can consider wide bore cannula cricothyrotomy with the commercial sets available, or you may consider doing needle cricothyrotomy, provided you have pressure regulated jet ventilation and you have to keep the upper airway patent. Once you have successfully rescued the patient, you should always consider further airway management plan, treat airway edema if you are suspecting it, monitor for complication, and always counsel and document. So all in all, the highlight of IDA 2016 guidelines for the management of unanticipated difficult airway in tracheal intubation in adult is about oxygenation. We have clearly identified apneic oxygenation clearly at every step of a guideline. You should call for help at earliest and continue to call for it till you get the help available. Multiple attempts are clearly discouraged, and they are allowed only if oxygenation is normal, that is more than 95. Intubation attempts not more than 3, and supraglottic airway insertion should not be allowed more than twice. Capnography has been made mandatory for the confirmation of intubation. Need for second generation supraglottic airway is clearly identified. Blind intubation through supraglottic airway is clearly discouraged. Ensure relaxation for the face mask ventilation. we have identified a situation where oxygenation may be normal, but you are not able to intubate and ventilate with either supraglottic air or face mask ventilation. And we have termed it as complete ventilation failure. Do not wait for saturation to fall and perform cricothyrotomy at inability to ventilate. And of course, observe, document, counsel, and report. Thank you.
Thank you so much, Dr. Amit, for giving such a comprehensive overview of our guidelines. Of course, this is just the algorithm. The algorithm has to be read in conjunction with the text, but Dr. Amit has given you a broad overview. I don't see any questions in the chat. Dr. Amit, I'd like to ask you that you have highlighted the key points of the algorithm. And being that we have given a lot of emphasis to peri-intubation, oxygenation, earlier trigger for doing emergency cricothyrotomy, and various other aspects. So I would like to ask you that since the new guidelines are going to come in December 2021, what do you think are the sort of limitations of this guideline, and what are we trying to achieve in the updated guidelines? Can you throw some light on this?
In the sense?
No, I said in the new guidelines, what can we expect? Any limitations in these guidelines, something we plan to change, or?
We have the attempts are not more than 3.
Yeah.
We have considered that, waking up option is the best option, and the intubation through supraglottic airway is clearly discouraged. And cricothyrotomy, I think we have termed it as a complete ventilation failure, and I think that is most appropriate term. Your apneic oxygenation may continue your oxygenation. So if waking up option is not available, you may go with the cricothyrotomy. There might be more options available for the cricothyrotomy, or rather we can limit the options for the cricothyrotomy, and we may go with the only surgical cricothyrotomy.
Right.
Yes, Dr. Sheila, there are certain gray areas in our guideline which needs improvement as per the newer evidences. The first thing, considering the recent evidences about the high flow, we need to make a decision: should we include the HFNO in the guideline or not? That is one thing. Second thing, number of
already in the guidelines, right?
It's in the 50 liter flow. Apneic oxygenation is there. I'm talking about the high flow. Should we include or not? That we need to discuss it out as per the evidences, and that decision we have to make. Second, number of attempts we have given. Whatever the device you can choose, but we need to specify the device. Now it's high time to specify the device. Should we go for second attempt with this type of device, or hyperangulated blade, or angulated blade? Again, we need to collect the number of evidences and need to improve upon that.
So,
that is
if you agree, I think one thing that is a limitation of not only our guidelines but a lot of guidelines is we start with a failed tracheal intubation. And today we know that when we practice anesthesia, it may not only be tracheal intubation, but we may be using just a supraglottic airway device, or just maintaining the case on TIVA or something like that. So we need to have something which includes all these aspects and not just a failed tracheal intubation. So that definitely is one of the limitations of the guidelines and all the aspects that you've already mentioned. One of the advantages of IDA is we came with a guideline very late, the national guidelines. So we incorporated all the good positive points of all the guidelines. So quite a robust guideline made. So in the interest of time, if there are no other questions or comments, or Amit, if you'd like to give.
It was difficult for me to find out the faults with our guideline. Except that, yes, as you suggest, that if you are doing, we don't have any guideline for, suppose if you are starting with a supraglottic airway, then what you should do.
Yeah. Amit, another
thing, see, whatever what are the existing guidelines, either us or others, is an intubation oriented guideline.
Yes. That's what I was trying to make.
Yeah.
In the interest of time, we'll wind up and go to extubation of the difficult airway. But before that, Amit, if you'd like to just give some concluding comments about the guidelines before Dr. Mohit takes over.
I think one important consideration is oxygenation, oxygenation, and oxygenation. It is very, very important that you don't fix up yourself on the attempts or laryngoscopy or intubation. You should always consider oxygenation as the priority. And apneic oxygenation is one thing which has changed from whatever we were thinking previously. And we should continue with the pre-oxygenation, proper pre-oxygenation, and then continue with the apneic oxygenation. And don't keep on doing attempts to perform the procedure. think of oxygenation and move to the next step.
I think that's a very important point that we did. In fact, one of the unique features of our guidelines is we've given a lot of emphasis to peri-intubation oxygenation. And like you rightly said, limit attempts because we tend to go on and on. Thank you so much, Dr. Amit. I hope all of you will also read the whole text of the guidelines. Now we move on to Dr. Mohit, who is going to tell us not about routine extubation, but extubation of a difficult airway and guidelines for that. So over to you, Dr. Mohit. Mohit, you are muted.
I'm sharing my screen, please. Yeah. Is it visible? Is my screen visible?
Yes, please. Yes, please. Go ahead.
Yeah. Good afternoon to all of you, and special thanks to the organizers for letting me be a part of this conference. I bring greetings from my institution and my university. I'll be speaking on anticipated difficult extubation, and which is being published in Indian Journal of Anesthesia, and it's an IDA guideline. And whenever we speak on this algorithm, it has to be in conjunction with the manuscript which has been published in Indian Journal of Anesthesia in 2016. What is extubation? It is a purposeful removal of tracheal tube and transition from an established airway to a normal natural airway. And what is the extubation failure? Inability of the patient to maintain a patent airway with effective spontaneous ventilation after purposeful removal of the previously placed tracheal tube within a specified time. And the incidence is pretty high in ICU, but not as such in cases of operation theater. It's around 1.1 to 0.2 and 6 to 25% in intensive care unit. So extubation, remember always that it's an elective procedure, and plan the strategies to avoid extubation failure. So it needs an algorithm approach. So either the extubation strategies may be planned based on initial assessment and with regards to difficulty in airway and predicted concerns in extubation. And IDA has 3 limbs approach for extubation. In limb 1, we have the normal airway, where the patient condition requires a suppression of hemodynamic responses during extubation. Limb 2, which is 4 Ds consisting of difficult mask ventilation, difficult intubation and reintubation, delayed recovery, and difficulty pre-existing in pre-existing diseases. And in limb 3, we have 3 S's, which is surgical cause for airway complications, compromise, suspected airway edema, and suspected airway collapse as well. So the first limb is normal airway, where we have patients are usually going for a neurosurgery or an ophthalmic surgery, where we need to have a hemodynamic, stable hemodynamic responses at the time of extubation. So we can have 2 ways. One is awake extubation or a deep extubation. In awake extubation, we can go ahead with the topical lignocaine or IV beta blockers, IV lignocaine, IV fentanyl, IV dexmedetomidine at the time of extubation, so as to prevent the hemodynamic responses or pressure responses at the time of extubation. Now, in case of deep extubation, we can also use the surgical airway devices. There are 3 methods. The one is you can remove the endotracheal tube and insert in supraglottic airway device. We can use a insert a supraglottic airway device followed by endotracheal intubation into endotracheal tube removal, and remove the endotracheal tube over an AEC, and then you pass an supraglottic airway device as well. So these are the methods which we can use to in case of deep extubation. Now, secondly, which comprises of the 4 Ds: difficult mask ventilation, difficult intubation, difficult reintubation, delayed recovery, and difficulty because of pre-existing disease. Now, here you always remember that you need to keep the difficult airway cart ready before extubating these patients, and patients should be fully awake and obeying your commands. Recruitment of and subsequently you should see if it is possible, you can recruit the patient lung. If not contraindicated, you can supplement oxygen through endotracheal tube during extubation and extubate over the AAC or fiber optic bronchoscope. Limb 3, we have the 4 surgical causes, which is surgical cause for 3 surgical causes, which are surgical cause for airway compromise, suspected airway edema, and suspected airway collapse as well. Now, always here again, you have to keep in mind that you need to keep the difficult airway cart ready before you extubate these patients. In situations where you think that the airway compromise is likely to last long, especially in prolonged surgeries or surgeries with extensive upper abdominal surgeries, where we can go for an upfront tracheostomy before you extubate these patients. In cases where we think that you are not very sure of immediate airway patency after extubation, there you can delay that extubation and post-operatively ventilate this patient or let them breathe spontaneously and consider administration of steroids, and then subsequently you can extubate in the intensive care unit or over an AEC. In situations where you think that there is an airway collapse, in those situations, obviously you must go for a leak test to assess the airway edema or collapsibility. And if you think that there is a leak test is present, then obviously you extubate over an AAC or a fiber optic bronchoscope to be on the safe side. And if you see that the leak test is absent or unequivocal, then you may delay the extubation and extubate over an AAC. And if you think that the patient is leak test is absent, again you can do what you can do is you can extubate the patient in an OT under deep inhalation anesthesia. Now, even after that, if you see that the patient cannot be extubated and there is still an obstruction which persists, then you have to plan for reintubation and straight away go for tracheostomy. And for post-procedural plans, you need to supplement the oxygen continuously to these patients, observe for airway compromise in control and monitored environment, document difficulty strategies and adverse events, and counsel these patients. Thank you. At the end, I would like to acknowledge the IJ and the IDA officer bearers. Thank you so much.
Thank you so much, Dr. Mohit, for giving again an algorithmic approach. Routine extubation, of course, we're all familiar with, but for the different clinical scenarios. And I must tell you one thing, interacting with a lot of international faculty experts in airway management, they have really complimented us on the extubation guidelines, because they say it almost encompasses all the scenarios that you can face, whether structural loss of airway or whether it is an OSA patient or whatever. The stepwise kind of approach and the 3 limbs cover everything from all the different complex extubation scenarios. So thank you very much, Dr. Mohit. There's no specific question on extubation. If any of you would like to ask anything, any of the other panelists would like to ask Dr. Mohit any question on the algorithm? Dr. Apex, Dr. Amit, any question you'd like to ask Dr. Mohit?
One thing which I would, in fact, try to emphasize here is in most of the, if you see the other algorithm, in most of the extubation algorithm, one thing which they have not emphasized is, which we have always, as you said, for anticipated difficult intubation also, we emphasized one is pre-oxygenation. Now here, we emphasized mainly, if you see at one point of time, we said recruitment, which is very important in these patients to go for a very good oxygen reserve. At the same time, supplementation of oxygen post-extubation is something which we are always trying to emphasize. And at the time of extubation also, we are trying to give the air exchange catheter, where we would like to go for supplement oxygen through that catheter as well. So so naturally, we are also emphasizing not only the pre-extubation, pre-intubation oxygenation, but at the same time, we're trying to emphasize post-extubation oxygen, and before the extubation also some amount of oxygen to reserve to keep the patient at
I think one thing our guidelines have definitely highlighted, and which is very underutilized actually when people extubate, and a lot of problems are faced during extubation, is underutilization of the airway exchange catheter. Very few people use this. And extubation is a time when very few of the staff are present, all the equipment is packed away, the senior consultant is gone home, very junior person left with the extubation. And problems when they occur during extubation can result in significant morbidity and mortality. So I think our guidelines has highlighted this, the utility of the airway exchange catheter. And one more thing, like you rightly said, perhaps in our revised guidelines, the utility of oxygenation strategies post-extubation, especially in high-risk patients, perhaps the use of high flow or NIV, especially in kind of ICU patients, extubation followed by directly using high flow NIV as a bridge, rather than just giving conventional oxygen, maybe something we should consider. Any thoughts from any of the panelists?
Especially, Sheila, especially keeping in mind the present scenario, the COVID situations, where probably high flow nasal oxygenation and non-invasive post extubation, I don't know, it could play a major role at that point of time, especially in those patients.
Yeah.
Another one more thing regarding the recruitment. We also have to define the proper recruitment before the extubations. That will be the next step in our guideline. That could be a next step in our guideline.
Yeah, recruitment is one thing which is not being very much emphasized in other algorithms, but we have always emphasized this.
Yes.
I think we need to very categorically mention the procedure of recruitment and to the extent of recruitment as well. That is one thing which probably we can try.
And also perhaps, the leak test, better define how the leak test should be performed. Not only in the operating room, but also in the ICU where your tube is there for a long time, you're expecting a patient to have edema, how you could do it, quantitative, qualitative, what is the,
especially nowadays, since we are having a lot of prone ventilation, especially in ARDS patients where we are going for a prone ventilation, where leak test is very important in those scenarios.
So perhaps you need to define that better.
The studies have also quoted leak test especially in relation to COVID management.
So we have the leak test, but perhaps we can describe it better and talk about its current role. So thank you very much, Dr. Mohit. That was an excellent overview of our extubation guidelines. And we hope for a more refined and algorithm with the new update in December 2021. Now, in the interest of time, I will move on to the next session. And this is an excellent session where everyone is going to be involved. It's a session putting it all together. Today we've had, a session, first session where we had all the 5 devices and gadgets that were discussed along with videos by the 5 expert faculty. Followed by this, we had the IDA adult guidelines and the extubation guidelines. And now we'll have a panel discussion on cases of both anticipated and unanticipated difficult airway cases. And this will be led by Professor J.V. Devatia. Who better than Sir to take this? He is Professor and HOD at the Tata Memorial Hospital. And he's been the past president of IDA. He's been the past president of ISCCM and has a lot of accolades to his credit. So I request Dr. Devatia to please take this session forward. This will be the concluding session, followed by question answers at the end. Thank you, sir.
Okay, good evening. Thank you, Sheila, and thank you, Dr. Nivedita Pani and Dr. Rekha Das for this invitation. So we'll move on quickly to the difficult airway cases. And, we have lots of cases and lots of discussion, but very little time. So I'll just flash a few cases. I'll ask the audience. Okay, so there'll be some multiple choices for each case. And I'll ask the audience to quickly type in the chat box what would be their option. Okay, so 1, 2, 3, 4. So write case 1, 2, if that's 2 is your option, or case 1, 3, if 3 is your option. And then I will open it to the panelists, and then we'll see what sort of discussion sort of happens over there. Okay, so this is the first case, right? So this is a commando planned for carcinoma of the tongue. This is nice big proliferative growth on the right lateral border. It's crossing the midline. It's going quite a way behind as well. Ankyloglossia is present. The patient cannot stick out his tongue. So that's ankyloglossia. And his mouth opening seems to be okay. It's about at least 3 fingers. So audience, you can please type in the chat box, what is your sort of option for this? Would you want to do an awake fiber optic intubation? Would you want to do a video laryngoscopy with the patient awake, or an inhalation induction with spontaneous ventilation and intubation, or give you a normal IV induction with a relaxant, or go in for an elective tracheostomy upfront? So audience, if you can type in your chat box, what would be your sort of preference for something like this? So can I see the chat box? Okay, so please put in your plan for anesthesia.
To meetings and more, are we able to see their questions in this chat or Q&A? Because we don't see any responses.
Can't see any chats. So I think Sheila, I'll start with you. You're the opening batsman and sorry, batsperson.
Right. So among the choices, so this is definitely an anticipated difficult airway. So there's no question that I would like to do an awake technique, and this awake would, the choices that we have are.
To interrupt you, Sheila, but why do you think this is a difficult airway? This is mouth opening is quite good. I mean,
Yes. So that's a very good point you made. So if I was in a very remote setup, so then my choices are fiber optic intubation and video laryngoscopy. Now, if I had a fiber optic, I would do awake fiber optic. But if I was, say, in a very remote setting, then I would even start with the electric. Tracheostomy would not be wrong because this patient, the disease is crossing the midline. It's extending to the base. So it's likely to, surgeons are anyway going to probably perform a tracheostomy later. So that's not a wrong option in a resource limited setting. But considering I have all tools in my armamentarium, my choice would be an awake fiber optic intubation. So if you could just go back to the first slide, sir, just to show the picture. Now here the airway examination is paramount. So what people normally look at, they just say, okay, mouth opening is okay, so chalo, let's give GA, mass ventilation easy, mouth opening is okay. Now this is a lateral border of the tongue. So your direct laryngoscope, if you're doing direct laryngoscopy itself, it can cause bleeding. So you have to know the site. They extend, likely to be extending to base tongue, crossing the midline. Now you mentioned ankylosing. This is a very important clue that the disease is extensive. And if there is lateral deviation of tongue, the lingual and all would be involved, and this means extensive disease. So these are the cases you have to be very, very careful about. The decision to do fiber optic shouldn't come later. It should be an upfront decision because bleeding will start. And as we know, blood is an enemy for fiber optic intubation because your visibility will be completely obscured. So straight away, with proper preparation and counseling, awake fiber optic intubation should be the choice rather than landing up in a mess after giving general anesthesia. And awake video laryngoscopy, no, because again, any type of oral instrumentation and you will need a nasal tube, but putting the scope in the mouth itself might cause bleeding. So I would not go for a awake video laryngoscopy.
Okay, thanks. Amit, any other opinion, or you just agree with Dr. Shi?
Suppose if we touch it and if it is not bleeding, can we have awake video laryngoscopy as an option?
Okay.
So definitely number one would be awake fiber optic, but awake video laryngoscopy if it's not bleeding on touch.
Okay. So
Yes, I agree with Amit if it's not bleeding. And if you are not using Macintosh type video laryngoscope, if you are using hyperangulated video laryngoscope, so it's not going to cause pressure over the tongue, means submandibular tissue. And with that, we can easily intubate the patient.
So I just like
even awake video laryngoscopy with hyperangulated blade.
I think then even then you need to go for nasal intubation in this patient because
it's a nasal intubation.
Only
yes,
nasal. No, there is no doubt.
Hyperangulated blade with nasal tube. So hyperangulated blade will prevent the additional compression over the tongue.
I just like to make a comment. There's no doubt that we need a nasal tube, whether you use awake video laryngoscopy or awake fiber optic. But today we are in the era of safe airway practices. And this will never bleed to start with. You will be amazed how many of these lesions, just by surface contact, not even pressure, start to bleed and can be catastrophic. So in this kind of situation, though I am a fan of VL, I would say that fiber optic would be the safest option.
And if it bleeds with the fiber optic?
No, you're not touching the tongue lesion, are you? You're going.
I feel that awake fiber optic is the best option. There is no doubt about it. But then, suppose somewhere down the line, if you feel that you have a video laryngoscope and not fiber optic, then if it is not touching, you can always touch, give pressure, and find out pre-operatively. If it is not touching, if it is not bleeding on touch, then it can be considered. I still feel that the number one, the best option is awake fiber optic.
So I think we'll all agree that fiber optic is the best option. I personally would have reservations on video laryngoscope or any laryngoscope for the simple reason that this is going to the base tongue, towards the base of the tongue. And that's, where all your blades are going to go. And even if there's a little bleeding towards the base of the tongue, a video laryngoscope, the blood is the enemy of both the fiber optic and the video laryngoscope. It's even with a hyperangulated blade, you get it past the back of the tongue. So in the interest of safety, I guess fiber optic would be the best option. And, we often take our chances in practice with video laryngoscopy or sometimes even direct laryngoscopy, but I think the safest and the best option would be a awake fiber optic in this situation. And fiber optic will not touch the tongue or any part of the base tongue. So I guess that should be quite okay. Yeah. So Rakesh, you've not said anything, but I presume you agree with whatever we've said.
So
I agree,
moreover,
sir.
so one point is once it starts bleeding, you cannot switch over to fiber optic.
Yes.
But instead, if fiber optic is creating problem, you can switch over to video laryngoscope. It's not the vice versa. So that's a problem because once it starts bleeding,
Even video laryngoscope, once the bleeding starts, your visibility gets obscured. So
then
both for any video devices,
it is visible to certain extent.
Another important thing, if surgeon is going to perform the tracheostomy at the time of recovery, why not to perform at the start of the surgery? So that is the most safest method.
Yeah, but if you're not very sure, or you can of course go in with the fiber optic. But like I'm saying, surgeon, if he's going to do, or you don't have fiber optic, my second choice would be an elective tracheostomy.
And another thing, the lesion is crossing the midline, extending up to the base of tongue. So as such, they are going to cut the genoglossus.
So likely to be needed.
Likely to be cut the genoglossus. So better to have a tracheostomy prior to the surgery.
Regarding tracheostomy, I have one point here. When for those oncosurgical procedures, the upfront blind tracheostomy is usually not done because you'll be going through the plane of their dissection.
Correct.
So in our practice, what we do is we secure the nasal intubation in these patients. They do a neat dissection, they clarify everything, and they are not infringing into the plane of oncology so that the recurrence and metastasis decrease. And if required, as you read, it is crossing the midline. This is one. Second, this is going to the base. So this patient would require tracheostomy. So at our center, we are doing tracheostomy at the end of surgical procedure, depending upon to what extent they have removed and genioglossus is safe or not. But upfront tracheostomy is not a good option from oncology point of view.
Yeah, I agree, Rakesh. This is a very good point. I was just saying that in a remote setting, if you had no tools like this in your armamentarium, that the safest solution would be tracheostomy.
The other thing that I would like to point out is, if I may continue, that I agree with Dr. Rakesh that tracheostomy, the issue is that you have a PMMC flap or something like that coming in the field. So after they have a flap, then if you do a tracheostomy, they're sure that the plane for the flap is clear and you are not impinging onto that.
Yeah, so I think the best option is to do an awake fiber optic and let the surgeon do a tracheostomy at a time that is suitable for them. And like Sheila mentioned, if you have no other option, if you don't have access to a fiber optic scope, then the best option is awake tracheostomy upfront. Then the other things don't matter. So I think
one point I just want to emphasize, sir, and this is also when I joined Tata. Just one point is, don't just look at adequate mouth opening to decide whether you want to give general anesthesia, and there are a lot of other examinations that is required for oral malignancy.
Like we mentioned, ankylosing is a key sign, and extension towards the base of the tongue and crossing the midline are also important, very important factors. Okay, so we'll go on to this case. Okay, this is, you can see the extent of edema and swelling and all. This is a young male with a retropharyngeal abscess, and he's got cellulitis all over, and it's extending up to the chest wall. The whole neck is turgid and it is stony hard with that edema, and he needs drainage of the abscess. He's got a little limited mouth opening of about 2 fingers. Mohit, what would you like to do in this?
So mouth opening is 2 fingers.
Yes.
Okay. So again, I would like to go for, because if it is 2 fingers, I would always go for nasal fiber optic one. Second thing is, if there are certain devices, video laryngoscope, which can accommodate less than 2 fingers, video laryngoscopy, that can be possible if you go with oral. So first preference will be always fiber optic nasal in this.
Awake fiber optic.
Yeah.
And awake video laryngoscopy?
Awake video laryngoscopy, see 2 fingers. As I said, sir, there are certain devices which can be accommodated within these 2 fingers. Awake can be done in those situations as well. So that is my second option.
But he's got a retropharyngeal abscess and he's got a lot of inflammation inside the pharynx and all.
Yeah.
So how would you, for both awake fiber optic or awake video laryngoscopy, how would you give topical anesthesia for this?
So the only thing is you have to go say as you go, spray as you go. That's the only way. You cannot go for any other injectable methods, or you can, at the same time, you can go with a spray, this nasal spray, an oral spray, glossopharyngeal spray. That is again the puff and the nasal, inhalational, nebulization with local anesthetics. So 3-4 techniques you can go. You can go for gargling as well to a certain extent.
Okay. Jason?
You're muted, Jason.
Yeah. So I would go ahead with a awake fiber optic nasal, because I don't know whether this abscess is actually pointing somewhere in the oral cavity. And if I put a video laryngoscope or a conventional laryngoscope, even with an awake technique, I'm worried about rupturing the abscess and causing pus spillage on the field. And there's a lot of inflammation there. So something which is more under control, maybe an awake technique with nasal route with a fiber optic scopy, is with a spray as you go technique, is my technique of choice.
Apex, you wanted to say something?
Yes, sir. Important thing is an inflammatory reaction, a lot of inside the oropharynx also. There will be a lot of exudate into the oropharynx that makes the fiber optic scopy a little bit difficult. And even a regional block is not possible inside. You have to go ahead with the Sprague technique. So in my experience, considering my experience, I'll go with the awake fiber optic with Sprague technique, and I'll continue oxygening through the instrument channel of the scope. So that will prevent exudate to come over the scope, and we'll get a clear vision of, in most of the cases, and we'll proceed with the awake fiber optic.
So I think Apex brought a very important point that you can expect a lot of edema inside as well, in the oropharynx, as well as maybe even towards the laryngopharynx. And you might find that even fiber optic views may be a little difficult. You might not be able to identify everything very easily, and things might be quite edematous. So while fiber optic is a good choice, it's also needed an experienced person to do that fiber optic, because it could be quite challenging to visualize.
So one point we have to keep in mind here is, since it's an inflammation, a lot of inflammations are there, and we are giving local anesthetics. So that is something which which will always we have to keep in mind the toxicity and the amount of the quantity of the local anesthetics which we'll require.
See, another point, Dr. Mohit, is that when we are spraying the local anesthetics over the inflammatory tissue, we will not get the desirable effect of the local anesthetic.
That's what I'm saying. So
it is very important.
Increasing your dose. That's what I'm saying. That means you'll go on increasing your dose. So that you have to keep in mind, that you don't overdose your patient with the local anesthetics.
I'd just like to add one point, that no question that this has to be done awake for the reasons already highlighted. But this is a place where even awake fiber optic intubation is very challenging. So most important thing you need here is good patient counseling and cooperation. And spray as you go technique, but even that has its limitations. Like you're saying, it may not work too well. So my technique would be awake fiber optic, but this would be something that needs to be done by an experienced operator. It's not a routine awake fiber optic intubation. So even the fiber optic intubation itself is going to be challenging in this case.
Anything to add?
I agree, sir.
I'll agree.
Yes.
I also agree. Experience fiber optic intubation.
So continuous oxygenation, counseling first, continuous oxygenation, and then spray as you go, and awake fiber optic. These are the four.
In addition, I will suggest a good working suction equipment must be ready.
Yes.
And your table should have head down options available, because there are chances that sometimes this abscess can rupture, and then it's a tragedy. So a working wide bore section, usually a Yonker section cannula along with a head down option must be available for this. And patient cooperation is very, very important, because he will be in distress because of cellulitis, as you mentioned in the case. So good patient counseling is very important. We cannot give him sedation or opiates, but his cooperation is paramount. So maybe a good counseling session is also paramount.
Another important reason why not to give GA.
One is nasotracheal intubation or orotracheal intubation?
Nasotracheal.
Nasotracheal. Na?
Suppose someone suggests that why don't we just puncture that abscess under local anesthesia, just with a needle, aspirate out the abscess, and then after some time attempt to do the intubation.
But so how would you meet the area of maximum pus? How will you meet that?
It would be an incomplete clearance.
How will you meet that area?
Not advisable.
Multi-loculated inside. If you have a needle in one of the locules, that is going to drain pus only partly. The other locules are still intact. So how are you going to drain the pus completely?
The surgeon will want complete drainage, and he'll want the area to be secured.
Exactly. You will not be able to actually access that area, the exact where the pus point is.
I think we should not accept the surgeon to go ahead with anything without securing the airway first.
So fiber optic, difficult fiber optic, challenging, but that's probably the best option available, right? Okay. So we'll move on to the next case. Okay, so this is a lady who had a very big thyroid, and as you can see, the thyroid has been excised. Okay, so the surgery is over, and now at the end of surgery, it's been a long and difficult surgery. The trachea appears to be soft, and the surgeon says trachea is quite soft. And what is your thing for extubation of this patient? Would you just extubate this patient on the table, or would you leave the tube in and extubate the following morning after about 24 hours? Or would you exchange in the OT or in the recovery room after a couple of hours over a tube changer when she's fully awake? Or because the trachea is soft, go ahead and do a tracheostomy, or you do something else? Mohit, you spoke on the extubation guidelines. Would you like to start?
So we must know the history of this patient preoperatively. The patient had any problem of dyspnea at the time of sleeping, or there was any sign of compression, along with the investigations where the X-ray and the CT scan.
Soft over there, and you saw the size of the tumor.
Sorry, sir.
You saw the size of the tumor, and the surgeon telling you the trachea is not good.
That tells you that probably the patient will always have some amount of tracheomalacia, tracheal collapse at the end of the surgery. So in that case, obviously, I would always go for first and foremost, I would like to go for leak test, find out what is the situation, and then I would like to go for even if if the leak test is present, then obviously I will go with an airway exchanger, and then I extubate. If the leak test is absent, delay my extubation for another 24 hours, and even after that, we have to go for again an AAC under the under the guidance of an AAC. We can extubate and find out if he's not again the patient has an obstruction. Then obviously I can go for an upfront tracheostomy. That's the only thing. But obviously we have to go for a leak test and keep everything ready.
May I add to this, sir?
Yeah.
So I think like Mohit said, the history is very important, long-standing, big tumor. And the most important is that the trachea appears to be soft. This itself tells you that there is some tracheomalacia and there is a likelihood of collapse. Now, again, I don't think the leak test will have any value in this situation because this is dynamic airway collapse. Till the tube is in, there won't be any problem. But the moment, even if you deflate the cuff, you will have the leak test will be fine. But the moment you take the tube out, and that is when there will be dynamic airway collapse because this is tracheomalacia. So if you want to, seeing this kind of history, I would not extubate this patient. I would wait for 24 to 48 hours. Just keep the tube and maybe some pressure support. The reason being because the fibrosis sets in, stabilizes the trachea, and then the extubation is likely to be successful and you can avoid a tracheostomy. Tracheostomy here would be an overkill. But if I want to give a trial on table, then I would do it over a tube exchanger. If I keep it for 48 hours, then my strategy for extubation would not be over a tube exchanger. I would actually use a bronchoscope. And the way I would extubate this patient, because this is dynamic airway collapse, is I would put a bronchoscope through the endotracheal tube, deflate after 24 to 48 hours when I think maybe the trachea has stabilized and it is ready, time for extubation. Keep the surgeon on standby. In case it fails, we will have to do a tracheostomy. But the way I would extubate this patient is deflate the cuff of the endotracheal tube and go on withdrawing the endotracheal tube, keep the flexible bronchoscope distal to the tube, and I keep on viewing the distal part of the trachea to the tube as I am pulling out the tube. If at any point I see that the trachea is collapsing, that means the problem has not been sorted out. I'll just slide the tube back over the bronchoscope and not extubate this patient. Whereas if I use an airway exchange catheter, I will not be able to visualize this. So this is one setting where a bronchoscope will score over an airway exchange catheter because you can actually visualize dynamic airway collapse and avoid a re-intubation, but by just keeping the tube where it is and not extubate the patient. That would be my strategy.
So, Jason, anything?
Sir, I agree with that. Not immediate extubation, wait for 24 to 48 hours and then take into OR under inhalational agent. Probably I would do a fiber optic scopy and gradually withdraw the tube and see whether there is any distal airway collapse. So that would be my strategy too.
Can we do this thing immediately on table? In the sense, we try to see immediately on table with the fiber optic bronchoscope, we see the collapsing segment. And if it is collapsing, fine. We know that it is collapsing. We wait again for 24 hours and again do similar procedure. If it is still there, then you go ahead with the tracheostomy. Otherwise, you can remove the tube.
I agree with Amit. We can even try.
I'll have a little bit different opinion. So there are two reasons of airway compromise in this case. One is airway edema over the trachea, inside the compromising the lumen, and second, soft tracheal rings that leads to tracheomalacia. These two things. So whether leak, just a minute, whether leak is present or not, I'll wait for 24 hours. And meanwhile, within this 24 hours, I'll take the measure to reduce the edema, and then I'll extubate the patient over the fiber optic scope. So by that time, 24 hours, most of the edema gets settled. And if there is a collapse, that is purely because of tracheomalacia. If I find a tracheomalacia, I'll reintubate the patient over the scope and directly go for the tristomy.
Apesh, why do you expect airway edema? Airway edema?
Because of tracheal dissection. It's a huge tumor. Tracheal retraction.
I think Apesh, you brought out two important points. One is there a potential for airway collapse because of tracheomalacia, and the second is airway obstruction because of laryngeal edema, or cord palsy. Okay, because of the major thyroid surgery that has happened. Right?
Yes.
Can I add one point, sir?
Rakesh.
Sir, usually what we have seen in these patients, whether it's a benign goitrous mass which have extended over time vis-a-vis malignant mass, the involvement of tracheal collapsibility can be seen. But the other aspect, we need to look for the length of the tracheal collapsibility. So one of the feature that we can ask for is when our surgeons are doing it, we just ask how many tracheal cartilage, usually the upper one, they can feel and they can say that these cartilages are really soft. So if the extent of tracheal cartilage involvement is more than 2 to 3, then definitely there is no indication to extubate them on table. Then probably this becomes a higher chance, and maybe they require more than 24 hours for ventilation. So there is no even a chance for doing leak test on table for ventilating it, because some of them, because of the lymphatics involvement and all those things, the edema is going to increase in first 24 hours. So these patients should be kept not only for the purpose of tracheomalacia at that point of time, but also because of the lack of support and the increasing edema because of lymph node dissection and vascular dissection. They should be kept for intubating for 24 hours. Secondly, the 24 hours versus 48 hours, obviously leak test can be done. This is one. But if somebody is having a softening of the tracheal cartilage of more than 2 or 2 to 3, this means it's a long segment and the support will not happen. Sometimes we see a small thyroid nodule which is sitting on the one tracheal cartilage and softening it. The tracheal cartilage above and below are well preserved. In those situations, probably these patients are extubated 24 hours because the trachea will be supported from one cartilage above and down. So this will be an additional tool which we are doing it by asking our surgeons intraoperatively and giving a good option for us to take a decision. Though we do not have an evidence yet, but experience-based, this we are finding useful to ask the surgeon how many tracheal rings are softened.
Let me ask you two questions here, okay? And anyone can take it. One is, just because the trachea is soft, doesn't mean it's going to collapse, right? Doesn't mean that there's going to be tracheomalacia to the extent of causing tracheal collapse and obstruction. That's one. The second, the leak test. How good is it to determine obstruction due to tracheomalacia? Because, you know, when tracheomalacia, the leak, they are going to give positive pressure, and that time the trachea is actually going to expand. So whether the leak test is good for tracheomalacia, I agree it's very good to detect laryngeal edema. So if there is laryngeal edema superior to the cuff, you know, proximal to the cuff, the leak test is very good. But if there is a collapse around the cuff or below the cuff, how accurate or how useful is the leak test, Rakesh?
So that is what I said. If we know about the involvement of tracheal rings, so this will give a fair hint. You are absolutely right, sir, because we are checking the collapsibility at the level of mid trachea where the cuff is being inflated. We are not talking about up and above. So we have to look for the extent of trachea and its adhesions to the trachea while they are removing it to the surgical procedure. So that's why this is. And what Dr. Sheila also mentioned is one of the very good option. Rather than using blind airway exchange catheter for extubating, it's always use a fiber optic bronchoscope as a tool for airway exchange catheter, so that in case if we see the collapsibility distal or proximal to it, then we can re-intubate. Maybe we can ventilate for another 24 hours, or maybe we can plan for tracheostomy in these patients and then decannulate after a week or so. There is some evidence, there is some literature, though this is I've seen only in 2 patients. When there is tracheal involvement is too much, they just put up a suture to the strap muscles. Though we don't have a robust evidence that this will prevent collapsibility, but this may be one option that we can think of in patients who have extensive involvement of trachea with collapsibility, that if they can just make a suture with the trachea with the resolvable suture so that fibrosis can happen and patient may have some fibrotic adhesions leading to the contour formation of the trachea.
Yes.
So if I may add one point. So the three things that have been highlighted is one is about tracheomalacia, second is about the nerve injury, and third is about the edema. I would put edema very low down in my cards because neck dissection, lymphatic dissection is done in almost all head and neck surgeries, but it doesn't result in edema. We're never worried about that during extubation. So this is very less likelihood of this happening, though of course edema can happen after any surgery. It would be tracheomalacia, and if it is dynamic collapse, again the leak test has no role. The sensitivity and the specificity of the leak test is low, so you cannot just extubate, you have to do it over a bronchoscope, as Dr. Amit also highlighted. Now, in this kind of setting, a lot of time, like if a couple of rings are removed, the surgeon himself will tell you don't extubate this patient or will insist on doing a tracheostomy. I agree, tracheostomy may be a overkill without giving at least one trial of trying to extubate the patient and avoiding a tracheostomy and waiting for maybe 48 hours. So I would say that more than edema, one should look, and also nerve injury, because if you're not doing it, most of these surgeries are done with neuromonitoring now. So a lot of chance that it may actually not even be tracheomalacia, but you may need to actually do a tracheostomy because they have caused nerve injury. So these are the, I would say tracheomalacia and nerve injury would be higher on my cards than edema vis-a-vis other surgery in this kind of setting.
So let's say, can we say that most people agree not to extubate on the table?
Yes.
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 Okay. Then next, so we are going to then extubate the next day after 24 hours or maybe 48 hours. But let's say at 24 hours or the next morning, you will try and extubate. And we will agree that we will first visualize with a fiber optic bronchoscope as we are withdrawing the endotracheal tube. Is that also agreeable?
Yes, sir.
And I think we should not just look at the trachea, but we should also visualize the vocal cords when we withdraw the trachea, tracheal tube, and see whether there's edema or whether there's a nerve injury resulting in vocal cord palsy, either one or both or whatever it may be. Right? And then we can decide on the future plan of action.
So in that case, do we need to go for a supraglottic airway device as well?
So that was the other question. So I was reading in some CME somewhere that they do something like a Bailey maneuver, at the end of surgery. You put a supraglottic. Now, again, this is a very advanced technique and I can't do it. Maybe Apex can do it or maybe Sheila or Rakesh can do it. But so at the end of surgery, you put a supraglottic device behind the trachea, okay, and do a fiber optic examination with the trachea out. So you exchange basically the supraglottic, the trachea for the tracheal tube for the supraglottic device. And then through the supraglottic, you do a fiber optic examination, see the vocal cords, see the tracheal collapse, and if anything is there, you again go back with an endotracheal tube.
So I would completely discourage this maneuver. First of all, Bailey's is something that is to be done by an experienced.
I said I can't do it, but
no,
would be brave enough.
I would not do it. Even I would not do it because what you're doing is you are removing the endotracheal tube and you're putting in a supraglottic airway device. If you fail, what you're going to do, you're going to re-intubate the patient again. You can avoid all this by doing what Dr. Amit rightly said. Even if you want to do it on table, put a bronchoscope through the tube, keep withdrawing the tube. And if you see any collapse, you can slide the tube back off on. So you can avoid this again, re-intubation. You don't extubate the patient.
So I think we'll go back to what we agreed on. Whatever we do under vision with the bronchoscope, preferably on the after 24 hours. Right?
Sir, there is one question in question and answer chat. Someone has asked, if we don't have fiber optic, then what?
That's exactly the question I was coming to. So if you don't have access to a fiber optic, because thyroids are done all over the place.
Airway exchange catheter.
Airway exchange catheter.
At least that, yeah.
So you will not leave the trachea unguarded for at any point in time, right? So you will put in a tube, you will put an airway exchange catheter through the tube, pull out the tube, and then hope for the best. And if there is airway obstruction, because now you won't know whether it's because of airway collapse, because of tracheal collapse or cord edema or vocal cord palsy, but then you will re-intubate over the airway exchange catheter, and then you will have to do something to find out what exactly is happening.
I think the important message here is
cost is the, sir, just
an anticipated difficult extubation, airway extubation. at the least we should use an airway exchange catheter. We should not extubate with the airway.
Especially in these situations, we always should always keep an airway exchange catheter, extubate over an airway exchange catheter.
Don't be in a hurry to extubate, right?
Yeah.
Take your time, extubate the next morning when the patient has settled and everyone has settled down.
And remember, unlike intubation, extubation is always elective. There's no emergency to extubate. So if you're not sure, you can always wait for a few hours. You can always call an expert. You can always get a bronchoscope from another institute. There's no emergency to extubate. It's an elective procedure. So you are not pardoned if you extubate this patient and he has some morbidity or mortality. So take your time and plan it carefully and do it wisely.
And the other thing is, please keep 2 hours free to observe this patient after you extubate him. Right? Don't run away for the next case, or if you're working in that practice where you have to induce a next case with no supervision of this patient needs to be supervised with someone to be able to re-intubate and assess the airway for at least 2 to 4 hours or 6 hours after you extubate this patient. Yeah. Okay. So I think we can move on to the next case. We have about 10 minutes more, so we'll go on to one unanticipated difficult airway scenario. And again, this is the algorithm which all of you have been through. So this is roughly the principle we'll follow. The reason why I'm putting up this case is, the algorithms is very nice and logical, but when scenarios happen in the theater, suddenly you have a lot of options and you need to make sure you're going in the logical fashion, right? Okay, so this is a young lady undergoing laparoscopic hysterectomy, right? So under GA, she has, everything seems to be okay. There is no past history. The airway examination was unremarkable. So you induced her with propofol, fentanyl, and then you do bag mask ventilation, and you find that it is difficult to do bag mask ventilation. You've not given a relaxant, you've given propofol, fentanyl, propofol, and now you're testing before you go ahead with the relaxant, and you find that it's hard to ventilate and the saturation starts dropping. So now what are your options? One, you will increase the depth of anesthesia and then insert a laryngeal mask to ventilate the patient. Or in spite of the fact that you're finding it a little difficult to ventilate after fentanyl and propofol, you'll go ahead and give a relaxant anyway. Third, you will try to perform some maneuvers to improve mask ventilation, like maybe put an airway or improve your jaw thrust, or two-handed ask an assistant to bag and while you hold the mask well, or you just try and intubate the patient, or you do something else. So if anyone has any questions, 1 minute. Let me see if someone puts something in the chat. They have started putting up.
So can you go back to the first slide, please?
Yeah. So please put in the chat all these things. Okay. Any 1, 2, 3, 4, or 5. Okay. This is the first slide.
Okay, sir.
And these are the options. Okay. No one has put up anything in the chat. So who wants to take this first? Apex?
Yes, sir. I'll optimize the patient position and mask ventilation grip, optimize the grip of the mask ventilation, and then give relaxant, and then try again give a chance of ventilating the patient with the mask.
Okay.
So that's my...
First, you'll do number 3. You'll try something to optimize ventilation.
Yes.
And then you'll
give relaxant. Then relaxant.
The patient is still difficult to ventilate after you try to optimize ventilation. Mask holding and all that. Will you give a relaxant or you won't give a relaxant?
I'll give the relaxant.
You'll give the relaxant. So even if you find there is difficulty, you will go ahead and give a relaxant.
Yes.
Okay. I'll ask the others, but I'll come back to you. So Rakesh, what will you do?
I think first is optimization, ventilation, and maintaining depth of anesthesia. This is paramount, because checking for bag and mask ventilation just after induction with inappropriate depth and neuromuscular blockade itself is a difficulty. So that will optimize first, and then we can go ahead and give an supraglottic airway device to maintain it.
Okay, so you'll do first 3 and then you'll do 1. If it doesn't work, you won't give a relaxant. You'll instead.
Relaxant you have already given to him.
No, not given. Not given.
In that sense, we'll give relaxant also, sir.
So you'll go 3, and so you'll follow Apex's line, right?
Yeah. 3, 1, 2.
I think 3, 1.
3, 1, 2. Yes.
I think
3, 2, 1.
3, 2, 1. 3, 2, 1.
3, 2, 1.
One sec. Hold on. As far as I have understood, Apex and Rakesh want to do 3, improve mask ventilation. Then they'll give a muscle relaxant, even if the mask ventilation is not doesn't seem to improve. And then If and then even after relaxant, the ventilation is not good, then they will increase the depth and put a laryngeal mask. Is that right?
Sir, DAS and muscle relaxant will go hand in hand, sir, I think.
Oh, fine.
Yeah.
Mohit and Jason are going as 3-1-2. First,
No, 3-1, sir. 3-1.
3-1.
I'll go for first is perform maneuvers to improve mask ventilation.
Increase.
And then obviously if I'm not being able to do mask ventilation, because at times what we feel mask ventilation becomes difficult when the patient is not relaxed properly. So naturally at that point of time, I would like to go for muscle relaxants and then increase the depth with anesthesia and go for LMA.
So I think what everyone is saying is that, even this is a very common practice, and this has been ingrained into us since at least I was trained in anesthesia. And even I guess even the trainees are being taught of this today, is that always after you give an induction agent, test for bag mask ventilation. If bag mask ventilation is not good, don't give a relaxant. But here I think the experts are saying something that just go ahead and give a relaxant because that improves bag mask ventilation.
Exactly.
Right.
So may I add a comment?
What is your comment?
I would do, of course, this is initial difficulty. I would do 3 first, but I would do 1 and 2 simultaneously.
Okay.
I mean, together almost, I can say. And look at the situation here, 94, your saturation is already dropping. After giving muscle relaxant, your chance of being able to successfully ventilate this patient are higher. So by not giving it and the patient further desaturating, you're really not achieving anything by not giving it. So there has definitely been a paradigm shift in the way we are looking at this, the initial, we're actually giving muscle relaxant to improve our ventilation, improve our chances of success, rather than not giving it if it's difficult.
Okay, so I think that's a very important message that has come through. But please remember, we are talking of this patient who doesn't have any adverse features on the airway examination, right? We are not saying you should give a muscle relaxant if the patient has an obstructed airway or any of those dirty cases which we showed you in the first few slides. So in someone who doesn't seem to have any adverse features on the airway examination, very often giving a muscle relaxant actually improves the ability to do good mask ventilation, right? Is that okay?
Yeah.
Yes, sir.
Yes, sir. Okay, so now here what happened is, fortunately with a little, with putting an airway and so on, they were able to maintain bag mask ventilation, saturation came up, and then they gave vecuronium. Okay. Now, unfortunately, what happened is after they gave vec, again there was difficulty in bag mask ventilation, and now the saturation drop was it went down to 90%. Right. So you overcame the initial difficulty in bag mask ventilation, but after you giving the relaxant, again it became difficult. Bag mask ventilation, something happened and this thing. And in spite of optimum mask ventilation technique, the saturation started falling. So now what would you try to do? One is just try and intubate this patient. 2, put a laryngeal mask and try to ventilate the patient, some kind of supraglottic device. 3, use a video laryngoscope. So 1 and 3 are probably the same. 1 is with a standard laryngoscope, 3 is with a video laryngoscope, and 4 is try something else. So
I will go ahead with the putting the insert LMA, but I will also consider putting apneic oxygen. I don't know whether it was apneic oxygenation is on or not, but we'll continue with apneic oxygenation, give 15 liter of oxygen and put supraglottic airway.
So you would go ahead. So a good point is that you should actually have in all these situations where you should maintain apneic oxygenation, right? So that's a very good point. But as far as these choices are concerned, you would go ahead with a laryngeal mask airway, right?
Yes, sir.
A supraglottic device. Okay. Anyone else? Any other opinions?
So I just like to say that what the clinical setting is very important. Here the saturation is 90. There's no time to do a direct laryngoscopy or video laryngoscopy. By the time you put your scope in, the saturation is going to plummet down and there'll be precipitous drop. So definitely insert a supraglottic airway device. Again, coming back to Dr. Amit's point, the apneic oxygenation will work provided you've done good pre-oxygenation. So then the apneic oxygenation, and I think not only in this case, but routinely we should consider giving nasal oxygen during attempts at intubation. So I would put in a LMA and try to ventilate this patient.
Sir, I'll go for the same. I'll pass the supraglottic airway device, but at the same time, I'll ask my colleague or other staff to get ready with the cricothyrotomy.
Okay, so you're already thinking ahead. So you're calling for help and you're doing all those other things that preparing for the next 2 steps, which may be required, right?
Yes.
I think that's also a very important piece of information and some fantastic advice from Apex.
I think that's a very good point because, I would wonder why after giving muscle relaxant, this mask ventilation has become difficult. That would worry me a lot. So definitely preparing for an emergency cricothyrotomy at this point, because we don't know what we are going to expect. So that is, I think, a very, very important statement that Dr. Apex has made.
So, but as of now, everyone's happy with putting in a suprachoroidal device and going ahead?
Yes.
So, Rakesh?
Yes.
Amit?
Yes, sir.
Okay, thank you. Okay.
So only one point what I had and query was that the patient was having 90% saturation.
Yeah.
And if you see our guideline, probably we need to make the patient to 95% saturation. So if you think about that aspect,
so they're not able to.
Ventilation was not possible.
So naturally, my point is, why was, as Dr. Sheila said, that why is the patient desaturating despite the patient's saturation improved? Subsequently, he desaturated, she desaturated. So what was the point? What was the reason behind it? That could be a real, finding. Of course, that is the point when we need to keep a cricothyrotomy ready.
But we don't know, Mohit, and we can't mask ventilate. So we have to put in supraglottic airway device.
Yeah, supraglottic airway device is the choice. That's the ultimate, I know. But then we have to keep that.
Put in a suprachoroidal device, and again, but 2 attempts, both were difficult. It resulted in bleeding in the larynx, in the pharynx. Now you're not able to ventilate either by mask or by suprachoroidal device, right? Both have failed. The saturation has dropped even further. Now what are you going to do? So you never attempted with a laryngoscopy and intubation in this patient. One quick attempt with some kind of a laryngoscope?
No, sir.
Attempt at fiber optic?
No.
One more suprachoroidal airway insertion?
Sir, I think we should not go out with even 2 attempts. One attempt at LMA, because saturation is still dropping. We should think of doing emergency cricothyrotomy.
Already twice are over. 2 attempts.
This was all happening before our guidelines were published. It was being done by someone who didn't know our guidelines.
No, that's fine. 2 attempts. Our guidelines says 2 attempps. So only 2 attempts.
But the saturation has to be 95. It is dropping.
Low. So after the first attempt, ideally you should not try a laryngeal mask.
Attempt, yeah.
Good point.
Second attempt.
Second.
My point is, was the patient totally relaxed to ensure whether the patient was adequately relaxed?
Yes, right after the
after election, saturation dropped down.
Yes,
but then whether it was still there, the relaxation was still there. We need to see that.
You need to put your phone on silent, please.
It's just about 5 minutes, so things are moving quite fast. So
surgical cric will be the only option in this.
Yeah.
We need to be, we are already prepared, as mentioned earlier by Dr. Sheila. So at this point, the decision would be going for surgical cric.
I completely agree with Dr. Rakesh. And at this point, the saturation is 80. There's no question of putting a video laryngoscope or fiber optic. Again, will be useless because the patient is bleeding. So the visibility will be very poor. And 2 attempts at supraglottic airway device have already been done. And there is trauma. So 3rd attempt is not warranted. And considering the saturation is falling, and if we have been wise like Dr. Apex, we already have the cricothyrotomy set ready. But if not, at least get it ready at this point. And you should not waste any time doing any attempts at supraglottic or fiber optic or video laryngoscopy or even DLVL. I think straight away do emergency cricothyrotomy.
And so I think the whole idea is that, because all these options have been tried in various situations in the past. And, it's time we abandon this method of thinking, chalo ek baar tube dal ke dekho. I think that sort of attitude is completely wrong and it must completely change. And this is a setting where you should think of nothing, like Rakesh said, nothing but a cricothyrotomy.
Would you all agree, like Rakesh said, this is complete ventilation failure? You are not able to ventilate this patient by whatever means possible.
Yes.
Absolutely.
Complete ventilation failure. And so now, what is your best rescue strategy? I think we've answered it. The options are, of course, surgical tracheostomy, percutaneous tracheostomy, cricothyrotomy, or tricho, right? Okay. So I think my time is up, and I guess we've covered a lot of what we've been wanted to cover. We've missed out on a couple of cases because the time was short. But anyway, so thank you all very much. I think we made some very important points. I hope the message went through to all the people who are listening in and on this case discussion.
Thank you so much, sir. You've covered all the aspects of both anticipated and difficult and unanticipated airway situation, even dynamic airway collapse and all aspects of difficult airway. So it was really very comprehensive.
Good evening.
Are there any questions in the chat?
Good evening and thank you very much.
Any questions in the chat for us?
I can't see anything in the chat.
No, I don't think so.
No. I think they have been quite clear about the whole piece of lessons that you've been teaching them. So,
So I'd like to end by thanking
Sheila?
Dr. Yeah, I'd like to thank Dr. Devatia and for taking this excellent session forward, and the entire team, all the faculty that have participated, and special thanks to Dr. Nivedita Pani and Dr. Rekha Das for giving us this opportunity to conduct this workshop. Thank you very much.
Thank you, Stella. It was wonderful. All your team has done excellent job, and it is really helpful for our postgraduates and to us also. Excellent. Congratulations.
So I would also like to thank Sheila, Dr. Rakesh, Dr. Shah, Dr. Patua, Dr. Devatia, and Jason, and Dr. Said for a wonderful session. You have made a very good overview of the entire thing and gone into the depth of each thing. And I did see a few questions from the students in between. Like they wanted to ask you, in the absence of fiber optic, what would you do in case of a retropharyngeal abscess? That was one question which was probably missed out. So I think if some of you can, any of you can clear that, then I think we can wind up the whole session. And thank you once again.
Okay, anyone wants to take that question? If you didn't have a fiber optic in that patient with Ludwig's angina from a retropharyngeal.
Yes, that's a question.
In that case, I'll make it sure, I'll make it available and then proceed. So ideally, all postgraduate students should do not compromise on airway management, make it available and then go ahead.
I think
Nowadays we have a cheaper version of it.
Yeah, I think
so why to compromise the patient's safety?
It's
Otherwise,
a very important point that Dr. Apeksha has made. Just saying that I don't have the bronchoscope is not enough. Make it available, transfer to the patient to a center where it's available. Safe airway management practices is the dictum today, not doing heroic airway practices, because you might land up in a mess, and it's not worth losing a patient who's just come with some infection for a reason like this. So we have the option of preparing for this, and we should get the scope available or get someone who uses it or from a center that has it available and with someone with the expertise to use it. But this should definitely be something done under vision. So I think this is where we are changing our practices today from heroic airway practices. Sometimes you might get away, but that doesn't mean the next time you should do it the same way. I think it's very, very important that we should not compromise, and we were unanimous that this should be done using a flexible bronchoscope.
I think every hospital has some limitations, and that limitations should always be taken care of. And depending on that, you should know your limitations, and you should not venture into those operative procedures. It's better that you transfer them. You should cut.
I think the message is very clear. So I think we should not really do anything heroic in the absence of any instrument. And this message is very clear right from the start. And with this, I think we would come to the end of the session. Thank you once again, Sheila, for such an enlightening topic and for an enlightening course, and to the whole team for their collaborative effort.
Thank you for the opportunity. Thank you, Dr. Devatia, Dr. Mohit, Dr. Rakesh, Dr. Apeksha, Dr. Amit, and Dr. Jason. It was a very interesting and interactive session. We would have loved to be there in Orissa and do a hands-on workshop with you, but unfortunately, this is not possible. Thank you so much.
Sheila, it is a future invitation to you and your group that anytime this corona scenario will improve, definitely you all are welcome to Orissa, and we will love it.
Thank you, madam. Thank you.
Thank you, madam.
Thank you, ma'am. Thank you, sir.
Thank you.
Bye.
Thank you.
Hello. Am I audible? Hello.
Yes, ma'am.
Am I audible?
Yes, audible. Audible.
Thank you. Thank you so much. Yes, ma'am. Yes,
All
ma'am.
the best. All the best.
Thank you so much, ma'am.
Video on the call.
Yes, ma'am. Ma'am, am I audible, ma'am?
Yes, Nitu.
Thank you so much.
You are audible.
Good evening, sir.
Good evening. Good evening. Good evening. Sir, namaste, sir.
नमस्ते, गुड इवनिंग
Sir, good evening. Namaste, sir.
नमस्ते, कैसे हैं? नमस्ते
सर बहुत अच्छे हैं
कैसे
सर.
हैं?
सर सब कुछ अच्छा है सर आपके उधर. मैडम सर.
Hi, Murli.
बस हाय मैडम, हाउ आर यू मैडम?
Fine.
Good to see
Nice
all
to
of
see you in this platform.
Things are changing, you know.
Yeah.
We are getting adopted to the newer requirements.
I think all have joined, all the GC members.
Yeah, they will join. Some might be in the hospital, some might be on the way.
Nivedita madam, namaste. President, namaste. And Devshis, namaste.
Namaste, Dr. Giri.
Sir, namaste, sir.
Good evening. Good evening, Venkat.
Every. I have switched on my video.
Venkat sir, namaste.
Namaste, everybody. Nivedita is looking very smart. Organizing chairperson.
I think time slot is going in time, no?
Yeah. When you are there, it should go in time.
Yeah. Thank you.
Nice seeing Devshis after a long time.
Sir, namaste, sir.
See, we traveled together in Odisha.
Yes,
and
sir.
after that, silver mementos are not going together.
Sir, you promised to come with your mom, sir. Again, but you have not yet fulfilled, sir.
Presidency, I will come. Hope this
Sir, thank you, sir.
Murali. He could not
Sir, thank you, sir.
Corona.
Again, Corona has the number has increased.
Increasing in Maharashtra, yeah.
No, in Odisha also, sir, we have 65 cases today recorded.
Naveen has come. Good evening, Naveen.
Good evening, sir. Good evening, Dr. Muralidhar Joshi, sir. Good evening.
Good evening.
Namaste, sir.
Namaskar, madam.
Good evening, Naveen.
Dr. Suresh, good evening. Dr. Virender, good evening.
Virender. President Rekha Das, namaste.
Good evening, sir. Good evening, Dr. Virender. Dr. Bhargav, good evening.
Good evening, everybody. Good evening.
Rekha, good evening.
Sir, namaskar. sir.
Namaskar.
Namaskar. Joshi sir, Naveen sir, Virendra sir, Venkatgiri sir.
I think all have joined. Or anybody left?
I think Manoj has to join, I think. Dr. Bala Bhaskar.
Devasis, just kindly give a call to Balabhaskar sir. I'm calling Manoj sir. Manoj.
Good evening, Dr. Bhaskar.
Good evening, Dr. Bala Bhaskar.
Balabhaskar has joined.
Yes, madam.
Yes, he has joined. Bala Bhaskar has joined.
Okay, I called Manoj also. If President sir give okay, then we'll start.
I want to wait a couple of minutes for Manoj to join. That
Devasis, just see Rajat has joined or not and Palay has joined or not.
Yeah, ma'am. Yes, ma'am.
Okay.
how hot is it in Odisha, madam? How is the summer?
Pardon, sir, what did you say?
How is the summer in Odisha?
Oh, summer, it's still manageable. It is not so hot yet. and it is sometimes it is sunny, sometimes it is it's very cool and it's shady. So we are having a mixed climate.
That's good.
But the humidity is there. Humidity is there.
Has Manoj joined?
I think we should start on time. He will join in due course of time.
Okay, okay.
Let us start in time.
Rekha, tell Manoj.
We can start now.
A very good evening to one and all. I, Dr. Neetu Gupta, Senior Resident, Department of Anesthesiology and Critical Care, SCB Medical College, Cuttack. I welcome you all to the inauguration function of 49th OSISACon and ISA Odisha WebCon 2021 on the 13th of March. It is a rare opportunity conferred on me to accord a warm welcome to the dignitaries of the day. To start with, I now request Organizing Chairman, Professor Dr. Nivedita Pani, HOD, Department of Anesthesiology and Critical Care, SCB Medical College, Cuttack, to give a welcome address. Over to you, Madam.
Respected dignitaries on the dais, a very warm welcome to each and every one of you to ISA Odisha WebCon 2021 and 49th OSISACon. At last, this beautiful day has arrived. अतिथि देवो भव कहती है भारत की धरा, स्वागत करके आपका निभा रहे हैं परंपरा. It gives me immense warmth and great pleasure to grace all of your presence in the inaugural function. It really gives me tremendous contentment to be presenting the welcome speech among the most esteemed personalities who have won accolades in their respective fields. The theme of the conference, Grooming Postgraduate to Skilled Anesthesiologist. So this conference will help the students to get into self-introspection as well as their achievements. This encourages the students to participate in various events and see their blossom into an excellent anesthesiologist. I am sure the conference will be fruitful for everyone present here. सभी कहते हैं रिश्तों में नो थैंक्स नो सॉरी की जरूरत नहीं है. सभी कहते हैं रिश्तों में नो थैंक्स नो सॉरी की जरूरत नहीं है, पर हकीकत में यही सब रिश्ते बनाकर रखते हैं. हकीकत में यही सब रिश्ते बनाकर ही रखते हैं. Thank you one and all. I love you all. Jai Jagannath.
Wonderful, ma'am. Thank you so much for your precious words. I now request our President, ISA Odisha, Professor Dr. Rekha Das, HOD Anesthesiology, AHRCC Cuttack, to welcome all the dignitaries of the day. Over to you, madam.
Madam, please unmute yourself, madam.
Yes, yes. Sorry. On this 49th OSISACon ISA Odisha WebCon 2021, I'm indeed privileged and honored to welcome our national leaders. who have all come together, spared their valuable time at one point of time, and have come on one visual platform. At the outset, I would like to welcome our National President, Dr. Muralidhar Joshi, sir, who is the chief guest of the inaugural ceremony of this function. Thank you, sir, for being there. I also welcome our Vice President National, Dr. Suresh Rathod, sir, for being there. Sir, welcome you too. And our President-elect, Dr. Venkat Giri, sir, enthusiastic leader.
गणनायकाय गणदैवताय गणाध्यक्षाय धीमहि गुणशरीराय गुणमण्डिताय गुणेशानाय धीमहि गुणातीताय गुणाधीशाय गुणप्रविष्टाय धीमहि एकदन्ताय वक्रतुण्डाय गौरीतनये.
I also welcome our President-elect Dr. K. Venkat Giri, sir, and our ever-dynamic Secretary National, Dr. Naveen Malhotra, sir. Sir, welcome, sir. And our National Treasurer, Dr. Virendra Sharma, sir, who is still in the OT but could spare some time. I also welcome our past President, Dr. S. Palabhaskar, sir, who is a strong support pillar to all of us. And nonetheless, our GC member is John Dr. Manoj Kumar, who may not be there, but who is always with us and a part of with us. I also welcome my EB members, Vice President of the State, Kishore Mahapatra, President-elect Dr. P.K. Pallai, our Honorary Secretary, Dr. Debashish Swai, Joint Secretary, Dr. Rajat Das, Past President, Dr. Mahendra Nayak, and all other EB members. Please join together to inaugurate this scientific program and the 49th OSISACon by lighting the lamp. Sir, I welcome all of you again to light the lamp and inaugurate this session. Sir, please.
Thank you.
Thank you so much, ma'am. Now comes the moment of lighting the lamp. May Lord inspire and guide all of us to serve humanity in true spirit. I now request our Chief Guest National President ISA, Dr. Muralidhar Joshi, for lighting the lamp ceremony with other dignitaries. Please, sir.
Sure. Thank you.
Rekha, please tell Manas to start.
Yes, ma'am, we are playing now.
गणनायकाय गणदैवताय गणाध्यक्षाय धीमहि गुणशरीराय गुणमण्डिताय गुणेशानाय धीमहि गुणातीताय गुणाधीशाय गुणप्रविष्टाय धीमहि एकदन्ताय वक्रतुण्डाय गौरीतनयाय धीमहि गजेशानाय भालचन्द्राय श्रीगणेशाय धीमहि एकदन्ताय वक्रतुण्डाय गौरीतनयाय धीमहि गजेशानाय भालचन्द्राय श्रीगणेशाय धीमहि.
Thank you so much. Now I would like to invite our chief guest, Dr. Muralidhar Joshi, President National ISA, to address the August gathering. Over to you, sir.
Respected Organizing Chairperson, Dr. Nivedita Pani Madam, Organizing Secretary, Dr. President of ISA ODISHA, Dr. Rekha Das, Vice President of ISA ODISHA, Dr. Kishore Mahapatra, Honorary Secretary, Dr. Debashish Swai, and of course, our own President-elect, Dr. P.K. Pallai, Treasurer, Dr. Rajat Das, and at the outset, we all from ISA National, we thank you for inviting us to the ISA ODISHACon, which is being in web format for the 2021. thank you so much, and I really appreciate the theme what you have taken, grooming of PGs for the future. And of course, that's a great event. I would like to say, I would congratulate. And I also acknowledge the presence of all our ISA National Governing Council office bearers who could find valuable time to share their thoughts with the ISA Odisha branch, respected Vice President Dr. Suresh Bhargava, President-elect Dr. Venkat Giri, Chairman Academic Committee Dr. Bala Bhaskar, Honorary Secretary Dr. Nayan Malhotra, Honorary Treasurer Dr. Virendra Sharma, Editor-in-Chief Dr. Lalit, our GC member from East Zone, Dr. Manoj. And of course, we are joined by all the other GC members and all our friends of ISA National. And our special, I would like to thanks to all the faculty and delegates of ISA Odisha 2021. Not to forget all the ISA National and of course state office bearers of the governing council all throughout. And we have a lot of friends in Odisha. And of course, we have one of our close friends who is no more with us, Dr. Mishra. How can we forget him? So this is something probably like he would have definitely cherished to be part of this particular event. But well, we have to get going with life and all. I can never forget March 13th in my life. I think Naveen will agree with me because this was March 13th last year, 2020, the first advisory from ISA regarding to all ISA members about the COVID water pandemic that was getting breaking. Like we said, please hold back all the physical meetings till further orders. That was October 13th, and we launched the whatever the advisories, and subsequently many series followed, and subsequently, what all happened last 1 year. Well, time moves on, time and tide wait for none. We had to get going. The going gets tough, the toughs get going, and probably we are IS members as COVID warriors, otherwise as vigilance officers. We are made for this one. Definitely, we'll definitely flourish, and we'll do much better than what we have done. Let's not drop the gun. And of course, the vaccination, definitely all of us, we should take, no exception as such at all. We should take it and continue to maintain the same, what are the masks we are supposed to wear, and hand wash, and of course, social distancing. Having said the customary things about the event as such and all, the most important thing I would like to say that ISA will be celebrating its Platinum Jubilee celebrations in the coming these 2 years, this year and next year. Of course, our Prime Minister announced about just about a couple of days back about the Jubilee celebration for next 2 years. We announced it on January 26, 2021. For next 2 years, a lot of programs are going to be conducted from ISA National with the help of ISA state and city chapters. And it's not only from the office bearers. We have a lot of other groups which are evolving slowly in ISA. Name it a sports club, name it a cultural club, arts club, literary club, Indian Journal of Anesthesia, IRC, FBF, you name it, and they are there. So we can expect a lot of activities for the Platinum Jubilee celebration. I request all of you to join this particular, all the programs for the next 2 years, and it will be make it a memorable and great occasion for all of us to celebrate in the coming 2 years. Of course, rare occasion, probably many of us are part of this ISA Platinum Jubilee celebrations. I'm sure with the help of all seniors, my colleagues, friends, and all my PG students and who are probably looking for the great future, we'll have a wonderful couple of years as Platinum Jubilee celebrations. It's going to be fantastic. I'm sure about that one. One thing I would like to say, because the spirit of ISA continues to vibrate and keep on doing much more bigger things than what we are doing. In fact, we are going to have the virtual SARC event in coming couple of months, and which will be followed by the physical events coming next year. So many things are lined up, and I will be again flooded with all these programs. I know, of course, every weekend all of you are stuck in front of the computer going through the jet factor, that is the Zoom factor. And hopefully the jet factor ends, and then we go into R factor, that's real factor. With these few words, we wish to once again all the best for the organizing committee for the fantastic event. Long live ISA. Jai Hind.
Jai Hind.
Thank you so much, sir, for your humble words. Now I would like to invite our guest of honor, Vice President, National ISA, Dr. Suresh Kumar Bhargava, to address the August gathering. Over to you, sir.
Good evening, everybody, and respected our ISA President, Dr. Mulita Joshi, our President-elect, Dr. Venkat Giri, the Chairman, Academic Committee, Dr. Bala Bhaskar, our Secretary, Popular Secretary, Dr. Naveen Malhotra, Dr. Virendra Sharma, and Dr. Nivedita Pani, Dr. Rekha Das, डॉक्टर देवाशीष एंड हमारे यहाँ बैठे सारे उत्कल प्रदेश के सारे एनेस्थेटिस्ट। मैं पहले सोचता था ये उत्कल शब्द जो राष्ट्रीय गायन के अंदर, राष्ट्रीय गान के अंदर उत्कल शब्द यूज होता है, इस उत्कल का मतलब क्या होता है। तो मुझे मालूम पड़ा कि उत्कल का मतलब उड़ीसा होता है। और उड़ीसा, जैसा कि डॉक्टर निवेदिता ने बताया, उड़ीसा अपने आप के अंदर एक बहुत ही हिस्टोरिकल प्लेस है। यदि हम अशोका का याद करते हैं तो उड़ीसा याद आता है, यदि हम कलिंगा को याद करते हैं तो उड़ीसा याद आता है। उड़ीसा अपने आप के अंदर इतना प्रभावशाली है हर चीज के अंदर, चाहे वो कल्चर हो, चाहे उसका डांस हो। उस डांस जो 2000 साल से वो डांस कंटिन्यूसली इंडिया के अंदर कोई डांस रहा है तो उड़ीसा का डांस रहा है जो 2000 साल से प्रचलित है। और पिछले कुछ सालों के अंदर उड़ीसा वालों ने बंगाल वालों पर एक केस कर दिया कि सर रसगुल्ला भी हमारी देन है, और वो रसगुल्ला भी अल्टीमेटली वो उड़ीसा वालों के पास ही गया कि साहब वास्तव में रसगुल्ला जो है वो उड़ीसा का ही है। तो मैं आप सब लोगों को प्रणाम करता हूँ। और उड़ीसा के बारे में तो मैं कभी वहाँ आया नहीं, लेकिन मेरे बहुत सारे मित्र, मैंने दिल्ली के अंदर राम मनोहर लोहिया हॉस्पिटल के अंदर सीनियर रेजिडेंसी की थी। वहाँ पर उड़ीसा वाले लोगों का गढ़ है। वहाँ पर 70% सीनियर रेजिडेंट या रेजिडेंट उड़ीसा के लोग होते हैं, बहुत अच्छे लोग होते हैं। मैं जहाँ जहाँ गया, सऊदी अरेबिया में गया, डॉक्टर सामंत था, एक प्रोफेसर सामंत था हमारे साथ थे। ओमान में गया, डॉक्टर एपी सिंह हमारे साथ थे। हमारी आईएसए के अंदर डॉक्टर मिश्रा हमारे साथ थे। डॉक्टर, इतने सारे लोगों के संग मेरा रहना हुआ, बहुत अच्छे लोग होते हैं। जैसा कि डॉक्टर हमारे प्रेसिडेंट साहब ने बताया कि आईएसए और उसकी सभी ब्रांचेस पिछले एक साल के अंदर बहुत सारा काम कर रही हैं, और अगले 2 साल का भी उन्होंने पूरा एक फ्लो डायग्राम सबके सामने रखा कि अगले 2 साल के अंदर भी डॉक्टर नवीन मल्होत्रा और डॉक्टर मुरलीधर के नेतृत्व के अंदर आईएसए बहुत कुछ करने जा रही है। चाहे वो कल्चरल क्लब हो, चाहे युवा आईएसए कौन हो, चाहे वो आर्ट एंड लिटरेरी क्लब हो, चाहे वो स्पोर्ट्स क्लब हो, इन सब फील्ड के अंदर बहुत कुछ करने जा रही है। हमने पिछले 1 साल के अंदर कोरोना के दौरान बहुत कुछ खोया है, बहुत सारे हमारे साथियों को खोया है। हम सब लोग बहुत डिप्रेस रहे हैं, और इस डिप्रेशन के अंदर एनेस्थेटिस्ट फोर फ्रंट पे हमेशा काम करते हुए आए हैं। लेकिन हम लोगों ने इसको एक अच्छाई के रूप में भी बदला है। हम लोगों ने जो वर्चुअल कॉन्फ्रेंस जो आज हम कर रहे हैं, ये वर्चुअल कॉन्फ्रेंस वास्तव के अंदर आध्यात्मिक एंड एजुकेशन के दोनों के रूप के अंदर 1 साल हमारा काफी अच्छा निकला है। जितना भी पहले फिजिकल कॉन्फ्रेंस के अटेंड करने के लिए हमें दूर दूर तक जाना पड़ता था, और हम लोग कभी ये देखते थे कि बहुत सारे लोग अटेंड करते हैं लेकिन वो एकेडमिक सेशन के अंदर कम से कम अटेंड करते हैं। अब ये देखा जा रहा है कि जो लोग इंटरेस्टेड हैं वही लोग इस वर्चुअल कॉन्फ्रेंस को अटेंड करते हैं, और बार बार हर वीक, हर 15 दिन में, हर महीने कोई अच्छी सी कॉन्फ्रेंसेस हो रही हैं, वर्चुअल कॉन्फ्रेंस, जो कि वास्तव में नॉलेज को इम्प्रूव कर रही हैं। और मैंने ये कल प्रोग्राम देख रहा था आईएसए उड़ीसा कॉन का। ये प्रोग्राम was very well balanced, and the opportunity was given to all youngsters as well as the seniors. Seniors हमारी शान होते हैं, ये youngsters जो होते हैं वो हमारे आने वाली शान होते हैं। और डॉक्टर निवेदिता पानी ने बोला कि हमारी जो थीम है that is for the PG students, that is very good। आखिर आईएसए का कर्णधार हमारे जो पीजी स्टूडेंट्स हैं वही आगे आने चाहिए, और उनको भी और मौका देना चाहिए। डॉक्टर नवीन मल्होत्रा ने युवा आईएसए केंद्र चालू करके एक बहुत अच्छा हमें एक थीम दी है कि हर स्टेट, हर सिटी युवाओं को मौका दे बराबर का, क्योंकि वही युवा हैं जो आने वाले टाइम पे, हमारे पास युवा शक्ति की कमी नहीं है और टैलेंट की कमी नहीं है। और जब तक ये कॉन्फ्रेंसेस की जब मात्रा बढ़ेगी तो डेफिनेटली हमारे युवा लोग इसके आगे आएंगे, और युवा शक्ति को हम पहचानेंगे, और नेशनल लेवल तक भी हम लोग उसको प्रदर्शित कर पाएंगे। डॉक्टर नवीन मल्होत्रा ने इंटरनेशनल युवा सम्मेलन की भी बात कर रहे हैं कि अल्टीमेटली हम लोग इंटरनेशनल युवा सम्मेलन की में कॉन्फ्रेंस करेंगे, जिसमें कि इंटरनेशनली हमारे हिंदुस्तान के युवाओं को उसके अंदर काफी मौका मिलेगा। और हमारे पास टैलेंट की कोई कमी नहीं है, टैलेंट बहुत है। हमारे यहाँ पर जिस स्थिति के अंदर हम काम करते हैं, हम अच्छी से अच्छे इक्विपमेंट के संग भी काम करते हैं और खराब से खराब स्थिति के अंदर भी काम करते हैं। और हमारे चेयरमैन एकेडमिक कमेटी बहुत सारी गाइडलाइंस हमारी तैयार कर रहे हैं। तो इंडियन गाइडलाइंस तैयार हो जाती हैं तो हमारा वर्ल्ड के अंदर एक स्टेटस होगा। जहां आज हम अमेरिकन गाइडलाइंस की बात करते हैं, वी आर टॉकिंग अबाउट द कैनेडियन गाइडलाइंस, वी आर टॉकिंग अबाउट द ऑस्ट्रेलियन गाइडलाइंस, देन पीपल विल टॉक टू इंडियन गाइडलाइंस। Then that is very improvement in our anesthesia society, and ISA is definitely doing very good. और उसके साथ साथ जितनी भी all the branches of ISA, city branches, state branches, they are also very good, doing very good. And I wish you all a successful years ahead, and I congratulate all the organizing committee of the ISA Odisha Con for making such a wonderful program. And मैं दोबारा आप सब लोगों को बधाई देता हूँ। जय उत्कल, जय हिंद, जय ISA।
Thank you so much, sir, for your valuable words. Now I would request our guest of honor, President-elect National ISA, Dr. Venkatgiri KM, to please deliberate a few words. Over to you, sir.
President ISA Odisha, Dr. Ekadas, President ISA National, Dr. Joshi ji, Vice President Dr. Bhargava, Organizing Chairperson Madam Nivedita Pani, Secretary Naveen, past President and Academic Chairman Bala Bhaskar, all dignitaries, friends, Namaste. It is a happy occasion to be with you on this evening during the inaugural function of the online conference of ISA Odisha branch. As Devashish told, he expected me to be there with my family in Odisha, which I promised him when I went last time. I will come next year. This year we are not able to go anywhere, and next year, definitely I will come there and have. I was telling always whenever I was meeting Nivedita, and she was bringing prasad from Jagannath after praying and all that helped and elevated me this post. Maybe she also prayed for me. Thank you. Whatever I wanted to speak, previous speakers talked, and next whatever I want to speak, maybe Naveen will be speaking. So I don't want to speak much about it. These online conferences have really helped many of us, at least me, because whenever we go for a conference, we office bearers, we get very less opportunity to attend any scientific program because we must be always busy with our association activities. With this online conference, definitely, at least I am able to attend some scientific programs sitting at my home or in my theater, and definitely have improved our knowledge and perspective what we are doing. There are a lot of changes from what I have learned and learning during this time. New things have come, and it is not only for me. Everybody should attend whenever it is possible. But offline now, I'm seeing earlier people had a lot of interest in attending all the con. Now it is the attendance is coming thin. But even if there are good speakers and talking and giving their knowledge free, we don't see that much nowadays, because I'm seeing for the last 9 months, even if you get the best speakers, people are not getting that. And what ISA is giving them, it is not any, they need not spend even a single paisa sitting at home. That's what we have to change our perspective, because at least I am getting benefited because of this online conference. Second thing, I wish that all members, two things, because now the number of anesthesia PG seats are increasing. When the national board has started, I think Naveen, it has started that diploma also. The number is going to increase. So the practitioners' opportunities are going to come down in coming days. So we have to think of that in the future, how we sustain our practice and decent practice and all. That is, every practitioner should think. People who are employed will have that salary and fixed. But what I'm seeing is that people who are having salary also, there is cut in salary during the pandemic. Even the government has cut salary, private and corporate also have cut their salary, and even the private also. It is coming down, practice also coming, because a lot of people in my state, more than 300 people are joining anesthesia practice every year, but surgeries are not going or increasing in that speed. So that same surgeries or anesthesia is shared between more people. Retirement is less and joining is more. So now demand is less and our setting. So we have to think of that. What I'm telling is, whenever other day I discussed with Naveen also was telling that we have to have the financial management. Our people also we have to tell our younger generation that how the practice, because yesterday Karnataka, they made that their one topic was freelance practice. So we have to tell that, and we have to find an alternate source of income and how to financial management, because when money is coming, we may spend and make loans. That's one thing we have to say. Second thing, for our family also, the FBF, everybody should join that. Younger age, when money is coming, we are all very happy and all. But when the earning member loses practice or loses a life, the family will be very difficult to cope up with that. Because see, at the age of 60, many people may not need the money and all, maybe that 60, the whatever social security gives that. But at the age of young age, 30 or 40, if somebody dies or something happens to him, he may not be able, the family may not be able to sustain. So I request every member, we should promote every member to join the Family Benevolent Fund and support. You or me may not require, but somebody else requires. This 300 rupees is large for somebody else. May not be for me, but everybody should think in that way. And I am supporting another colleague, his family maybe. This is when we have to think. So these two things, I request all who have joined. Yes, at least the younger generation should join the family event, though not for you, it is for somebody else. You have to think and think of younger generation and think the future of practice. We have to think that for the future and how we sustain the same practice and how will we go and have income. In few words, I wish all the best and good scientific deliberation during this period. Hope to come and see you all next year there in Odisha and pray with the Lord Jagannath. Jai Jagannath. Namaste. Namaskar. Jai ISA. Jai Hind.
Thank you so much, sir, for enlightening us. I would now like to request our guest of honor, Honorable Secretary, National ISA, Dr. Naveen Malhotra ji, to please speak up a few words. Over to you, sir.
Good evening, respected Dr. Muralidhar Joshi, President ISA National, Presiding Officer Dr. Rekha Das, President ISA Odisha, dignitaries Dr. Nivedita Pani, Organizing Chairman and past Vice President of ISA National, Dr. Kishore Chandra Mahapatra, Vice President State ISA, Dr. P.K. Pallai, President-elect State ISA, and very dear Dr. Debashish Swain, Honorary Secretary of Odisha State Branch and Joint Organizing Secretary of this particular conference, and Dr. Rajat Das, Joint Secretary and Treasurer of State ISA, and also past GC members from Odisha, Dr. Sikdev Nayak and Dr. Narayana Acharya, and very, very respected past ISA National President, late Dr. B.B. Mishra. I pay homage to him along with my council members. Heartiest congratulations to ISA Odisha State Branch on organizing this 49th ISA Odisha WebCon today and tomorrow. And I still remember the warm hospitality which was extended when I was on that whirlwind tour during the East Zone Conference in 2019. Yes, I agree with Dr. Venkat Giri. अगले साल फिर आएंगे जब आप फिजिकल कॉन्फ्रेंस करेंगे तो we will come together and enjoy the warm hospitality and pay homage to Jagannath ji, Balbhadra ji and Subhadra ji and seek their divine blessings. The scientific program of this conference has been very nicely designed, starting from theme and to the topics. And I see lots of posters and paper presentations are there. So definitely going in line with the focus on Yuva ISCNs, the theme is to grooming postgraduates to skilled anesthesiologists. And I must say that ISA National salutes all the anesthesiologists for the exceptional work done during the COVID pandemic. और हमारे पोस्ट ग्रेजुएट्स ने तो कमाल ही कर दिया. हमें लगता है कि हमारे पोस्ट ग्रेजुएट्स की जो बॉडी है वो मेटल की बनी हुई है और जो उनकी नर्व्स हैं वो स्टील की बनी हुई हैं और उन्होंने इस कोविड पेंडेमिक के दौरान जैसे कहते हैं ना गेंद बाउंड्री लाइन के बाहर स्टेडियम से बाहर पहुंचा दी. इतना उन्होंने अच्छा काम किया है. इसलिए ये उचित ही है कि वर्ष 2020 हमेशा से ही हमेशा के लिए एनेस्थीसिया रेजिडेंट्स का वर्ष के रूप में चिन्हित रहेगा। स्वर्णिम अक्षरों में लिखा जाएगा आईएसए के इतिहास में, एनेस्थीसिया के इतिहास में और मेडिकल हिस्ट्री के इतिहास के अंदर। बहुत अच्छा लगता है जब आईएसए की कोई भी स्टेट कॉन्फ्रेंस होती है। इस पैंडेमिक के अंदर चैलेंजेस को अपॉर्चुनिटी के अंदर कन्वर्ट करना हमारी आईएसए की स्टेट ब्रांचेस से कोई सीखे। प्रेसिडेंट डॉक्टर मुरलीधर जोशी ने बिल्कुल सही कहा, हर हफ्ते कोई ना कोई स्टेट कॉन्फ्रेंस हो रही होती है पिछले 4 महीनों से, और हर स्टेट ने इस वर्चुअल प्लेटफॉर्म को बहुत अच्छे ढंग से यूटिलाइज किया है। और डेफिनेटली थोड़ी बहुत अटेंडेंस कम हुई है, पर फिर भी जिन्होंने सीखना है वो सीख रहे हैं, अच्छे लेक्चर्स भी हो रहे हैं और आपको ट्रेवल भी नहीं करना पड़ रहा। पर ठीक है, जेड से आर के ऊपर तो हमें अल्टीमेटली आना ही है, और हमारी ये कोशिश भी है कि हम जूम से रियलिटी के अंदर अहमदाबाद के अंदर भारी संख्या में हम एकत्रित हो पाएं, ऐसी कुछ स्थिति बने कि स्वास्थ्य भी ठीक रहे हमारे परिवार का, हमारा भी, और सेफ भी हो ट्रेवल करना, और हम सब इसाकॉन 2021 अहमदाबाद में एक अच्छा शो करके आपस में मिल पाएं। कुछ जगह के ऊपर हाइब्रिड कॉन्फ्रेंस भी शुरू हो गई है। अभी पीछे लखनऊ के अंदर पीजी असेंबली हुई थी, तो उसमें हाइब्रिड भी था कि कुछ लोग वर्चुअल प्रेजेंट कर रहे थे और कुछ लोग फिजिकली वहाँ इकट्ठा हुए थे। तो अब पीजी असेंबलीज भी शुरू हो गई हैं, और सेंट्रल जोन ने इसको शुरुआत करी है लखनऊ से। और डेफिनेटली ये 2 वर्ष, आने वाले 2 वर्ष हमारे लिए बहुत ही उत्साहजनक हैं, बहुत ही इम्पोर्टेंट हैं, क्योंकि हमने 26 जनवरी 2021 26 जनवरी 2021 से हमने अपनी प्लेटिनम जुबली सेलिब्रेशंस को स्टार्ट किया है बाय लॉन्चिंग द आईएसए कैलेंडर। उसका बहुत अच्छा रिस्पांस आया, एंड ये जो सेलिब्रेशंस हैं ये 2 साल चलेंगी, एंड ये नवंबर 2021 में ख़त्म होंगी। उस आईएसए कैलेंडर की खास बात ये है, आप सबने, आपके पास पहुंच भी गया है ईमेल के थ्रू भी और सोशल मीडिया के थ्रू भी, और वेबसाइट पे भी है, कि उसमें आईएसए के सारे 25 प्रोग्राम्स जो चल रहे हैं वो हाईलाइट किए गए हैं। चाहे वो हमारा इंडियन रिसर्च काउंसिल के प्रोग्राम्स हो, फैमिली बेनेवलेंट फंड हो, हमारा आईजे हो, कल्चरल क्लब हो, गाइडलाइंस हो, इनोवेशन क्लब हो, फाइनेंशियल एडवाइजर हो, युवा आईएसए हो, प्राइवेट प्रैक्टिशनर्स फोरम हो, स्पोर्ट्स क्लब हो, फिजिकल फिटनेस के बारे में हो, मेंबर्स कॉर्नर हो, WFSA के बारे के अंदर जितने भी हमारे प्रोग्राम्स चल रहे हैं वो सब उसके अंदर हाईलाइटेड हैं। और मैं बधाई देना चाहूँगा ओडिशा स्टेट ब्रांच को कि उन्होंने पिछले 1 वर्ष के अंदर इन सारे प्रोग्राम्स के अंदर बढ़ चढ़ के भाग लिया है। तो ये प्लेटिनम जुबली सेलिब्रेशंस की शुरुआत 26 जनवरी से शुरू हुई है, लॉन्च जो हमने किया अपना आईएसए कैलेंडर, और ये अब चलती रहेगी। चाहे वो अभी हम रामनवमी के पावन पर्व के ऊपर अपनी ऑनलाइन क्लासेस और अपनी नेशनल रजिस्ट्री को भी लॉन्च करने का प्लान बना रहे हैं। और जैसे सुरेश भाई ने बताया, हमारे वाइस प्रेसिडेंट डॉक्टर सुरेश कुमार भार्गवा जी ने, कि हम ग्लोबल युवा कॉन मई के पहले सप्ताह के अंदर कर रहे हैं। युवा ईसा कॉन को अब हम एक लेवल ऊपर ले जा रहे हैं कि हमारे जो यंगस्टर्स हैं उनकी जो लोहा है वो हमने तो माना ही है, अब पूरा विश्व माने। तो उसके लिए भी तैयारियां जोर शोर पे चल रही हैं। और साथ साथ ही हमारी सार्क की कॉन्फ्रेंस भी वर्चुअल हो रही है 2021 के अंदर, डॉक्टर वेंकट गिरी के मार्गदर्शन के अंदर, और कोचीन और केरला स्टेट के अंदर वर्चुअल करेंगे, और अगले साल इसको फिजिकल करेंगे। और जो पूरी टीम है डॉक्टर बाला भास्कर के नेतृत्व में साइंटिफिक प्रोग्राम बना रही है, और बड़ा अच्छा प्रोग्राम जल्दी आप सब लोगों के सामने होगा। साथ ही साथ हम लोग हमेशा, जैसे डॉक्टर सुरेश भाई ने बताया कि हम दूसरी गाइडलाइंस की बात करते हैं, तो जो हमारी गाइडलाइंस कमेटी है जिसका नेतृत्व डॉक्टर बाला भास्कर कर रहे हैं, वो बताएंगे अपने अपने भाषण के अंदर कि रीजनल एनेस्थीसिया, एंटीकोगुलेंट्स और मॉनिटरिंग स्टैंडर्ड्स के ऊपर तो गाइडलाइंस का काम बहुत स्पीड पे चल रहा है। और मुझे पूरी उम्मीद है कि इस वर्ष के अंत तक, हो सकता है कि जल्दी भी 16 अक्टूबर को ही सर उसको फाइनलाइज कर दें। ऐसी हमारी शुभकामनाएं और सपोर्ट है उन गाइडलाइंस कमेटी के प्रति। साथ ही के साथ हम अपना इंडियन हिस्ट्री ऑफ एनेस्थीसिया के बारे में भी पूरा काम चल रहा है कि हम हमेशा बच्चों को बाहर के बारे में बताते हैं, पर हमारे रेजिडेंट्स को, हमारे पोस्ट ग्रेजुएट्स को, हमारे यंगस्टर्स को इंडियन हिस्ट्री ऑफ एनेस्थीसिया और इंडियन हिस्ट्री ऑफ डिफरेंट स्टेट ब्रांचेस, कैसे कैसे एनेस्थीसिया अलग अलग स्टेट ब्रांचेस में इवॉल्व हुआ, उसके ऊपर भी एक हमारा पब्लिकेशन तैयार हो रही है। और हमेशा हम अमेरिकन सोसाइटी ऑफ एनेस्थीसियोलॉजिस्ट फिजिकल स्टेटस ग्रेडिंग की बात करते हैं, अब हम इंडियन फिजिकल स्टेटस क्लासिफिकेशन के ऊपर भी हमारी तैयारी चल रही है, जिसके ऊपर सेक्रेटरीट और लोगों के साथ मिलकर कार्यक्रम चला रहा है। और हम आने वाले 2 वर्षों के अंदर अपना ISA पोस्टल कवर, ISA स्टैम्प ये भी जोर शोर से लॉन्च करेंगे। और ये एक बहुत अच्छा स्वर्णिम मौका होगा हमारी स्टेट ब्रांचेस के लिए। जैसे वर्ल्ड एनेस्थीसिया डे के दौरान सब स्टेट ब्रांचेस ने अपना टैलेंट शोकेस किया था, अपनी एक्टिविटी शोकेस की थी, ये प्लेटिनम जुबली सेलिब्रेशंस भी हर स्टेट ब्रांच के लिए एक मौका है कि वो अपना जो है अच्छी अच्छी चीजें सारे देश को दिखाएं, पूरे हिंदुस्तान को दिखाएं। डॉक्टर गिरी ने बड़ी अच्छी बात कही कि हमें फाइनेंशियल मैनेजमेंट भी करनी होगी। मेरे ट्रेजरर पार्टनर डॉक्टर वीरेंद्र शर्मा इस मामले में माहिर हैं और वो फाइनेंशियल एडवाइजर के सेमिनार्स भी करते रहते हैं, और कल भी उनका एक सेमिनार है स्टॉक मैनेजमेंट के ऊपर। तो हमेशा एक सेकंड सोर्स ऑफ इनकम होनी चाहिए, सेकंड लीगल सोर्स ऑफ इनकम। ऊपर की कमाई मत करिए, एक सेकंड सोर्स ऑफ इनकम जरूर होनी चाहिए जिससे आप फाइनेंशियली स्टेबल हों। और जितने भी हमारे और प्रोग्राम्स हैं, मैं आपको चाहे कुछ यंग एनेस्थीसियोलॉजिस्ट है, चाहे सीनियर मोस्ट है, यू आर ऑलवेज मोस्ट वेलकम टू गेट एसोसिएटेड with those programs and contribute to it and coordinate with ISA National Secretariat in establishing these programs further down to the city level. ISA National, along with this whole governing council. So this is a very excellent governing council. I can say we all are sitting in the midst of a history, because this is a historic governing council. 1, 2, we are in the historic period of Platinum Jubilee celebrations. So we have to contribute and mark ourselves in the history. And the ultimate measure of a team is not where it stands in its moments of comfort. The ultimate measure of a team is not where it stands in moments of comfort, but where it stands at times of challenges and adversities. And ISA is following that in letter and spirit. Once again, I congratulate the ISA Odisha State Branch for inviting us here to this inaugural ceremony. Heartiest congratulations to all of you. Jai ISCN, long live ISA, Jai Hind. Thank you very much.
Thank you so much, sir, for your wonderful words. Now I would like to invite our guest of honor, Treasurer, National ISA, Dr. Virendra Sharma, to please address the August gathering. Over to you, sir.
Thank you. Good evening, respected President ISA, Murli sir, President ISA Odisha State, Dr. Rekha ma'am, my senior office bearers of ISA National, Dr. Nivedita ma'am, other office bearers of ISA Odisha State, and some of the members whom I shared my council tenure, although they are not present, Dr. Sukhdev Naik. COVID कुछ ज़्यादा लंबा खिंच रहा है, and there was a hope in January कि अब केसेस कम हो रहे हैं, and we were thinking कि फ्यूचर में शायद फिजिकल के लिए अब मौका मिले. But one thing I must acknowledge that by virtue of this virtual conference, this is the first inauguration of the ISA Odisha State I am able to attend. It is not that I didn't get an invitation, but unfortunately could not attend. And this time also, as Rekha ma'am said that I am still in OT. Yes, I was supposed to be in the OT, but she kept on insisting, "So आपको attend करना है, आपको attend करना है." And I told my colleague, look, मुझे यहाँ OT में I am not feeling comfortable, यार, please if you can. So he said, sir, थोड़ा और cases manage हो जाएं. Then finally I could get a chance. So now, ma'am, I am at my home, relaxed. So thank you so much for giving this invitation. One thing, since your theme is related to PG students, I would like to share on behalf of my secretary that very soon, see, it was on the request when I was in a CME in Karnataka in Bellary, Dr. Bala Bhaskar sir invited the governing council. I had the opportunity to interact with the PG students. I mean, we were coming back from a sightseeing tour. So I said, what do you expect ISA to do for you? So one of the things which they raised, and later on we discussed in the governing council, and now it is going to be very soon launched. That is the online classes for PG students all over India. The same faculty is going to address them, and they will get that opportunity to listen to our great speakers all over India. So that is a very good opportunity to the students. And also I request the faculty to give their names to our secretary. So that is regarding the PG students. And yes, those 25 programs which Dr. Naveen mentioned about, I'm looking after 2 programs, and they are both very important as far as the members are concerned. One of them, most of you must be knowing, that is the Private Practitioner Forum. In Odisha, I have tried with lot of efforts. Yes, there is a PPF state chapter, but not much of activities, or maybe I'm not getting that information. My advice is you need to be united. See, in private sector, until unless the anesthesiologists, they have a unity, you are not going to achieve anything. We have seen in the past with our own experience, all those who are into 20 or 30 years, they know how things are there. And the second one is the financial. So yes, I would like to share that we started the financial advisory, ISA financial advisory. That was in 2017. Now it is ISA financial advisory. And what we are doing there is that we are guiding our members that how you can save money and invest it. See, and I would like to share that initially when so many members joined, and they said, sir, nobody in past told us like this. I purchased a vehicle on loan, I went for a lavish vacation and all, but we never learned that concept. So that is a very good group. And now since the demand is increasing because the awareness due to our secretary, he is always promoting all these programs. So we have now switched over to Telegram, because see, in WhatsApp group, you can accommodate only up to 256. And adding to that, when we interacted amongst ourselves, there are very knowledgeable and intelligent members regarding finance management. I mean, we don't need experts from outside. We have experts in financial management in our own anesthesiology circle. So another specialist chapter of that I had to form. That was stocks. I mean, those who are, and again, there are around 230 to 40 members who have joined. And on their request, tomorrow, I mean, all those who, it's a bit higher level, because we'll be sharing the technical and fundamental analysis of shares when you purchase and sell and all. But still, a lot of enthusiasm was there, and I had to request my colleagues, and they came forward, sir, we'll do it for you. So all those who wish to know the financial planning, you can join in the ISA financial group. Our experts who are whole time into this, I would like to share that they have qualified the NISM program, I mean National Institute of Stock Management. One Dr. Gajjar, he has done 2 courses, and of course Dr. Kumaresh from Madurai, they are doing full-time financial management, and they are very happy to teach our members about the aspects of the financial management. So anything regarding these 2 programs, all members, they are most welcome to contact me if they have any problem in joining. And thank you so much, and congratulations for such a good scientific program, and all the best for this ISA WebCon Odisha. Thank you so much.
Thank you so much, sir, for your wonderful words. I would now like to request our guest of honor, past President, National ISA, Dr. S. Balabhaskar, to enlighten us with his valuable words. Over to you, sir.
Good evening. I think I have some network issues. Are you able to hear me?
Yes, sir.
Yes, sir, you're audible, sir. Yes, sir, you're audible.
Yes,
You're audible. You're audible.
Okay, thank you. Thank you very much. Good evening to all my colleagues.
Sir, we lost your voice.
Sir, now you're not audible.
I think he's disconnected. His name is not there. He's disconnected.
Yes.
Oh, he has come.
Yes.
Hello?
Yes, sir. You're audible.
Very sorry. I was, it happened just in the last 5 minutes. Good evening. Am I audible? Shall I go ahead, please?
Yes, sir, you're audible.
Thank you. President ISA National, Dr. Mulira Joshi, and my co-GC members, and Dr. Nivedita Pani, the past Vice President and the organizing chairman for today's program, and of course, Dr. Rekha Das, the President of ISA ODISHA State Branch. Then we have Vice President Dr. Mahapatra, then President-elect Dr. Palai, and Devshi Swain, the Secretary. And I'm very happy to be part of online program, but I'm definitely missing the physical program because there are still some unexplored areas in Odisha which I would have loved to visit and be there. So as Dr. Venkiri was telling, so next year we'll come. Please extend an invitation next year also. And my wishes to all the faculty who are participating, ISC members from Odisha. Because it's online, we have got the viewers and the participants from across the world, not just in other parts of India. My wishes to them and to the postgraduates and the practitioners who are going to participate in the online conference in the next 2 days. With respect to the IS academic activity, much has been already discussed by Dr. Mulira Joshi, Dr. Naveen, and Dr. Suresh. Details have been put forward, and just to keep it short and sharp, we are trying to go back to the physical work in this year's national conference at Ahmedabad. Hopefully, if everything is safe and perfect, mainly because we had started good work for about 2 years. We had new programs introduced into the ISACON National. We had published the abstract of the papers presented in ISA National for the first time. So the good work would continue for the future also, and especially because we have planned the 75 years celebrations. More and more new programs in academic activity also will come and should come. And with respect to the guidelines which all of us have been in our practice, not dependent on guidelines from other societies in the world. Published the fasting guideline. Dr. Rekha Das was also one of the chief contributors as an expert. And we've got 4 more pending. They are in various stages of development. And we've got experts in different parts of India again, including Odisha. About 2 people are still participating. There was a push and pressure from Dr. Naveen Malhotra while he was speaking. Yes, I accept there has been some delay because our colleagues were all stuck in COVID work. I only pray that the second episode doesn't draw us into that work again. If it doesn't, so I assure that the rest of the guidelines will be ready by end of this year. So thank you very much and all the best for Thank you.
Thank you so much, sir, for your valuable words. Now I would like to invite our guest of honor, GC member East Zone, ISA, Dr. Manoj Kumar, to please share with us a few words. Over to you, sir.
Hello, Jai Jagannath to all of you. Good evening, President ISA National, Dr. Muralidhar Joshi sir, Vice President ISA National, Suresh Bhargav sir, Secretary ISA National, Naveen Malhotra sir, President-elect ISA National, Venkat Giri sir, past President ISA National Bala Bhaskar sir, past Vice President respected Nivedita Pani madam, President ISA Odisha State Branch Dr. Rekha Das ma'am, Vice President Mahapatra sir, Secretary as well as Organizing Secretary Devashish Swain sir, and all the delegates and the member of the ISA Odisha State Branch. I am very delighted to Odisha Branch WebCon organized by Odisha State Branch. My best of luck to ISA Odisha WebCon 2021. So thank you very much for nice conference and my best of luck for grand success of the conference. Thank you.
Thank you so much, sir, for your wonderful words. Now I would request to invite Professor Dr. Rekha Das, President, State ISA and Organizing Secretary, to please enlighten the August gathering. Over to you, Madam.
Thank you, Neetu. Once again, I take this opportunity to express my honor and pleasure to all our national leaders, without whose blessings and good wishes, I don't think this conference would have been able to be conducted. And it is not only a day we are having, today we had a workshop, and tomorrow we are going to have a CME along with our competition papers. To conduct this ultrasound guided nerve block workshop in a hybrid manner was indeed a challenge to us. But as there were various requests from various members, the students, the faculties, so we as members of the executive committee, we decided why not. So we were stimulated by their inspiration, and that is why we had this workshop today in a hybrid fashion. And I'm happy that it took off well and it has been quite fruitful. The airway workshop has also been conducted live, and I'm extremely thankful to all the faculties who taught us a great lesson to the students, and it has been very fruitful also. The CME tomorrow that we are going to have has some very interesting topics, particularly for the practitioners and also for the grooming and budding anesthesiologists. And these are being brought to them by experts in their field. The papers that the students are going to present tomorrow are also going to cover some innovative works. We understand the COVID has taken a great toll on us, yet it has taught us how to continue academics, fellowship, and professional interrelationship in this odd time. I would also like to thank and seek the blessings of my senior members of the state, Dr. Sukhdev Naik sir, Dr. Annanga sir, Hari sir, and many others, and pay homage to our past president, Dr. V.V. Mishra, and alumni of SV Medical College, Cuttack, who was a constant guidance for us. I also now again thank our national leaders for ornamenting this ceremony and their good wishes. Thank you once again, and thank you all the leaders.
Thank you, Madam, for your precious words. Now I would like to invite Dr. Kishore Mahapatra, Vice President, State ISA, to please speak up a couple of words. Over to you, sir.
Very good evening to all. Respected all the dignitaries like Muraldhar Joshi sir, Nobin Malhotra sir, Venkat Giri sir, Balabhaskar sir, Suresh Bharkar sir, Birendra Sharma sir, Dr. Manoj Kumar, and the ODISHA executive members. Definitely, it's a great opportunity that with the good support of ISA National Executive, we are going to conduct the annual Odisha State Conference in the web-based manner, and definitely we will do it very much successful. Definitely, we heard everything from our national executive, and their blessings always with us. And today, we have got two workshops. One is regional anesthesia, and other is difficult airway. And these two workshops definitely very good participants and very good, excellent performance. I think in the last talk, in the difficult airway, there is a very good talk. There is a very good case discussion and case management, and which is very much helpful to all the faculties and all the physicians also. Again, and tomorrow we have got a very good CME work, which is very much beneficial to all our PG students, all our faculties, all our participants and practicing anesthesiologists, which is very much helpful to us. Thank you all. Again, we all welcome all the national to Odisha next year, this year, when we have a conference in our Odisha state, and I am the organizing secretary this year. I definitely welcome you all. Thank you. Long live ISA. Thank you again.
Thank you so much, sir, for your humble words. Now I would like to invite Dr. P.K. Pallai, President-elect State, to please address the August gathering. Over to you, sir. I think sir has lost his connection. Now I would like to request Dr. Debashish Swine, Honorary Secretary, State ISA and Joint Organizing Secretary, cum Treasurer, to please enlighten the August gathering with a few words. Over to you, sir.
Thank you. Namaste. Good evening and warm greetings. Respected National President Dr. Muralidhar Joshi sir, Vice President Suresh sir, President-elect Venkatagiri sir, Honorary Secretary Navin sir, Treasurer Birendra sir, Past President Balabhasra sir, and East Zone Governing Council Member Manoj sir. Organizing Chairperson Professor Nivedita Pani ma'am, State President Professor Rekha Das ma'am, Vice President Dr. Kishore Mahapatra, President-elect Dr. Pramod Kumar Pallai, and my Joint Secretary, cum Treasurer Dr. Rajas, and other esteemed dignitaries live on this web platform. It's a matter of great honor and a very proud moment for all of us as ISA Odisha State is conducting its first webcon live on a virtual platform today and tomorrow, the 49th State Annual Conference and ISA Odisha Webcon 2021. On behalf of all Odisha State members, Executive Committee of the State and 5 city branches of Odisha and the local organizing committee at Qatar, I am delighted to invite you all and extend a hearty welcome to all participants and delegates in this State Annual Webcon. The theme of this conference is Grooming Postgraduates to Skilled Anesthesiologists. The scientific program will focus on symposia and lectures by distinguished speakers from all over India. Hope that deliberations by eminent anesthesiologists will enlighten you all with ample scientific knowledge. The organizing committee, under the valuable guidance of our chairperson, Professor Nivedita Pani ma'am, and organizing secretary, Professor Rekha Das, the senior state members, as well as all state EB members, has been very active, and arrangements are well underway to ensure that the 49th ODISHA 2020 becomes a resounding success. However, the most meticulously organized program and extracurricular activities will be nothing without delegate active participation and support. It's our sincere request to you all to come forward with your valuable contributions during scientific deliberations and other activities. Dear guests and dignitaries, the state, as well as all its 5 city branch members, has left no chance to serve the mankind during the last 1 year throughout the corona pandemic scenario. Apart from direct and regular involvement with COVID patient management, the state members have trained a number of doctors and paramedics throughout various government-sponsored programs and saved lives of uncountable number of patients, starting from setup of new hospitals like care centers, health centers, and dedicated COVID hospitals to impart critical training for doctors and other fraternities, and advising people through Chief Minister's telephonic helpdesk. We have delivered optimum selfless service and bagged respect and reward from all corners of the society. We feel proud to be anesthesiologists and leaders of intensive care at present times. We are happy to inform that all our members and their families are safe and cross the COVID crisis by the blessings of Lord Jagannath. The state executive body, along with the organizers, have left no stone unturned to ensure that the webcon turns out to be an occasion from which all of you shall carry feedback, shall carry back eternal memories of scientific excellence. I wholeheartedly thank all the esteemed National Council members, especially our National President and Honorary Secretary, as well as the organizing team, Madam Professor Nivedita Pani and Professor Rekha Das, and the entire team members for their tireless effort, dedication, and time for the noble cause with high academic values. Also, I am immensely thankful to the entire team, which consists of our faculty members, delegates, students, anesthesiologists of the state, and coordinating staff, event management team, and all other persons associated for this genuine and kind-hearted support to make this event memorable. Long live ISA, Jai Hind, Jai Jagannath. Thank you once again all.
Thank you so much, sir, for your wonderful words. Now I would like to invite Dr. Rajat Das, Joint Secretary and Treasurer, State ISA, for a vote of thanks. Over to you, sir.
Good evening, everybody. On the behalf of the ISA Odisha State Branch, I wholeheartedly thank all the esteemed members of ISA National, President Dr. Muralidhar Joshi sir, Vice President Dr. Suresh Bhargav sir, President-elect Dr. Venkatgiri sir, Honorary Secretary Dr. Naveen Malhotra sir, Treasurer Dr. Birendra Sharma sir, Past President Dr. Balabhaskar sir, EC Member Dr. Manoj Kumar sir, and our State Office Bearer, Organizing Chairperson Professor Nivedita Pani Madam, President ISA Odisha State Branch and Organizing Chairperson Professor Rekha Das Madam, Organizing Vice President Dr. Kishore Chandra Mahapatra, Honorary Secretary Dr. Devashish Swai, President-elect Dr. Pramod Kumar Pallai, Scientific Chairperson Professor Basant Kumar Pradhan, for their tireless effort and dedication for Nobel cause. Also thankful to great extent to all the faculty members, delegates, students, anesthesiologists of the state, coordination staffs, event management staffs, member of Mr. Girish and Mr. Manos, also all staffs of Shanti Memorial Hospitals for his genuine and kind-hearted support to make this event memorable. Thank you. Jai Jagannath. Long live ISA.
Thank you so much, sir, for your wonderful words. I now request all the dignitaries to please stand up for the national anthem.
भाग्य विधाता पंजाब सिंध गुजरात मराठा द्राविड उत्कल बंगा विंध्य हिमाचल यमुना गंगा उच्चल जगधि तरंगा तव शुभ नामे जागे तव शुभ आशीष मांगे गाहे तव जय गाथा जन गण मंगलदायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे
Thank you so much for being a part of this beautiful inaugural function. But yet, the second most beautiful part of the evening is still left. We'll start up with the cultural program soon. Thank you, all my respected dignitaries, to be a part of this inaugural function. Long live ISA, Jai Hind.
Heartiest congratulations to Master of Ceremony for doing it wonderfully, and minute to minute, .705 we are over. Congratulations.
Thank you so much, sir. Thank you.
Thank you, sir. Thank you
all the dignitaries to stay and see the cultural function. It is
You are performing, madam? You are performing?
Thank you and all. Thank you so much. Congratulations for a successful conduct of the program. All the best.
Thank you, sir. Thank you.
Sir, please be there for the cultural program.
For sure, for sure.
It's only 40 minutes, sir.
Okay, ma'am.
You can just see a part of it if you don't have so much of time. Just watch it. Be encouraging.
Program, Nivedita, madam?
Yes, it is there. It is there.
A very good evening to one and all. I, Dr. Neetu Gupta, Senior Resident, Department of Anesthesiology and Critical Care, welcome you to the vibrant cultural program of 49th ODISHA 2021 on this day of 13th. This cultural program is done by the doctors fraternity with their efforts by colorful music and dance, which would fill up your hearts with joy. I hope you all will enjoy this. Life is the most colorful festival, and we should enjoy all the days with full of happiness. To start with this beautiful evening, the first program, I would like to present before you a beautiful song मधुबन खुशबू देता है, by none other than Dr. Anjan Das, cardiac anesthetist, Apollo Hospitals, Bhubaneswar. The next program would definitely win your hearts and make your feet tap to the rhythm by the PG students of Department of Anesthesiology and Critical Care, SCB Medical College, on the dance number Senorita by Dr. Parimita, Dr. Rahul, Dr. Brahmajyoti, and Dr. Sikta. The third program would bring out the child in every heart sing by a beautiful number, Main Hoon Jum 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 Jumru, by none other than Dr. Anjan Das, cardiac anesthetist, Apollo Hospitals, Bhubaneswar. This program would definitely add the cherry to the cake. It will definitely leave you all spellbound by making you fall in love with her expressions and lyrics of a dance number by none other than our beloved and talented Madam Professor Dr. Nivedita Pani and Dr. Suchitra Das. Be ready to tap to the rhythm on the song E Moro Manasiyasa. The fifth program would for sure make every string of your heartbeat by a beautiful song, Tu Hi Hakikat, presented to you by Dr. Snehashish Mandal, second year PGT, Department of Anesthesia, SCB Medical College, Cuttack. The sixth program is a dance number by Dr. Asuranti Kaura, Associate Professor, SCB Medical College, Cuttack, Kanha Soja Zara, which would leave you all mesmerized by her graceful steps. The seventh program is a beautiful song, Ki Pag Ghungaru Baje, Meera Nachegi, by none other than a talented and multi-talented singer, Dr. Anjan Das, the cardiac anesthetist from Apollo Hospitals, Bhubaneswar. The eighth program is a beautiful mashup dance number, Ure Jab Jab Zulfe Teri, by a second year PGT, Dr. Sikta Suman, who would add colors to this beautiful evening. Last program of the evening would be an all-time favorite song, My Name is Anthony Gonzalez, by none other than Dr. Anjan Das, cardiac anesthetist, Apollo Hospitals, Bhubaneswar. Thank you. Stay tuned with a lovely, vibrant, colorful cultural program. Thank you.
Hello everyone. A warm welcome to all the delegates, all faculties, my colleagues and the organizers. I must thank the organizers for giving me this opportunity to sing on this virtual platform. मधुबन खुशबू देता है, सागर सावन देता है, जीना उसका जीना है, जो औरों को जीवन देता है। मधुबन खुशबू देता है। सूरज ना बन पाए तो बन के दीपक जलता चल, सूरज ना बन पाए तो बन के दीपक जलता चल, फूल मिले या अंगारे सच की राहों पे चलता सच की राहों पे चलता चल, प्यार दिलों को देता है, अश्कों को दामन देता है, जीना उसका जीना है, जो औरों को जीवन देता है, मधुबन खुशबू देता है, सागर सावन देता है, मधुबन खुशबू देता है। चलती है लहरा के पवन की सांस भी की चलती रहे, चलती है लहरा के पवन की सांस भी की चलती रहे, लोगों ने त्याग दिए जीवन कि प्रीत दिलों में पलती रहे, कि प्रीत दिलों में पलती रहे, दिल वो दिल है जो औरों को अपनी धड़कन देता है, जीना उसका जीना है, जो औरों को जीवन देता है, मधुबन खुशबू देता है, सागर सावन देता है, मधुबन खुशबू देता है।
He movido cielo y tierra y no te encontré, y llegas hoy tan de repente, y la he sentido toda mi vida por tu querer.
ना मैं समझा ना मैं जाना जो तुमने मुझसे कहा है सेन्योरिटा, मगर फिर भी न जाने क्यों मुझे सुन के अच्छा लगा है सेन्योरिटा।
No desvíes la mirada, quédate cerca de mí.
मुझको बाहों में तुम घेर लो, समझी ना सेन्योरिटा, चाहत के दो पल भी निभाए, दुनिया में भी खबर है क्या, खबर को बनाए, खुले हम हो खबर है क्या सेन्योरिटा, सुनो सुनो सेन्योरिटा कहते हैं हम क्या।
You Odi diddy odday, odi odday, odi diddy odday, odi odday। मैं हूँ झुम 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 झुमरू पकड़ घूमू बन के घुमरू में ये प्यार का गीत सुनाता चला, मंजिल पे मेरी नजर में दुनिया से बेखबर बीती बातों पे धूल उड़ाता चला। मैं हूँ झुम 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 झुमरू फक्कड़ घूमू बन के घुमरू में ये प्यार का गीत सुनाता चला। मंजिल पे मेरी नजर, मैं दुनिया से बेखबर, बीती बातों पे धूल उड़ाता चला। ओए युडडे पका युका पका, ओए पक्कर मेरे 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 युडडे बगा लुका बगा, ओए युडडे। मैं हूँ झुम 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 झुमरू, पकड़ घूमू बन के घुमरू, साथ में हम सफर न कोई कारवां। भोला भाला सीधा साधा लेकिन दिल का हूँ शहजादा, है मेरी ये जमीन ये मेरा आसमां। ओए युडडे पका युका पका, ओए पक्कर मेरे 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 युडडे बगा लुका बगा, ओए युडडे। हम मैं हूँ झुम 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 झुमरू, फक्कड़ घूमू बन के घुमरू, प्यार सीने में हर किसी के लिए। मुझको प्यारा हर इंसान, दिल वालों पे हूँ कुर्बान, जिंदगी है मेरी जिंदगी के लिए। उड़डे 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 उड़डे। मैं हूँ झुम 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 झुमरू, फक्कड़ घूमू बन के घुमरू, मैं ये प्यार का गीत सुनाता चला। मंजिल पे मेरी नजर, मैं दुनिया से बेखबर, बीती बातों पे धूल उड़ाता चला। अड़ली अड़ली ए उड़ली उड़ली ओ, अड़ली अड़ली ए उड़ली उड़ली ओ, एड़ी उड़ली उड़ली ओ, एड़ी उड़ली उड़ली ओ, ओ अड़ली अड़ली ए उड़ली उड़ली ओ, अड़ली अड़ली ए उड़ली उड़ली ओ।
ମାନସୀ ଆସ ପ୍ରେମ ରାଇ ଯେ ଗଢ଼ିବା ମନ୍ଦିର, ଡେଣ ମେଲି ଉଡ଼ି ଯିବା ପ୍ରେମ ପକ୍ଷୀ ଆମେ ଦୁନିଆର। ଏ ମୋର ମାନସୀ ଆସ ପ୍ରେମ ରାଇ ଯେ ଗଢ଼ିବା ମନ୍ଦିର, ଡେଣ ମେଲି ଉଡ଼ି ଯିବା ପ୍ରେମ ପକ୍ଷୀ ଆମେ ଦୁନିଆର। इल्ले इल्ले अयो अयो अम्मा अम्मा से कथा कहनी आऊ तुम्हें तो खाली जड़ू ना हो, छाती हुए धक 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 देह महेलाणी क्षीण। ए मोर ମାନସୀ ଆସ ପ୍ରେମ ରାଗି ଯେ ଗଢ଼ିବା ମନ୍ଦିର, ଡେଣା ମେଲି उड़ी जीवा प्रेम पक्षी आमे दुनियार प्राण प्रिय सुण मोर मु तुम गभार फूल तुम पद अलता मु अंजन तुम आखिर हे हे प्राण प्रिय सुण मोर मु तुम गभार फूल तुम पद अलता मु अंजन तुम आखिर
तुमे मो गणर हर मम धर मधुमणि भूली बनी प्रिय मोर रहिबी मो चिरऋणी
ए मोर मानसी आस प्रेम जाई जे गढ़िबा मंदिर
तेरा मेली उड़ी जीवा प्रेम पक्षी आमे दुनियार
आहा हा हा हे 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 ओ हो 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 हो
ला 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 ला
हो कब भला अब ये वक्त गुजरे कुछ पता चलता ही नहीं जब से मुझको तू मिला है होश कुछ भी अपना नहीं उफ ये तेरी पलकें घनी सी छाँव इनकी है दिलनशी अब किसे डर धूप का है क्योंकि है ये मुझ पे बिछी तेरे बिना ना सांस लूं तेरे बिना ना मैं जीऊं तेरे बिना ना एक पल भी रह सकूं तू ही हकीकत ख्वाब तो दरिया तू ही प्यास तो तू ही दिल की बेकरारी तू सुकून जाऊँ मैं अब जब जिस जगह पाऊँ मैं तुझको उस जगह साथ हो के ना हो तू है रूबरू तू हम सफर तू हम कदम तू हम नवा मेरा तू हम सफर तू हम कदम तू हम नवा मेरा
हे बुजुर्गों ने फरमाया के पैरों पे अपने खड़े होके दिखलाओ, फिर ये जमाना तुम्हारा है। जमाने के सुर ताल के साथ चलते चले जाओ, फिर हर तराना तुम्हारा, फसाना तुम्हारा है। अरे तो लो भैया हम अपने पैरों के ऊपर खड़े हो गए और मिला ली है ताल, दबा लेगा दांतों तले उंगलियां लिया, ये जहां देख कर अपनी चाल। के पग घुंघरू के पग घुंघरू बांध मीरा नाची थी, के पग घुंघरू बांध मीरा नाची थी, और हम नाचे बिन घुंघरू के पग घुंघरू बांध मीरा नाची थी। वो तीर भला किस काम का है जो तीर निशाने से चूके रे, के पग घुंघरू पग घुंघरू बांधे मीरा नाची थी, पग घुंघरू बांधे मीरा नाची थी। हाँ, के पग घुंघरू बांध मीरा नाची थी। सा 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 ग ग रे रे सा नि 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 सा सा सा, सा 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 ग ग रे रे सा नि 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 सा सा सा, ग ग ग प प म म ग रे 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 ग ग ग, पानी सा मा पानी रे 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 ग रे ग रे ग रे ग रे ग प प प प प म ग रे सा नि सा सा नि सा 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 प म प म ग म ग म ग म सा रे सा रे सा रे सा रे रे ग रे ग रे ग म ग म ग म प म ग रे सा नि सा 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 प म ग रे सा नि सा 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 प म ग रे सा नि सा सा सा। आप अंदर से कुछ और बाहर से कुछ और नजर आते हैं, वाह खुदा शक्ल से तो चोर नजर आते हैं। उम्र गुजरी है सारी चोरी में, सारे सुख चैन बंद जुल्म की तिजोरी में। आपका तो लगता है बस यही सपना, राम नाम जपना पराया माल अपना। आपका तो लगता है बस यही सपना, राम नाम जपना पराया माल अपना। वतन का खाया नमक तो नमक हलाल बनो, फर्ज ईमान की जिंदा यहाँ मिसाल बनो। पराया धन पराई नार पे नजर मत डालो, बुरी आदत है ये आदत अभी बदल डालो, क्योंकि ये आदत तो वो आग है जो एक दिन अपना घर फूके रे, के पग घुंघरू पग घुंघरू बांधे मीरा नाची थी, पग घुंघरू बांधे मीरा नाची थी। हाँ, के पग घुंघरू बांध मीरा नाची थी।
झूला लिटिला लिटि लिटिला झूला लिटिला लिटि लिटिला मौसम इश्क में मचले हुए अरमान है हम, दिल को लगता है कि दो जिस्म एक जान है हम, ऐसा लगता है तो लगने में कुछ बुराई नहीं, दिल ये कहता है आप अपनी है पराई नहीं, संगे मरमर के हाय कोई मूरत हो तुम, बड़ी दिलकश बड़ी खूबसूरत हो तुम, दिल दिल से मिलने का कोई मुहूर्त हो, प्यासे दिलों की जरूरत हो तुम, दिल चीर के दिखला दूं मैं दिल में यही सूरत हसी, क्या आपको लगता नहीं हम हैं मिले पहले कहीं, क्या देश है क्या जात है क्या उम्र है क्या नाम है, अरे छोड़िए इन बातों से हमको भला क्या काम है। और जी सुनिए तो हम आप मिले तो फिर हो शुरू अफसाने लैला मजनू के पग घुंघरू बांध मीरा नाची थी, और हम नाचे बिन घुंघरू के पग घुंघरू बांध मीरा नाची थी, के पग घुंघरू बांध मीरा नाची थी, के पग घुंघरू बांध मीरा नाची थी।
नजर फिसले जिंद मेरी